So to start off, I'm going to introduce a former fellow of ours last year, a friend of mine, Asra Tubaye, and she's going to present on drivers of junctional failure in cement augmented thoracolumbar posterior fusion constructs. It's one of our studies, so thanks for doing this.
Okay. Good morning. I have no financial disclosures, relationships to disclose. By now we all know that PJF is a significant complication after adult spine deformity surgery, and cement augmentation at UIV, UIV plus 1 or both is commonly used to mitigate this risk. We still don't know the full impact of the surgical construct configuration and alignment on PJF risk in this population. The purpose of this study was to identify perioperative radiographic and construct-related factors associated with PJF in patients undergoing thoracolumbar posterior fusions with cement augmentation at UIV, UIV plus 1. This was a retrospective review of adult patients that underwent thoracolumbar to pelvis posterior fusion. All constructs included cement augmentation at UIV and UIV plus 1. We identified patients with PJF versus no PJF at 6 month or 1 year follow-up. Then we compared demographic, surgical, pre-op, and post-op radiographic variables between the two groups. Overall, we included 85 patients in this study. 12 of them developed PJF, and half of these patients required revision surgery. There was no difference in age, gender, or BMI. There was also no difference in cement level, rod material, UIV level, pre-op and post-op global alignment parameters. In terms of the surgical construct configuration, PJF groups had significantly higher number of rods, more number of pelvic screws, and shorter accessory rod distance to UIV, all emphasizing the fact that excessive construct stiffness can increase stress at the upper junction and predispose the construct to mechanical failure. In terms of alignment, the PJF group showed greater postoperative thoracic kyphosis and greater increase in thoracic kyphosis from baseline, pointing to the fact that greater change in thoracic kyphosis or greater correction of thoracic kyphosis can increase proximal junctional stress and mechanical failure. The majority of our patients had T4L1 PA mismatch outside the target range. Most of them were in the non-PJF group, indicating that potentially UIV plus 1 cement augmentation could be protective in malaligned patients. After running the multiple regression analysis, independent predictors of PJF were post-op thoracic kyphosis, change in thoracic kyphosis, accessory rod distance to UIV, and number of pelvic screws. In conclusion, PJF is multifactorial. Stiffer constructs and greater thoracic kyphosis increase risk of junctional stress and mechanical failure in this group. And cement augmentation at UIV, UIV plus 1 may offer protection despite sagittal malalignment. Thank you.
Thank you, Oscar. That was great. So yeah, hanging out us here, we'll do some questions after the first group. Our next speaker is going to be Zach Rowe, who's going to be talking about upper thoracic versus lower thoracic UIV in adult spinal
Hello, everyone. My name is Zachary Brum, and I'll be presenting upper thoracic versus lower thoracic UIV in adult spinal deformity patients with a low pelvic incidence, risk factors for revision operations for proximal junctional failure kyphosis. No disclosures. By way of background, pelvic incidence, the pelvic orientation, determines thoracolumbar shape. Rizzulli classification describes various thoracolumbar spinal shapes as described by pelvic orientation. And on the figure on the right, you can see the 4 types, with type 1 and type 2 having a sacral slope less than 35 degrees, type 3 between 35 to 45, and type 4 between greater than 45 degrees. With the difference between type 1 and type 2, you look at the rotator tilt angle apex within L5, it is type 1, and within L4, it's type 2. Patients with a low pelvic incidence correspond to Razuli type 1, and these patients have a very unique shape with over 75% of lumbar lordosis concentrated between L4 and S1, resulting in very sweeping long hyperthoracic kyphosis. The figure on the top right demonstrates SL distribution according to pelvic incidence by Razuli type, and what we can see here is that Razuli type 1, indicated by the black dots, have a very high SL ratio and low pelvic incidence, meaning that they have a very high proportion of the lumbar lordosis concentrated in a distal lumbar segment. The figure below it demonstrates a very strong inverse relationship between pelvic incidence and SL ratio. In these patients, it's very difficult to restore appropriate spinal shape, increasing the risk of PJK. Therefore, our question is, does UIV for thoracolumbar instrumented fusions to the pelvis dictate PJK rates in low PI patients? The purpose of this study was to evaluate rates of PJK and associated revisions in low PI patients, comparing upper thoracic UIV to lower thoracic UIV levels. In terms of methods, this was a single center retrospective review of low PI patients who underwent thoracolumbar instrumented fusions to the pelvis for ASD. We had our low PI patient cohort and divided them into a lower thoracic UIV termed LT with a UIV between T8 and L1, and an upper thoracic UIV termed UT with a UIV between T1 and T7. Clinical, demographic, and radiographic data were collected. The primary outcome was revision surgery for PJK with multivariate logistic regression used to identify independent predictors within each group. Overall, the cohorts were very similar, the UT and LT groups. However, the LT group did have a higher rate of vertebroplasty and greater proportion of females. There were similar rates of PJK and revision operations to address PJK in both groups. We first looked at the univariate predictors of revision due to PJK, and what we found was that in the LT group, univariate predictors of revision due to PJK included lower preoperative PI-LL mismatch, greater postoperative T4-L1-PA, greater postoperative T4-T12 kyphosis, greater postoperative PT, and a smaller operative reduction in both PT and T4-PA. In the UT group, no univariate predictors were identified, and UIV level itself was not associated with revision due to PJK. We then performed a multivariate analysis for predictors of revision due to PJK, and in the LT group, we found that preoperative PI-L mismatch being lower, greater postoperative T4-L1-PA, greater postoperative PT, and a more negative operative change in PI-L mismatch were associated with revision due to PJK. In conclusion, the PJK rate around 35% and the revision rate between 12 to 14% were similar between the upper thoracic and lower thoracic UIV levels. Sagittal malalignment parameters, specifically increased PT, increased T4, T12 kyphosis, and increased T401PA, predicts PJK and revisions only in LT constructs. Therefore, stopping at a UT UIV may better control reciprocal thoracic kyphosis and lower PJK rates in low PI patients. When using an LT UIV, minimizing postoperative malalignment, T4L1PA, is key to preventing junctional failure. Thank you.
Zach, that was great. Our next talk is going to be Peruz Faraduni, who's going to tell us about preoperative teriparatide usage.
Hi, everyone. Today I'll be discussing perioperative teriparatide versus bisphosphonate usage in osteoporotic patients using a national database. I have no disclosures. So the preoperative risk of undergoing osteoporotic patients undergoing fusion surgery has been documented, and we wanted to evaluate the benefits and analysis of whether teriparatide had any advantages over bisphosphonates in those patients. Currently, the literature suggests that there's minimal studies comparing the two. Most of the studies done currently on this topic are comparing bisphosphonates and teriparatides versus control, or are only in single site studies with low N numbers. This was the first time we were conducting a national database query to address this issue. So the question that we asked was to compare the outcomes in osteoporotic patients using teriparatide versus bisphosphonates usage within 1 year before fusion surgery. For methods, we queried the national database Pearl Diver from the years of 2010 to 2023 Inclusion criteria included fusion surgeries with the CPT codes listed above, who had ICD-10 codes for osteoporosis as indicated, and baseline demographics and comorbidities were compared, and complication rates between 90 days as well as up to 10 years were compared using two-sided statistical analysis. Baseline analysis, the cohorts were pretty similar. Teriparatide cohort tended to be a little bit older than bisphosphonates, but beside that, no significant difference was found within the comorbidities of the two groups. In the univariate analysis, within 90-day outcomes, there was only a few differences. The pneumonia rates were significantly lower in the teriparatide cohort. Wound infection rates between 2 to 5 years were statistically significantly lower in the bisphosphonate group. Non-significant trends favored teriparatide, namely acute kidney injury, deep vein thrombosis, risk of transfusion requirement, as well as development of UTIs. In conclusion, first, I wanted to just address the limitations of the study. This is a retrospective study, so causation can't be assessed. And there was also a small sample size for teriparatide of only 92. In conclusion, there was slight superiority in perioperative outcomes for teriparatide. The baseline characteristics were similar enough to make some comparisons, except for age. And there were some non-significant and some significant outcomes that favored teriparatide, but overall, it seems that both medications are effective in promoting bone promotion before a fusion surgery. For next steps, we would want to conduct a multivariate regression to make sure to address for confounding variables. Thank you.
We'll open it up for a couple of minutes of questions. Any questions from the audience for our speakers?
Asra, thank you very much for your paper. I saw thoracic kyphosis, but how about thoracolumbar kyphosis? Preoperative thoracolumbar kyphosis, was that part of your study? Because I think when you stop at the thoracolumbar junction with thoracolumbar kyphosis, there's always a little bit of a greater risk.
It was, and there was a significant difference, T10 to T12.
Okay, great.
Yeah.
Yeah, so on that same paper, said it that way. What was the mechanism of failure in the patients who had cement? So the rate of failure was similar, but did you see any difference in mechanism? Meaning, was it a fracture of the UIV +1, or is it more of a subluxation problem, which is less characteristic of the lower thoracic spine?
I defined it as fractures, and looked at it as fractures. They all had fractures. I had UIV or +1, but the non-PJF group had one of them only had fracture UIV +2. Oh, sorry. Yeah. So yes, there was fracture.
I can speak up. It's for the second speaker. You talked about lower thoracic versus upper thoracic endpoints in more than one patients. With the lower thoracic endpoint, what was the UIV? Because often with those patients, you're into the lower thoracic spine, getting awfully close to the apex of kyphosis.
It was between T8 and L1 for the UIV for that cohort.
That's a big spread. Okay. Any thoughts of stopping a little bit lower than L2 on type 1?
I mean, yeah, that's a very good point, and something that we could definitely look at in terms of the sub-analysis to tighten that range.
I don't want you guys falling asleep. So for the second paper, I think it's a great idea, but I'm almost more interested in the high PI people. Because the high PI people are the ones that I think get into more trouble because either we don't get the low lumbar lordosis to mimic or to counteract their PI. So, have you studied that population? If you haven't, I would recommend looking at lower thoracic versus upper thoracic in that high PI people. And I think, like Mike Kelly said, it's a spectrum. So just make it more than 50 or whatever, and not a Russley classification. But I wanted to know from you, like you said, like the first paper said that T4L1 didn't really matter in her case, but you said if you go lower thoracic, you better pay attention to T4L1. So can you guys duke it out and tell me what's the truth?
I mean, want to go first?
So I looked at PJF and you looked at PJK.
Yeah.
And you had cement augmentation, right, in your study of UAV and UAV plus one?
Mm-hmm.
So I know that, so patients could still develop PJK, but not necessarily PJF in presence of cement augmentation if they're malaligned. That's what I'm getting out of this.
I mean, in terms of our study, looking at the LT group, T401PA did emerge in the multivariate analysis as like the most predictive variable for that group. And we were looking at for revision surgery for PJK. So, yeah.
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 And I was looking at the PJF.
Correct. Yeah. Yeah.
Yeah, complicated topic. There were differences in the type of cement that was done between the two groups and the other prophylactic strategies at the proximal junction. So I think there may be some differences in surgical strategies. And the first paper were all comers, different PIs, where the second one was more focused. So I think that's a good question of whether the T4 L1 PA access is applicable to everybody, or if it's more focused on one type of PI patient or not. All right, thank you guys. Come on down. So our next study will be given by Ryan Wong, and I was introduced to Ryan by one of our other fellows, Austin Katz, and this is the first time I'm meeting him in person. So he's done a lot of great work. He's going to present on long-term revision rates for posterior-only operations for pediatric and young adult deformities and national database analysis.
Yeah, thanks for having me, Dr. Theologis. My name is Ryan, and I actually think the slides might be switched. Sorry. Yeah, but I'll be first presenting today on a national database study looking at longitudinal reoperation rates, mainly for adolescent spinal deformities. So thanks for having me today. Next slide. Yeah, so I have no disclosures. And then for a bit of background, so particularly for adolescent deformities, for example, there's like adolescent idiopathic scoliosis. Generally, the standard of care is doing a posterior spinal fusion. And even though this is like a relatively not too well-studied field, so there's pretty limited literature looking at longitudinal reoperation rates and medical outcomes in this population. So basically, we were basically wanting to look at, with a national database, just these longitudinal outcomes and just basically classifying the outcomes after PSF in these patients. So in terms of the methods, we utilize the Pearl Diver Mariner database. So that's just a large insurance claims database. And this sort of allowed us to use a larger patient sample that previous studies looking at pediatric or adolescent deformities haven't been able to. So particularly, we looked at data from 2010 to 2023, and then we were looking at patients aged from 10 to 25, and then our exclusion criteria was basically patients who had any anterior fusion or just a previous history of thoracic vertebral fracture. Primary outcomes we were looking at in our cohort was just 90-day medical complications, so like acute kidney injury, blood transfusions post-operatively, and then sort of the primary outcome of our study was looking at longitudinal reoperation. So we basically looked at less than 1 year, 1 to 2 years, 2 to 5 years, and 5 to 10 years. And basically, we just wanted to sort of classify the success of these procedures longitudinally. I do want to clarify that this is a descriptive study because we just didn't have a comparison group, but since it hasn't been too well studied, we just wanted to make sure we could classify these outcomes. So it's just a descriptive study. So in terms of the patient sample, so there were 2,457 patients aged 10 to 25 who were undergoing posterior fusion for spinal deformity. The average age was 14.3. The comorbidities were like relatively low in this cohort. There wasn't a comparison per se, but this is just the characterization of our cohort for this study. Regarding the complications and longitudinal outcomes, so within 90 days, the medical complications were relatively limited. The most significant one was pneumonia with a 9.3% occurrence. The remaining medical complications within 90 days were relatively limited. Looking at the wound infection and reoperation rates, within 1 year of surgery, it was an 8.1% reoperation rate. Notably, after that, looking at sort of longer term outcomes till 10 years, that if patients were able to make it past the first year, that the reoperation rate did decrease pretty significantly down to like 3% and then 2 and less than 1%. So mostly if the patients were making it past the first year, outcomes were pretty successful. Another thing that we looked at in our study were reasons for reoperation. So among these patients and why they were being taken back to the OR, we looked at, fusion, osteotomy, implant removal, device reinsertion. Based off what we found, the primary indications for reoperation among these patients was generally implant removal and device reinsertion. So that kind of just gives us an idea of why these patients are being taken back to the OR. In terms of conclusions, this descriptive study just characterizes the medical complications and then the longitudinal reoperation rates after posterior fusion for adolescent spinal deformity. For the most part, the complications and reoperation rates were in line with other spine surgery with less than 10% within 1 year. And then, that would lower longitudinally to 10 years. And then in terms of future plans for what we're hoping to do, we're also going to do a sub-analysis looking at specifically patients with AIS versus without AIS, sort of seeing if there's a risk factor for outcomes in those patients. Thank you.
Thank you, Ryan. The second study will be given by Peruz Ferranduni, minimally invasive versus open SI joint fusions, complications, and reoperation rates in a national database analysis.
Hello again. So if it seems like a lot of our methods are very similar, Ryan and I are actually roommates. He's a great mentor of mine. So just wanted to, I guess if that's a disclosure that I need to make, I just made that. So this, as Dr. Theologis just mentioned, this is a comparison for patients undergoing sacroiliac fusion with a minimally invasive approach versus an open approach. And again, this is a national database analysis. So sacroiliac joint pain roughly accounts for 15 to 30% of low back pain, and according to some studies, has been shown to be very underdiagnosed. As a result, there has been a uptick into the usage of sacroiliac fusion as a means to address that. To date, there's been no clear conclusion reached comparing the efficacy of minimally invasive versus open approaches. According to my literature review, I was only able to find one comparison, and that was in a single site, or it was a multi-center study, but there was only about 200 patients compared. So we wanted to broaden our view of this into a national database and ask the question of what outcomes differences are there between minimally invasive approach versus open SI fusion. We queried the Pearl Diver National Database to include patients, adult patients defined as age of greater than 18, and those who have undergone SI fusion codes. The codes for 27280, I believe, is for open surgery versus 7.9, which is for minimally invasive, and baseline demographics and comorbidities were compared using as well as the complications between 90 days and 10 years post-operatively using two-sided statistical comparisons. For baseline comparisons, there were some significant differences. The MMI group tended to be older, but had better comorbidities, anemia, COPD, cancer, chronic kidney disease, pulmonary disease, CHF, coronary artery disease, hypertension rates were lower in MMI. The only notable distinction from the trend was that obesity rates were higher in the MMI group. And for complications and outcomes, AKI, deep vein thrombosis, hematoma, pneumonia, pulmonary edema, blood transfusion rates were lower in MMI compared to only UTI being lower in open fusion, and reoperation and wound infection rates within 1 year, as well as wound infection rates within 5 to 10 years were lower in minimally invasive approach. Limitations, again, given the retrospective design of the study, no causation can be established. Given the conclusions, with the big caveat that the cohorts were significantly different in some regards, with that caveat, MMI seems to favor lower early complication rates as well as lower reoperation and wound infection rates on the long term. These findings support the potential safety advantages for a minimally invasive approach, underscoring the need to interpret the results further. For next steps, and these are big ones that we're undertaking currently, is to do multivariate regression and propensity score matching to kind of compare the cohorts more similarly and adjust for co-founders. This is just a slide that I put in from the manuscript that is coming up about the trends of SI fusion over the past 13 years. So as you can see, there's been a significant uptake. The 2023 data is erroneous because only the first quarter was included, but the trend still exists. Thank you.
Great. Our third talk will be given by Timothy Kim. Title of the presentation is Leveraging Personalized Interbody Implants for the Minimally Invasive Treatment of Adult Degenerative Scoliosis.
Great. Good morning. Thank you for having me. I'm at PGY4 at UCSD in the neurosurgery department. So I don't have any particular disclosures. So for background, as we've learned this weekend, adult spinal deformity correction, very challenging, and there's lots of complications. There's major surgery and implant adverse effects we see, and even the revision rate can be quite high. And part of the way that you're trying to tackle that challenge is trying to personalize deformity correction for that patient. And so what are the tools we can use to do that? You have robotics, we have patient-specific rods, and then, for the purposes of this talk, personalized 3D printed interbody cages. So here's just kind of a picture of what that looks like. You take the CT scan preoperatively, and you're able to essentially get a 3D rendering of the implant that you want for that specific level, and you can get the different measurements as you see over here. You can see in the sagittal plane what it would look like preoperatively, and then what it looks like corrected with these different inner bodies at every level. So you can see in the sagittal plane, and then you can even get really good coronal correction too with these inner bodies. There's been a couple papers so far, mainly in open deformities, showing some preliminary evidence of the safety and also just efficacy of these personalized inner bodies, and showing that when it comes to radiographically, they're able to reach these goal alignment parameters better than relative to the stock inner bodies. So this was just a single surgeon retrospective case series of consecutive patients with adult degenerative scoliosis who underwent minimally invasive reconstruction with personalized inner bodies for correction. So there's 12 patients. They underwent, stage 1 was an O-lift/lateral A-lift, and then the second stage was robot-assisted, minimally invasive placement of posterior instrumentation with multiple rod constructs. So this is kind of what it looks like preoperatively when you're designing it. As I said, you take the CT preoperatively with the thin cut slices. You're able to disarticulate each vertebral or each body or the segment, and then based off of whatever parameters, you can work with the engineers to meet whatever lordosis you want at that level. You can look at the coronal angle, things like that. So this is kind of what it looks like for the first stage for when we do the O-lift/lateral A-lift. Most of these patients got L1 to pelvis, so that bottom incision is for the lateral A-lift or 5-1, and then that other incision more laterally is used for the rest of the inner bodies. Then we get an interstage X-ray after stage 1. You can see that already with the inner bodies, we're getting good coronal correction. And then we get a planning CT for just planning the posterior instrumentation that we will do robot assisted and make sure that the screws are all aligned well and that the rods will fit. And this is kind of what it looks like in the posterior doing transfascial pedicle screw placement with the robot. Some results. So levels, it was average of 10 levels, 5 cages, and about 3 points of fixation for to the ilium as well as rods. And then operative time about 3:30 for the stage 1 and 3:80 for stage 2. So in terms of the radiographic parameters, we got scoliosis correction to about only 7 degrees postoperatively, then 38 degrees for L4 to S1 lordosis, about 2 degrees for PIL mismatch, 3 degrees for L1PA from target, and then the post-op, the mismatch of T4 L1PA about 4 degrees, and about no complications related to the inner bodies. So here are just some of the preoperative and post-op kind of standing x-rays and using these inner bodies and this kind of technique. And then here's some lateral standing x-rays, and you can see you get good sagittal correction as well. So in conclusion, personalized inner bodies show promise in achieving radiographic correction of degenerative scolia and minimally invasive reconstruction. Obviously, there's limitations in this: single surgeon, small series, limited follow-up and clinical analysis, and no comparison group. But the future direction is trying to compare it with some of our previous data with using the stock inner body spacers. I would like to do a multi-center study with these inner bodies, and then also evaluation of the proms. And as we've learned this weekend, some of the mechanical failures can take 5 to 10 years. So being able to have that follow-up would be helpful. And that's it. Thank you.
Hey, last talk, Ryan. Title of this presentation is a comparison of longitudinal reoperation rates up to 10 years in multi-level thoracolumbar posterior instrumented fusions with and without concurrent anterior lumbar interbody fusions for adult spinal deformity.
Yeah, thanks for the intro. Ryan again, and then as he mentioned, I'll be going over a national database study comparing outcomes for adult spinal deformity with posterior fusion and then with and without concurrent anterior lumbar interbody fusion. Once again, no disclosures. So for a bit of background, the current sort of gold standard for treating ASD is posterior spinal fusion. Something that hasn't been too well studied though is sort of the concurrent use of A-lift to augment the construct. There have been some limited pilot studies, but generally with a pretty small sample size that may sort of support that, A-lift is good at reducing reoperation rates and sort of stabilizing the construct, but there isn't really any large-scale data that supports those findings. So sort of what we were trying to do here is use this large national scale database to sort of validate the efficacy of using A-lift to bolster PSF for adult spinal deformity. So yeah, that's our objective. And then in terms of methods, once again, using the Pearl Diver Mariner database. For this study, our inclusion criteria was patients with adult spinal deformity, undergoing fusion, and then also older than 50 years. Exclusion criteria was prior history of thoracic vertebral fractures. And then similar to the first study, primary outcomes were looking at 90-day medical complications and then longitudinal wound infection and reoperation rates, and similar time points, less than 1 year, 1 to 2 years, 2 to 5 years, and 5 to 10 years. So this sort of helps to characterize the sort of long-term success with A-lift and whether it's beneficial. So in terms of the baseline characteristics, so the patients that were undergoing concurrent A-lift were older than those those without concurrent ALIF were older than those with ALIF by 2 years. Statistically significant, but a relatively small difference. And then as far as the comorbidities, relatively similar comorbidity profile. There's a greater rate of depression in the ALIF cohort, 58% compared to 52%, but otherwise the comorbidities were comparable. As far as the univariate analysis, there were actually no shown differences between 90-day medical complications and longitudinal reoperation rates. That was a univariate analysis. And the multivariate analysis actually showed that ALIF was associated with lower rates of reoperation at 2 to 5 years, approaching significance, and then also lower at 5 to 10 years. And it was actually like about 1/3 at the rate at 5 to 10 years. And then as far as medical complications, ALIF was associated with increased rate for acute kidney injury at 90 days, but no other medical complications otherwise. So in conclusion, it does appear that concurrent ALIF done for ASD does have some benefits for sort of longitudinal stability of the construct, reducing reoperation rates. But on the flip side, there are additional risks associated with the additional surgery. So keeping in mind sort of the additional medical complications that might be incurred. As far as limitations, similar national database, not really as granular, but definitely good for informing sort of large-scale data for these procedures. Thank you.
We'll open the floor to questions.
Thank you, gentlemen, for all your hard work. It's really great to see. Question for the paper on the personalized interbodies. Manish and I were talking, a lot of your interbodies are at upper lumbar levels. I even saw one, I think at L1-2 and L2-3 on one of your x-rays or one of your films there. What is the reason to put interbodies at those levels from your perspective?
Yeah, I think my understanding is part of it is helping with the coronal correction at that area.
Okay, I just want to highlight a point that Manish made yesterday, which is, that when you fill the interbody space at these upper lumbar levels, you block your correction capability because you basically overstuff the disc space and it doesn't move, right? And I think that I went through this for about 10 years myself, putting interbodies at those levels, and then I realized, it's not really absolutely necessary. So it's just a question. The second question really is, I haven't gone down the personalized interbody road yet, even though people have been pushing me to do that. From your perspective, is there a certain lumbar level where it's most beneficial?
I have very limited experience with this, but I would say, that 5-1 level I found very helpful. We use it in both ALIFs, supine ALIFs, standard ALIFs, and the lateral ALIFs. And I've done them without using the interbodies I guess some of it's also with the surgeon I'm working with, but I found them much easier, and the kind of correction you can get and the lordosis restoration is pretty good at that 5-1 at the bottom level.
I was actually expecting a question about cost, just like for yesterday. The interbodies, the interbodies up at L1-2, 2-3, mostly because all of those were circumferential MIS. So there's nothing opened in the back. So pretty much from L1 to S1, the patient is relying on the interbodies for fusion. All right, so everything else above that, there's some data that shows out of the Japanese literature, they actually don't decorticate the facets at all. I'll still decorticate facets. And I know Mike Wang used to put BMP, some people put chips, some people just drill. But for every one of those cases in the cohort, they were circumferential. So it's just screws through the fascia, and there's only bone graft I can put through the transfascial incisions. But otherwise, they're relying entirely on the interbodies for fusion. So that's the reasons to go essentially as high as I can.
And do you do that all the same day?
It's staged. So laterals are 1 day. So lateral to cubitus is stage 1. So L1 to 5, OLIF, 5-1 lateral ALIF. And then I rest them a day to get the CT. And then the posterior is a second stage. I used to do it in 1 day. As some of the maybe older residents will remember, it's just a very long day. So now, I think like many people who do MIS, I just stage them.
What would you say is your average length of stay for, complete MIS procedure?
Yeah, the promise of MIS is that they get out of the hospital sooner. I'll stay in honesty, it's not always the case. I've had someone leave the hospital on the 3rd day after stage 2. So it was a Friday end for stage 2, and they left on Monday. I've also had people leave and stay like an entire week. And it's mostly just for muscular recovery. Again, for MIS, I do operate on people who are a bit sicker. So I operate on people who are BMI 40, 41, 42. I operate on folks who are, say, 76, 77, because I'm more comfortable with the operative complication risk, which is lower. And so sometimes I think my length of stay, as much as people can get up on the podium and say it's faster, I think it averages about the same. But I think, overall, the ability, though, is to potentially operate on people who are a bit more frail or less candidates for open surgery.
Very nice study and great correction. Question about how you would do a single stage with the use of the robot. My understanding is that if you do the inner bodies, you need to get another planning CT to plan the screws. How do you do it on the same day?
So, that was always the recommendation from any of the robot manufacturers. They always recommend that you get a CT. I will say that some systems are better at capturing the vertebral body, even if there's something in between. So for the first 5 or 6 cases, I would do inner bodies. They'd be titanium. And then, of course, the pre-op CT captures a pre-op of the spine. So when we flip them prone, it would be more difficult, but they would still capture it. So, our rep, I know he had to leave, Carlos Rivera. He's been with me since 2019 when we got the robot. We started doing this in probably 2020 late. And it's a very technical thing. You have to get certain x-rays at a certain angle. So it's beyond what the companies teach you. But it is possible. So it tells you the capabilities of the system where we were still able to do it. The limitation wasn't the robot. It was just like my own fatigue by the end of the day. But even with titanium inner bodies that block multiple end plates, it took a little bit of changing the C-arm because I would do a CT to fluoro. We were still able to capture it. And it was still doable, which tells you kind of the advancements of the robotic systems now for registration.
The X-rays are so beautiful, and I love the way you contoured the rod up top for the lower thoracic spine. My question to you is, there must be some selection in your mind how you choose between MIS, right? Age, the levels, because I believe that staging is not only beneficial for fatigue of the surgeon, but also for the patients. They get extubated and they come back, they get extubated again. Sometimes when you do it all day, it's a long day, they try to keep them intubated, which is hell for the patient, right? More complications. So what is your selection criteria on who you choose to do this? And, do you do something else for the other ones with like worse deformity? Do you study them with CTs, look at what is your algorithm? Because I think that's important for the audience to know.
I think naturally it's all of this, hopefully, as many of the people in the room will see, it's just tools in your toolbox, right? I trained, like Joe and many of the others in the audience, I trained with Larry, for apprenticeship for a year in open surgery as a gold standard. So I think, my goals and selection criteria, if they've had prior fusion, prior surgery, if it's a large deformity, it's, you can't bend the tool of MIS to achieve correction, and that's still going to be the ultimate goal. So many of these are moderate deformities. I think the most Cobb angle I've done in the thoracolumbar spine for a degen scoli is maybe 55, right? And so anything more than that, or if it starts to get into a thoracolumbar spine or higher, it's just not going to be an MIS surgery. If they've had prior instrumentation, like one of the cases, I don't think a part of the slide deck that we had presented at home, it was a lady with a 3-to-1, and she's very flat. So that was someone I did a PSO on. But at least with all of these technologies, it was ACRs and a PSO below that, and it was a mini open. right? So there are certain things that you can still reduce risk, and it's a blend here. But ultimately, in terms of correction, it's just what alignment I think I can get. If it's not 5 interbodies, it's going to be a PSO, or it's going to be an ACR, it's going to be a combination of all of those.
Martin, I'll give you a little break. It is interesting, though, to think about learning from other people's workflow, because I can't think of a time where I've actually staged a front and back 10-to-1. So it's just sort of interesting to think of what makes that so exhausting. But let me go to a couple of questions about the large database studies. The first one on AIS, patients aged 10 to 25, and the revision surgery reason. Were you able to really get that out of a large data set in terms of, you talked about implant removal as well as re-instrumentation. Well, did that tend to be extension of the fusion cephalad or cauda? Did it tend to be implant removal for pain? Or what was the reason for the reoperations?
Yeah, so one of the limitations of the database and sort of how we got the data for the reoperations, so we basically, the way we coded it is that we were asking the database, like when, if there was a procedure done within a given amount of time, and then we were able to see like which CPT codes were done for it. But because it's basically coded in like ICD-10 codes, it wasn't really feasible to figure out the reason for that. So to answer your question, yeah, we weren't really able to granulate that in terms of the diagnosis for the reason, but we were able to figure out, like which CPT codes were performed for the reoperation.
And that's probably a limitation that's difficult.
Yeah,
to
one of the
overcome.
big limitations. Yeah.
And in Perez, with regard to your study, specifically, now you're going to have to remind me, the SI joint. Yeah, thank you. No, the ALIF. You did the ALIF one as well, right? All right. Well, let me get to the ALIF one. Probably the same question is in terms of the ALIF. Were you able to show why that might have been protective in terms of revision surgery? Was it pseudoarthrosis rates? Did it have to do with better alignment of the spine, or why was that relatively protective?
Yeah, I mean, I think, as far as the database limitations, we weren't really able to figure out the specific reason. I think biomechanically, sort of what I've seen in like previous literature is that, the ALIF is meant to augment sort of the stability of the construct. But it is difficult from like a national database standpoint to figure out if that's precisely the reason why. So I think that in terms of future studies, looking at specifically why it stabilizes it would be beneficial. But as far as like the limitations of the database, it's difficult to know.
Let me ask one for Perez. So specifically with the SI joint, differences between open and MIS, was more likely S2AI screws versus iliac screws, or was there a difference in a number of screws between those two techniques?
Similarly to Ryan's answer, so the main coding was also through the CPT codes, so the granulation also isn't included. The main outcomes that were considered were the ones in the second table that I showed, the AKI, the transfusions, all of those. But as for the granulation of like which levels, we don't have that data, unfortunately.
All right. Well, thank you, everybody. Thanks, guys. And also thank you to the audience. I really appreciate everybody showing up to support our students, residents, and fellows. I think let's maybe take a 10-minute break, top off the coffee, splash some cold water on our faces, and then I'll come back. It's going to be a really exciting session right after this.
Okay, let's take a seat. We're going to start our next session. And this session I'm probably most excited about. I think there's a lot of topics here that everyone wants to know about, and we made a formal part to the agenda so that we could talk about essentially patient optimization preoperatively. So the first talk will be given by Corey Walker, and he'll be talking about the challenges of the aging spine, frailty, osteoporosis, and sarcopenia. Oh, shoot, you're moderating.
Thank you so much for having me. I really appreciate it. And This is my first year attending this meeting. It's been really nice. So this is a real honor and something that I'm really kind of passionate about, and I think that is going to set the stage for all the great talks that are to follow. And we're really going to be talking about how do we assess these patients who are getting older and older and older in our clinics, and deciding whether they're good surgical candidates or not. Here are my disclosures. So we heard all day yesterday all the amazing talks about things that we do in the operating room that will change the trajectory of our patients' outcomes, tethers, getting the alignment right, spinal pelvic fixation, et cetera. But there's so many things that we don't have control over. And, we had a great talk yesterday about PJK from Mike, and it was just like, you look at all the things that we've implemented and tried to do, we really haven't been able to move the needle a lot. And I think a lot of that is our assessment of these intrinsic patient factors that we don't have control over, or we do have control over, but we're not doing anything with. So one of the things that's come up time and time again and has grown in all of medicine, but particular in our spine literature, is this concept of frailty. And I think it gets thrown a lot around, and so I'm going to kind of discuss this a little bit because I think the idea of frailty is, in our world, your patient's tolerance for this immense trauma that you impose on them doing an operation. But frailty in other categories really is a phenotype, and was described early on to describe older patients in nursing homes who were, at risk of death and loss of health span and all these things, and kind of composed of these 5 core elements. And then this guy, Rockwood, who's a gerontologist, described this concept of trying to quantify frailty. And he did something really brilliant. And he figured out that if you could basically count the number of patient health factors, and if you have enough that you take into account, it doesn't really matter what they are, the relative number of those health factors is strongly correlated to a quantifiable amount of frailty. And so this was called the deficit accumulation model. And this really served as the birth of a huge field of frailty indices that therein became super popular across all areas of medicine. And in our own deformity world, Chris Ames and the ISSG, and actually UCSF's own kind of product here was this adult spine deformity frailty index, which used this exact accumulation model concept, but with spine-specific things, as you can see here on the left. And basically, you just count these. There's no weighting to this. It's just you count the number of deficits that the patient has, and this strongly correlated to clinical outcomes that they looked at, which were pertinent to our patients, PJK, reoperation, pseudo, et cetera. And they categorized these patients and showed statistically significant differences. The challenge with this in our clinical practice is who's going to go through every single one of these and put a check mark in your clinic. And a lot of the inputs here are based off of the SRS score. If we don't have that available, or we don't regularly collect it, or a patient do it, then we're at a loss and we can't use this. And moreover, the question is then, what do you do with a number 16 versus an 8? It's all relative, but you don't really, it gives you an idea, but it doesn't give you an actual answer. What we've been working on with some of our computational scientists at Cedars is looking at patients and the data that we have readily available in the EMR. So basically Epic-based data, and seeing if we can just take this stuff that's already there and predict outcomes. And basically establish a frailty index with machine learning, with stuff that we don't have to go take out of a chart and add up ourselves and put together. And we've been able to really look at some pretty reliable outcome adverse event metrics and prove that. And if you really then go back and look, we just did a comparison study. Okay, how do I do some of these hospital-based frailty indices? There are frailty indices that are based on the electronic medical record where you don't need to do this other stuff. How well do they do against typical machine learning? And actually, the answer is they give you some indication, but their predictive value is a lot less in a spine surgery patient. And if you actually decompose the elements of each of these frailty indices and run them through a machine learning algorithm, it does better than if you just use it as a straight frailty index. And it's because all the things that go into these measures. They're not linear variables. They have, intrinsic relationships with each other, and machine learning tends to do a better job at predicting that. So I think as we go forward and we look at this concept of frailty, probably what's going to happen is it's going to morph into more of a machine learning predictive analysis based off of algorithms and patient data that's already available, rather than us sitting in a chart, counting deficits. For spine surgeons, we also know that there are direct things in the aging spine that contribute to outcomes and correlate strongly with frailty and back and forth. Specifically, we know that poor bone health and muscle health impact outcomes. Bone health, obviously, for several reasons. It affects the strength of our fixation and our ability to correct. It basically is related to our ability to resist fractures at our junctions. And there's a part that we don't really capture well at all, which is bone physiology and bone healing, which refers to the part that contributes to pseudoarthrosis. And we know some people just don't heal. And things like smoking and nutrition and other things can affect that. And simultaneously, sarcopenia has been studied extensively for two reasons. One, it serves as a surrogate biomarker for frailty. So people grossly look at sarcopenia as a means of assessing patient frailty. But also, as spine surgeons doing these long segment constructs, the muscle tissue envelope around the spine is immensely important because it has to do with our compensation. It has to do with our ability to withstand intolerances and getting the perfect alignment. And so we all know that some patients have perfect alignment post-op and they still fail, right? And so we also know there's patients who we didn't really do that great of a job getting their numbers right, but they're still doing well because they have all the muscle compensation. So studying these things directly is really important. But these disease states are probably very strongly overlapping for several reasons. We know that in large population-based studies that the two coexist, and there's strong relationships between the muscle and the bone from a physiological standpoint. There's endocrine factors that affect both. There are paracrine factors. The muscle actually inserts onto the bone, and there's crosstalk between the two elements. And there's, a hallmark of both diseases is fatty infiltration. It's actually something that we quantify when we measure some of these things. And so obesity, which is a huge problem in the United States, probably contributes. And so all of these things come together. And to add insult to injury, there's probably a genetic component to the coexistence of these things. So what I would suggest is that we really start to think about these things in a lumped disease process rather than just purely in isolation. So we talked a little bit about assessing bone health. And here are guidelines from the CNS from a few years ago. And the reality is that we don't really have a lot of guidelines at all. This suggests that we look at vitamin D, DEXA scores, and CT Hounsfield units with a cutoff of 97 in their recommendation. What we do know, and this was brought up yesterday, is if we do get people on anabolic therapies, and this was shown really well with the Columbia group and Zishan and Lanky, that if you do treat people appropriately with anabolic medications, they actually do as well as patients who have absolutely no osteoporosis and better than the patients who have osteopenia that's untreated. So we have effective therapies, but getting people into that area is the challenge. And the reality is that we don't do a really good job of detection with current methods. So Ben Elder is at Mayo Clinic. He's one of the kind of smartest people in the room for this sort of discussion. And they did a really nice study that's not really cited enough, but they looked at the different ways of evaluating bone health. And they actually put together a kind of a multi-linked assessment of bone health to see how well they could predict osteoporosis using FRAX scores, trabecular bone scores, DEXA, CT Hounsfield, et cetera. And actually what they showed was striking is that DEXA only accounted for about 25% of the osteoporosis. So if you use DEXA alone, you're missing 75% of your patients. We measure Hounsfield units. Well, Hounsfield units cover about 37%. So we're missing the boat on a lot of patients. It was brought up yesterday. What do you do about the patients who have osteopenia with a 2.2 T-score, their femoral neck? Like, the stuff they're not going to get paid for. And I think we're going to hear some good talks about treatment of osteoporosis and managing these patients later. So I'm not going to get into it. But the reality is that our current metrics and methods for identifying patients are lacking. Similarly, sarcopenia has been studied extensively. This is borne out in oncology literature and cardiovascular disease. And there's this European working study group that's like the authority on sarcopenia. And they've met a couple of times over the last decade. And their recommendations are that we define sarcopenia based on muscle strength, muscle function, and basically muscle size. And there's different ways of doing this. You can look at strength with things like grip strength. You can look at physical function by how fast they get up out of a chair or do different tests. And then you can quantify muscle and the actual muscle bulk and quality. And so you can do that with things like DEXA. You can measure appendicular skeletal muscle mass index. You can use body water composition with bioelectric impedance analysis. Basically, some people have these in-body machines in their offices to look at water content, which is basically a surrogate marker for body fat percentages, and that can give you an idea of sarcopenia. And then we can do like we do with Hounsfield units and make opportunistic assessments with available imaging that we already have. Obviously, the oncology literature has led this because every one of their patients has CT chest, abdomen, and pelvises, so they can very readily assess visceral fat and fat in the different compartments of the paraspinal muscles, psoas, and typically, this is assessed in the mid-lumbar at L3 or L4, and you can both measure muscle size with cross-sectional areas or volumetric assessment, or you can look at fatty infiltration and use, there's kind of categorical schemes for measuring that, like the Gutalier score, which is a 5 level, kind of qualitative assessment of the fat in the muscle, or you can actually use machine learning things to actually measure this for you. But the reality is in sarcopenia, there is no consensus on what is the best way to measure sarcopenia. There's all these different types of ways to assess it, but no one really knows how to use this clinically because all these different ways of looking at it and different clinical outcomes in every study shows something else. And for our patients specifically, paraspinal muscle fatty infiltration and muscle health doesn't always directly correlate to other global measures of sarcopenia that people are measuring. And this is a great study out of HSS that looked at different types of sarcopenia evaluations, and the muscle ones that we care about for our soft tissue envelope don't always necessarily line up perfectly with what we see in other measures of sarcopenia. So, from our standpoint, every study you see shows that sarcopenia is related to the clinical outcome that they want to look at, and there's some sort of correlation there. But we really don't know how to use or implement this in our clinic yet because there's all these different varying definitions, and we need to do more work to kind of look at specific spine outcomes and figure out what are the best measures that correlate to those outcomes. And that's something that we need to get better at as a field. If we're looking specifically at PJK, which of these measures of sarcopenia is most strongly correlated to the outcome? Which of these measures is most correlated to global outcomes? So there's a lot of work that needs to be done. Now, some steps moving forward in the same way with the machine learning. This was a study by John Shin and the MGH characters that did the metastatic oncology study looking at survival, just like all the other oncology studies, and they were able to show that they were able to not only segment automatically to L3 based on a CT, and then they were also able to simultaneously measure the sarcopenia based on a CT chest, abdomen, pelvis, and then quantify that, and you put that into an algorithm that correlated to survival. So this is a really good step forward. I think this is something that we need to kind of mimic and model. This is a study that was just published last month in Spine, and I think this is another attempt. This is a group out of Asia that looked at posterior lumbar interbody fusion subsidence and predicting that based on sarcopenia and this MRI-based osteoporosis measurement, vertebral bone quality score, which I have my own opinions on, but they were able to put these things together and, come up with a predictive outcome that strongly correlated with the presence of subsidence. And then actually they did a really nice thing. They open sourced a calculator that, you can use in clinic that might help you predict that. And I think this is kind of a move in the right direction. There's also this concept of radiomics, which is that, we're putting all these manually measured or even machine measured inputs into a data set. But there's probably features of imaging that we already have that may be predictive that we don't even know about. And we can use unsupervised learning and an analysis and study of these things to predict bone quality and sarcopenia and probably correlate to outcomes. And so we need to continue to develop that. But here's an example of doing that for osteoporosis using CT scans and coming up with some ways to use the machine learning itself to figure out what's the important part of the imaging that is actually most indicative. And then you can therein combine that with clinical outcomes to actually even further boost your predictive analysis. So this is where we're going, and it's really exciting. Our involvement with the Scoliosis Research Society, and I know Joe's part of that, and Alekos and others, and Chris. And basically the idea is to highlight where are we going with all this stuff in the future, both from the standpoint of osteosarcopenia, but also biological clocks and assessing tissue markers. And it's really exciting, but we have a long way to go. And we as scientists and surgeons at the same time have to be participatory so that we get the right direction hit here. And so this complex of interplay of all these things needs to be really looked at by us for spine-specific outcomes so that we get the involvement of surgeons who care about the right things, and we're not deriving these things from oncology literature or cardiovascular literature or whatever. So it's an exciting time, but we have a lot of work to do. I think machine learning is going to really help us. And, again, thank you for the opportunity to speak today. It's a real honor to be here, and I'm looking forward to the rest of the talks.
Thanks, Corey. That was awesome. I think we do have a few minutes for questions if anybody wants to jump in.
Great talk. Thanks for sharing. Do you have a problem? Like we have a problem if the DEX is normal, even though all the other parameters, maybe the Hounsfield units are bad and things like that, to try to get care for the patient's bones? Is that a problem for you guys as well?
Yeah, and I don't want to step, because I think there's going to be some discussion about treatment osteoporosis. So I don't want to get into too much. I will bring up one thing that might not be brought up is there is a company out of Berkeley that does, it's called On Diagnostics, and they basically, you can send them your CT scan that you already have, and they will apply a finite element analysis to look at stress and fracture resistance. And it's FDA approved, Medicare pays for it in the US, and you can use that as justification if somebody has, you measure their Hounsfield units and you can't really get that to get the medication paid for. You can send this out and then you have another level of verification. I think obviously if you can document the presence of fractures or something, a little subtle end plate thing that you can call and use these things, but it's a challenge. And I think that there's probably a real need and room for us to trial in spine patients, anabolic treatment in osteopenic patients, and they're the people that are cut off. And it's going to be hard, but I think we probably need to get some sort of involvement of some of the pharmaceutical industry to help do that. But I think that'd be something that would really benefit our patients.
Question around evaluating these patients and their neuromuscular component. We've known for years that Parkinson's disease, MS, other neurodegenerative diseases create problems for long constructs. I think frailty and there's a neuromuscular component there with frailty that we don't understand, and that I think is a big problem for the elderly. Where do you think we're going to go with that evaluation for going forward? How are we going to think about that?
I think it's huge, and I think the other thing that was brought up briefly yesterday is myelopathy, right? And a lot of our patients want to look down at their feet, even neuropathy, right? Peripheral neuropathy. And there's got to be some sort of functional assessment of cerebellar function or how people want to look and stand. So I think there's probably a neuromuscular part of that. Absolute Parkinson's is like the classic example. I had a patient the other day who was 8 centimeters off coronally, just purely coronal. We fixed him and he just can't help himself. That's your inertia concept, right? So how do we assess that? And I think that the talk yesterday about, assessing thoracic flexibility, that may be a part of it. Assessing motion is going to be probably the most important thing. And, patients' balance and, some of these ways of looking at patients' movement And we got to find a way to do that really easily. We can't just put everybody with little, balls on them and watch them in clinic. We got to have a good way to do that, readily available.
I totally agree. I think just as there's, the concept of sarcopenia, which is loss of muscle mass, loss of functional muscle mass, there's another concept of cerebellar degeneration, right, which is occurring as you age. And certain people have more advanced cerebellar degeneration as a part of aging that we don't understand. And I think that, it's interesting, I've been in this for a long time. Seg, Manish, been in this longer than me, but we listen to these PJK talks, right? And not a lot has changed. I mean, if you came to this course, it's 15 years old now, this course, Alekos? If you came to this course 15 years ago, right, and you sat in the back row and you listened to the talks about PJK, and then you listen today, there's not a lot that's different. So part of it is, I think, is this neuromuscular component that we don't understand at all. The other worry that I have is the field of neurology is in a huge struggle at all of our places, right? You can't get a neurology appointment. In my system, there's like 4,000 pending visits for a neurologist, right? And so they have to be our partners in helping us assess this, and that partnership is going to go away just because of lack of access. And so I think it's important for us to understand this. I really want to congratulate you on your point of this talk, which is that we have to own a lot of this. Because we are dealing with aging population. That's where a lot of our adult deformity surgery is.
Rajiv, do you think there's a role for individual departments, orthopedic, neurosurgery, to hire their own neurologists, hire their own endocrinologists, so that you have a little bit more focused treatment?
So the multidisciplinary center of the future is exactly what Alekos is talking about, right? So for example, at UCSF, physiatry lives under orthopedics, which is lovely, right? But you could imagine that if you had a bone health person on your team, right? It doesn't actually have to be an endocrinologist. It could be an APP who is advanced knowledge and is working peripherally with an endocrinologist. We tried to do that at Virginia Mason. We were unsuccessful at doing that. The other area is, hospital medicine. I know of groups that do a lot of complex spine that have their own hospitalist that, comes to their conferences, has, input, right? Part of building that multidisciplinary unit, I'm going to talk about that with the ERIS concept, but is, to your point, bringing all these specialists under our umbrella, right? Because as you know, even with peri-op clearance with anesthesia, that anesthesiologist might not know the difference between an L4-5 fusion and an L4 PSO. It's a completely different ball of wax there. So having specific people who understand complex spine surgery, I think, is a very important component.
Maybe one more question. If anybody has any.
Well, I'll throw it out. Is frailty a modifiable variable?
Well, there's a lot of geriatric scientists that are really trying to look at ways that we can change that. I think from a biological clock standpoint and some of these tissue markers. But it's hard. I mean, I think there probably at some point in the next 10 years will be some ideal medical therapy for that. I think even the concept of, boosting people with growth hormone or something to increase their muscle and, pre-treat them with, exercise to boost them, that might be something. I don't really know if, how much, there's some ideas of maybe like doing multifidus stimulation preoperatively and stuff. I don't know if that's going to get us to that level where it's going to probably prevent the PJF, but there, there's people moving in that direction. A lot of them are way outside of our world. So I think there's definitely research in that area, but we don't really have a lot right now. And honestly, what do you do with sarcopenia other than using it as a decision of maybe assessing how big of a surgery you should do? And I think that that's where a lot of this machine learning stuff will have to go. And Chris often talks about the digital twin. Is it's one thing to have a predictive model that tells you a number and you got a 16% risk of this or 56%. But the better model would be you have a 15% risk if you do this, but a 2% risk if you do that. And that's where the actual implementation of an intervention into the models is going to have to go. We can't just have a model that gives you a number that you're wondering, what should I still do it? Should we take the risk? It's like, no, you should be able to say, well, if we do this, this is what your risk is. And so I think that moving away from just like correlation analysis and stuff in our research, which is always great, you draw these lines between things, but actually looking at, we have all this powerful, machine learning and AI and stuff, like looking at how do we use that to actually test our plan ahead of time to see what the impact of it will be on the outcome. And that's kind of the exciting part, I think, for our field, because we're really close to doing that, but we gotta jump some hurdles to get there.
Yeah, I think Rajiv's point is a really important one as well. Is frailty, we're clumping together vastly different diagnoses. What we need to do is very discreetly cluster the subset with neuromuscular problems, the subset with neurodegenerative problems, subset with muscle bone problems, and the treatments and risks will be very different based on those discrete clusters rather than clumping it all together.
Absolutely.
Thanks again for a wonderful talk. And one of my questions was rate of change. I think baked into all of this as a fundamental assumption is, how are things changing? What rate are they changing at? We're not allowed to get DEXs once every 2 years, for example. Even CT scans, if they have like dose reduction protocols, I'm not sure that I can trust the Hounsfield units, particularly next to hardware. So I have a real difficult time making a important judgment about how to take care of a patient that may be frail without having that ability. Are there any tips or tricks or thoughts about that portion, or am I kind of looking in a different direction? Thanks.
I think it's a great point. And even we need a good way to assess our anabolic therapies, right? Are they actually helping? At what point? No one knows whether it should be 3 months, 6 months, a year. Is there a way that we can see where the asymptote is and assess people along the way? We just don't have a good way of monitoring chronologically, changes. But that's a huge need. Absolutely. Thank you.
That was awesome. I think there's also perfect lead-in. I think it's setting the stage for what the rest of the talk I'm so excited about. This is really going to highlight the multidisciplinary approach to these patients, and so we're actually moving outside of the surgical world. It's a real pleasure to introduce Dr. Long, who's going to teach us about osteoporosis.
Oh boy, in 15 minutes, no less. Excuse me. Yeah, so this is a huge topic that I'm going to try to condense down into a 15-minute, but likely a little bit longer than that. Sorry for the future or speakers ahead. Just give you a little background. I'm an endocrinologist. I'm actually the director of the UCSF Bone Health Program, and which is a new program that's created this year. And so my hope is that we'll be able to review some of the options from pharmacological interventions and hopefully encourage you to kind of intervene and hopefully reduce fracture events in the future. I have nothing to disclose. So just real briefly, I'm going to talk just a very brief review on bone remodeling, just to get a context of how these different therapeutics are their roles, and then discuss the diagnosis of osteoporosis, some current guidelines for treatment indications for therapy, and then discuss treatment options. And I am going to review as many as I can. There's quite a number of treatment options, but I don't want to necessarily be preferential towards osteoanabolics. I know there's a lot of push towards that, but I do want to give credits to the foundational medications, which are the bisphosphonates, and they're actually very significant positive benefit. So real briefly, bone remodeling. So this is an illustration just to give you a sense of the players involved and the processes involved. There's two key players, the osteoclasts and osteoblasts. The osteoclasts are resorbing bone. The osteoblasts are forming new. The osteocytes are embedded in bone. They're mechanosensors. They're detecting mechanical strain, detecting microdamage, and they're going to start a cascade of events to recruit osteoclasts from the precursors within the blood, forming a resorption pit, allowing then osteoblasts to come in and fill in this pit, forming new bone, and new osteocytes are in their presence. So bone remodeling is a two processes involve bone resorption and bone formation. These are coupled, so they're usually balanced. Most of our treatment agents, the bisphosphonates, selective estrogen receptor modulators, calcitonin, estrogens, and denosumab, act primarily on the left side of this equation. So they're addressing bone resorption, reducing bone resorption. This decrease in bone resorption is followed by a decrease in formation. And so these are coupled, and many times the bone mineral density improvements will plateau after a few years of therapy. However, there's an exception with denosumab. Of the contemporary agents, only teriparatide, abaloparatide, and romosozumab, Evenity, act on the right side of the equation where they're stimulating bone formation. However, keep in mind that abaloparatide and teriparatide also will increase bone resorption. It basically, the increased bone formation is a result of robust bone remodeling increase. So how do we get to osteoporosis? So there's many factors involved, and essentially there's an uncoupling of resorption and formation. Where resorption is greater than formation, there's various factors that come into play to create the situation. Aging and menopause are the primary drivers, and hypogonadism in males. This increase in resorption and decrease in formation relatively results in bone loss and a decrease in bone quality. And so coupled together, those will eventually lead to fractures. The decrease in bone loss will lead to a decrease in bone density. It's important to keep in mind that that decrease in bone density may also be a function of peak bone mineral accrual that happens during emerging adulthood. And so this is a lifelong process that might have basically manifestations from events much, much, much earlier in the patient's life. The combination of decreased bone quality and decreased bone density will result in an increased fracture risk. And that is also affected by falls. And there's discussions regarding sarcopenia and issues regarding fall risk, and it definitely contributes to fractures. So how do we diagnose osteoporosis? And so classically, how we diagnose osteoporosis is using the WHO bone density criteria from DEXA. And so in this figure or a table, it shows those different classifications: normal, osteopenia, and osteoporosis. And that's using the T-scores, which are standard deviation values from a difference from an average peak bone mass of young adult reference standards. So there are some caveats with bone mineral density determination of osteoporosis. The term osteopenia and osteoporosis were initially created as epidemiologic, basically, definitions in order to compare low bone mineral density across different countries. When they were created to determine fracture risk in women that were postmenopausal, so their application for men and premenopausal women is uncertain, but they are universally used. It's important to keep in mind that osteopenia is actually, in a young adult individual, a normal bone mineral density. And so osteopenia is a very, very confusing term, especially when you're looking at an individual who's less than 50, because in reality, that T-score may be normal for that individual based upon Z-scores that we use in younger individuals. There are also a clinical criteria that we use for defining the diagnosis of osteoporosis, this instant fractures at the hip, spine, or forearm. And there's also this tool that we use, the fracture calculator, FRAX. And we use these thresholds of a major osteoporotic fracture risk greater than 20% or a hip fracture risk greater than 3%. We missed this slide. Okay, so how do we determine when a patient should be on treatment? And so in 2022, the Bone Health and Osteoporosis Foundation created guidelines for when we would consider treatment initiation. And any individual who has had a hip fracture, a vertebral fracture, meets the criteria of increased fracture risk should be on therapy. Osteoporosis bone T-scores also qualify for therapy. Those that have osteopenic T-scores, if there is a coincidental pelvic fracture, forearm or humerus fracture, they would meet criteria for treatment, as well as those fracture risks that's above 3% at the hip or above 20% for major osteoporotic fractures. Keep in mind those thresholds for FRAX were defined using analysis that are undoubtedly out of date at this particular time. So when you come to FRAX, I know you guys have heard about it and used it. I just want to give you a sense of how we use it as an endocrinologist. This is basically a snapshot from the website for FRAX. It shows a 58-year-old woman who's got osteopenia, and it allows you to input clinical factors that come up with a fracture risk for this individual. Her fracture risk is at 9% for a major osteoporotic fracture and 1.3% for hip fracture. This is a snapshot of a similar individual, 58-year-old female who's got the same bone mineral density, but she has a history of past glucocorticoid use and a family history of a hip fracture. And now her fracture risk is much increased, significantly so, such that the major osteoporotic fracture risk is above 20, and she would be a candidate for osteoporosis management because her fracture risk is presumed to be high. Now, there's some caveats with respect to use of the FRAX. It is not designed to be used for individuals that are on pharmacologic therapy. You can consider the use of this fracture risk calculator 2 years after bisphosphonate use or a year after other therapeutics. And so important to keep that in mind. There are some other factors that come into play that might be involved in fracture risk. There is a new tool that's been available called FRAX Plus that is making some headway in use, but right now the standard is using FRAX. It's important to keep in mind the FRAX calculator only uses the femoral neck bone mineral density. So here are a list of therapeutic options that are available to us in the United States that are FDA approved for either osteoporosis prevention or for treatment. And so there's a vast list. I can't go through all of them, but I'm going to try to hit the highlights on quite a number of them. These are the list of the anti-resorptive agents, and so these are the results of clinical trials with respect to fracture risk reduction. One thing that's important to appreciate is that the fracture risk reduction is not uniform across all these anti-resorptives. Across spine fracture, non-vertebral fractures, and hip fractures, there's some various fracture reduction. For the sake of time, I'm just going to talk about denosumab, alendronate, and zoledronic acid. And there are in the syllabus some slides discussing estrogen, raloxifene, and calcitonin issues. So when you think about bisphosphonates, these are the formulations that are available. I've underlined the ones that are most commonly used. Alendronate, residronate, abandronate are oral forms that are typically used. The IV form of zoledronic acid is the one that's most commonly used with IV infusions every year. So what are the benefits of bisphosphonates? What do they manifest? So there's an increase in bone mineral density that's clearly observed at the spine of about 5 to 8% and at the hip about 3 to 6% after about 3 years of therapy on the clinical trials. It's important to recognize that there's a plateauing of that bone mineral density increase after about 3 years. The studies have shown that there's a reduced incidence of vertebral fractures, about 40 to 70% with bisphosphonates. Alendronate, residronate, and zoledronic acid have been shown to significantly reduce non-vertebral fractures 25 to 40%, and for hip fracture about 40 to 60%. It's important to keep in mind that abandronate has not shown or did not show significant reduction in those fracture, in the non-vertebral fractures or hip fractures. However, in post-hoc analysis, looking at a very high-risk group with T-scores less than -3, it did show a significant reduction in non-vertebral fractures. So a lot of times people are very concerned about bisphosphonates with side effects. Unfortunately, in the public's perception, many of these side effects are much greater than in reality. And so it's important to just kind of be aware of these side effects and of bisphosphonates. The most common are GI side effects, and that's due to just basically local exposure of the esophageal mucosa to these drugs. And that results in most commonly just abdominal pain or dyspepsia. Now, these rates are very low if the medication is taken appropriately. So counseling the patient to take the medication basically with a large glass of water, staying upright for a half hour. There's some other recommendations on how to take the medication to improve absorption, which is taking fasting and to avoid eating or drinking for 30 minutes afterwards. It's uncommon, but patients may manifest generalized achiness and basically joint pains with the medication, but very uncommon. I'm going to briefly address the issues regarding osteonecrosis of the jaw and atypical femur fractures. For those patients that are receiving IV infusions, it's important to counsel that it's very likely that they'll manifest flu-like symptoms for a few days after the infusion. That'll be self-limited, and those flu-like symptoms are expected to be much less significant on subsequent infusions. So osteonecrosis of the jaw. This one scares a lot of patients. It's very, very uncommon. Now, there are some risk factors that we're mindful of that might put someone at a higher risk for these events happening, namely if they've had cancer therapies, including radiation or chemotherapy or steroids. Poor dental hygiene. We very, very much encourage patients to have regular dental care in order to avoid invasive procedures, namely tooth extractions. Regular dental work, cavity, fillings, crowns, root canals, that's fine. You're not going to have an issue with ONJ with this medication. The prevalence is very, very low. I mean, 1 in 10,000 initially when you start on therapy. When you're about 5 years of therapy, maybe it's about 1 in 2,000 may manifest this, and a 10-year mark, it's about 1 in 500. So it's very uncommon. Atypical femur fractures are also very uncommon, and so it's associated with bisphosphonates. The duration of therapy likely increases that rate of these events. The causality is not really clear. We presume it's pretty low turnover, accumulation of microdamage that leads to these fracture events. If we, just to give you a sense of the numbers, if we take 1,000 patients and treat them with bisphosphonates for 5 years, using basically the criteria for treatment and the event rates that we've seen and the fracture reduction, 1,000 patients put on a bisphosphonate for 5 years, you're going to prevent up to 50 non-vertebral fractures, up to 100, 115 vertebral fractures. There might be 1 to 2 atypical femur fracture events. So there is a very low risk of these events, and there's a significant increase, basically increase in fracture reduction from common osteoporotic fractures. If we look at the denosumab data, there's a estimation of about 280 clinical fractures are prevented for every 1 atypical femur fracture. So that risk is lower with denosumab. So there are some controversies in care. So how long is the optimal therapy for bisphosphonates? We know that the longer you're on therapy, the more likely you will see these events. And this notion of a drug holiday comes into everyone's concerns. It's something that's applied only to bisphosphonates, and you're trying to allow washout of the medication, and you're trying to time the risk of these events that are rare with the benefits of therapy. And so typically we consider IV therapy courses around 3 years, oral therapy courses around 5 years. But if the fracture risk warrants, you can go up to 10 years and you're going to receive, if the fracture risk is really high, you're going to receive significant benefit that you're not worried about these risks. And so it's important to keep in mind these time durations. So switching gears to denosumab. So it's a monoclonal antibody targeting rank ligand, which is an activator of osteoclast, allowing osteoclast maturation. It's given as an every 6-month subcutaneous injection. In the 3-year trials from the Freedom trial, there's a 9% increase in spine BMD, a 4% increase in hip BMD, and there's a significant fracture reduction at vertebral sites, hip sites, and non-vertebral sites after 3 years of therapy. There's actually an extension trial going on 10 years that showed continued increase in bone mineral density with lower bone turnover and good safety data. This is a figure that shows that 10-year extension. What's striking about this is that you have this continued increase in bone mineral density over 10 years. Bisphosphonates, you're going to see this plateau, but for reasons that aren't necessarily clear on a drug that's targeting osteoclast maturation, there's this continued increase over a 10-year period. So, how do we consider denosumab and the duration of therapy? Is it necessary to stop therapy after a certain year? The 10-year extension trial would suggest that you don't need to. There's safety data that show that it's very effective. And we know that stopping denosumab, though, leads to rapid bone loss and a risk for multiple vertebral fractures. So there is a conundrum with this medication on how long you're going to stay on therapy, whether it's an indefinite therapy or a need to stop. And so just to give you a sense of these concerns, this is a schematic, basically kind of a cartoon illustrating what happens if you discontinue denosumab. So when you're on denosumab, you're going to see a reduction in fracture risk. You're going to see an improvement in bone mineral density and a reduction in bone turnover marker, CTX. When you stop, within 12 to 24 months, there's a rapid increase in bone turnover markers, increased bone resorption markers, loss of bone mineral density, that within a year, you're going to lose the gains from therapy, and your fracture risk is going to significantly increase. And so it's very, very worrisome with this medication on how best to treat and whether you can discontinue it. And so there's various different algorithms and approach. This is the most recent one that was published in the Journal of Bone and Mineral Research in 2025. It takes into account the risks of these events with discontinuation. It's really primarily a function of duration of therapy, but as well as whether or not the patient has had fractures beforehand. It's a higher risk, whether or not they have had bisphosphonate treatment in the past, whether or not they've had gains in bone mineral density. The magnitude of the gain, the higher the gain, the bigger the risk of loss. And so this algorithm is there for you to just keep in mind. The standard approach is to give bisphosphonates after you discontinue, but whether it's 1 dose of IV bisphosphonates, 2 doses, 3 doses within a year, it's really uncertain. And so there's a lot of thought and anxiety that goes into this. So just be very mindful of that when considering denosumab, is how long is this patient going to be on therapy, and whether or not you're going to try to get off. And if so, do it early rather than once you're about 5-year mark. I think you're continuing on therapy indefinitely. So I'm gonna switch gears to anabolics. So there's a lot of excitement about antibiotics and what they can do. So we have two that are PTH receptor agonists, teriparatide and abaloparatide, both delivered as daily subcutaneous injections. They have an FDA indication for treatment of men and postmenopausal women with high risk for fractures. So it's important to keep that in mind. There is an FDA indication for that. The BMD effects, we're going to see significant increases. Keep in mind, this is an 18-month treatment window. So bisphosphonates, we're looking at 3-year changes in bone mineral density. Now we've shortened it down to 18 months. So it is a dramatic improvement in bone mineral density at the spine and at the hip. There are some adverse reactions associated with these medications. Namely, there's some orthostasis and there's some kind of abdominal discomfort, some little pains that happen for within a couple hours of the injection that then resolve. We're trying to pulse this hormone through the body and it's gone within hours. And so a lot of times there's some symptoms associated with that usually do improve with time. Keep in mind there was a box warning for these medications for increased risk for osteosarcoma. That box warning has been removed, basically about 10 years now for teriparatide and a little shorter for abaloparatide. However, if there's concerns for osteosarcoma, so if a patient has had radiation therapy or has Paget's disease, you want to be cautious in the use of these medications because there might be an increased risk of osteosarcoma. So romosozumab is the other basically anabolic agent, the most recently approved treatment. It is both stimulates bone formation and it does inhibit bone resorption. So it's an inhibitor of an antagonist for Wnt signaling that then leads to this increased bone formation. It's given as every 4-month injections for a year. It also has an indication for individuals with high risk for fractures. Now keep in mind, it has an indication for postmenopausal women. And so for men that you're considering this therapy, sometimes it can be very problematic in getting this medication approved just because it is approved for women. It has dramatic improvements in bone mineral density. Keep in mind, this is a 12-month period. So this is even a shorter interval showing even greater gains. So it is a very, very potent bone building medication. It does have a black box warning. It is associated with increased risk for cardiovascular events, strokes, and heart attack. And so it's not indicated for any individual who's had a stroke or heart attack in the last year and those that you feel are at high risk. Now, keep in mind, the first study that was published on this medication, placebo-controlled randomized study, did not show a safety signal for cardiovascular events. The secondary study that was done in comparison between this medication and alendronate showed that signal and prompted the FDA to include this box warning. So is this truly a significant increase in cardiovascular events, or perhaps there's a protective benefit of alendronate, which has been shown, and that's where it basically manifests that signal. So time will tell whether or not this box warning will persist for this medication. So the osteoabolics, when you look at fracture risk reduction, this is a figure that just kind of compares these medications over a period of time. You can't do direct comparisons just because there's different durations. The teriparatide and abaloparatide were 18 months and romosozumab was 12 months. Important to recognize, vertebral fracture risk dramatically reduced significantly across all medications. For non-vertebral fractures, we do see it in teriparatide and abaloparatide. Romosozumab absolutely doesn't have a significant reduction, which may be a reflection of just the number of non-vertebral fracture events in that trial, but it is presumed to reduce those fractures clinically in use. So how do we take all those treatment options and their effects? Fortunately, Felisa Cosman led a group that basically was a combined task force for the ASBMR and the Bone and Health and Osteoporosis Foundation to try to help put all these treatment options into some sort of structure. And they've created this algorithm which basically categorizes patients with respect to fracture risk. And the higher the fracture risk, essentially identifying those individuals that these are the individuals that benefit most from osteoanabolics because they have a high risk of fracture and you want to rapidly reduce that fracture risk. The highlights from this is essentially if you have a T-score that is less than minus 2.8 at the total hip or less than 3 at the lumbar spine, that's considered a high risk for fracture, and osteoembolics are indicated as first-line therapy. If you had a history of a vertebral fracture, pelvic fracture, hip fracture, that's also indicative of a high risk of fracture, and osteoanabolics are first-line therapy. So this is a great document, great publication that provides justification for being more aggressive presently, or be more aggressive first off, which is very helpful for our management. Now, sequential therapy comes into play. Keep in mind, if you do a bone building medication, you build up that bone mineral density. If you stop it, you will lose the bone mineral density within a year of treatment. So you need to follow up any anabolic therapy with some sort of anti-resorptive to hold on to the bone mineral density. Depending on how much bone mineral density increase you need or fracture reduction you need, you may go from one osteoanabolic to another osteoanabolic in order to continue to stack up that effect. This figure provides kind of what we expect, what happens with these transitions. I think the important thing to keep in mind, if you go from osteoanabolic to an anti-resorptive medication, you will see continued gains in bone mineral density, so that's a good transition. It can be a little problematic when it comes to denosumab and how you're transitioning that medication. We talked about the bisphosphonates and how they can try to protect it. If you go from a denosumab to an osteoanabolic, if you go to a PTH analog, you're likely to lose bone mineral density at the spine. Transiently, it may recover. Hip, you're going to lose bone mineral density. If you go to romosozumab, you may see basically some slight gains at the spine, but you're likely to keep the hip stable just because of that rebound effect. So it's really problematic on that transition from denosumab to other therapies. So in summary, anti-resorptive therapies, just so you know, they are safe. They're effective. Don't discount them. They prevent bone loss, they preserve architecture, they improve the quality of bone, they reduce vertebral fracture risk. Most of them, excluding abandonate, basically we know that they're going to improve the non-vertebral fracture rates. Anabolic agents will have a greater effect within a shorter time period. They'll likely have a greater reduction in fracture risk, and they are first-line agents for those individuals that have very high risk for fracture. Keep in mind, patient factors will determine the most appropriate drug use. And one thing to keep in mind, bone mineral density change doesn't fully predict reduction of fracture risk. So don't be too fixated on the bone mineral density changes. You'll see plateauing, but fracture risk still persists with these medications. So just because the bone mineral density is stable doesn't mean the patient did not respond to therapy. The therapies are quite effective, and the bone mineral density may not necessarily reflect that fracture risk reduction. So it's basically a fracture risk, complex interactions. Contemporary therapies are very, very effective across all boards. But one thing to keep in mind is no pharmacologic therapy is going to reduce the fracture risk to zero. That's because we can't eliminate trauma and falls. So whirlwind tour. Sorry I went a little bit late. I'm happy to take any questions regarding that.
Thank you so much, Dr. I think we probably do have time for a couple questions.
Thanks. Thanks for sharing useful information there. It was really good for us. Now, we, as spine surgeons, we're worried about fusion as opposed to fracture risk. Like we do have, do these bones like biphosphonates by inhibiting resorption inhibit the bone turnover and limit our ability to get a good fusion? And what would you recommend is like kind of the ideal that would be a good balance that would give us bone to work with, but not inhibit the bone healing? And then is there a time that we should stop these medicines for a while before going through a fusion surgery?
Yeah, that's a great question. One of the challenges is I'm in for the long haul with these patients. So, and a lot of times when they're coming to you, it's the short term. It's like we need to address something clear and present and try to move on. And so I recognize that there's a little bit of a difference in kind of how I see this process and how the folks in the audience may see it. I mean, in an ideal world, we're capturing these patients much sooner before this. They're treated and their bones are much better quality, and the bisphosphonates will provide that improvement in bone quality that hopefully will then improve the surgical outcomes. In my review of the literature, it's really kind of a mix with respect to what is necessarily the best approach. I think any approach is better than nothing with respect to outcomes. I'm not convinced that necessarily bisphosphonates are detrimental and are basically would cause any sort of negative outcome, and that the outcome would be better with bisphosphonates versus nothing alone. And so I think it's a totally reasonable medication option. Now, in the acute setting where we have an untreated individual, and you want to try to get the biggest effect in the shortest time period, I think your osteoanabolics are going to be your best bet. The challenge, a lot of the studies that have been done are retrospective. There's very few randomized controlled studies that necessarily prospectively are trying to capture individuals with a lot of lead-in time to see if we can improve it. A lot of times at the time of surgery, and I feel there's really mixed results on whether or not it's necessarily helpful one versus the other, osteoanabolics versus bisphosphonates. And so I would treat any therapy as likely to be helpful. If we can work towards the osteoanabolics, you're definitely going to shorten that response time, and perhaps if ultimately you're better off on therapy, that's your best bet. But I don't think that bisphosphonates are necessarily detrimental. Does that hopefully answer?
So would you stay on treatment throughout the fusion process?
I don't have any evidence to suggest not doing that. I would ask you to continue on. Now, that said, if the patient has already been on therapy for 3 to 4 years, whether they're on it or off it probably doesn't make a difference, because they're at a point where a medication holiday makes sense, perhaps, where the continued therapy is likely a marginal gain relative to that first few years of therapy. So it has a lot to do with where they're at in their treatment course and whether this is something that's long-term or short-term. Short-term, I would definitely want to continue on to provide that fracture risk reduction. Long-term, there's not necessarily, I think, strong evidence that it's going to be helpful, because that drug is buried in the bone. You've got a huge burden that's going to slowly wash out over time.
Roger, thanks for joining us. And as was introduced, Roger is the director now of our Skeletal Health Service and a really important part of our work. In doing reconstructive spine surgery, what we find is that certainly bone health is a major determinant of mechanical complications. And so our optimization pathways have got increasingly strict. One of our shared frustrations is the difficulty and cost with regard to access, seeing some of especially the anabolics, but even in some cases, the bisphosphonates for our patients. So, for example, a patient with a DEXA score of minus 2.4, yet other risk factors, vertebral fractures coexisting. So, to that end, are some of the metrics like trabecular bone score, FRAX, are these things that we can actually use to try and help get authorization? So a FRAX score with a risk of more than 20% of a overall fracture, or I think 3% is the threshold for a spine fracture. Are these things that we ought to, metrics that we ought to be trying to put into the record to get authorization, or how do you get authorization for anabolics?
Yeah, I would say FRAX can be used. It definitely can be used, and I will use it regularly in situations where there's osteopenia on your bone mineral density measurements, which we all know is not necessarily the be-all, end-all when it comes to determining fracture risk. We know that half of individuals that experience osteoporotic fractures have osteopenia, and so it's not great. So FRAX is used, and I will use it. What I think is super helpful for us is if there is a fracture history and that referral documenting, yes, it's there, clearly defined, because fracture, as Felicia Cosman's and that position statement basically is clearly illustrated, that if you have this fracture history, that is an indicator of a significant risk for future fracture, and that can be used as justification. So documenting fracture history is very, very, very important, and we use that to primarily drive therapy. And I would say anyone who's got osteoporotic fracture automatically meets the criteria for any therapy. And then the question becomes is, can you massage it to say it's a high risk of fracture and we can get an osteoembolics for the sake of just trying to be as aggressive in the short term?
And then when we put somebody on an anabolic, you acknowledge that the rate of improvement of bone density might be faster than a bisphosphonate. I was impressed by how much improvement there was on bisphosphonates when it's just anti-resorptive. But having said that, how long do we need to have them on the anabolic before we think about reconstructive surgery? Do we need to wait until there's measurable evidence of improvement of DEXA?
Yeah.
Or is there some time frame that you consider ideal?
Yeah, that's one of the challenges because from with respect to fracture risk reduction and response bone density, yes, it is the most rapid. It'll have the greatest change and the fastest reduction in fracture risk. Now, when it comes to surgical outcomes and how that affects it, I don't know. I really don't. And the longer you can wait on therapy, in my mind, the likely the better the outcome. But obviously, there are other factors that come into play in the decision making and that timing. Your greatest gains are within the first, essentially 6 to 8 months on that therapy. So just be mindful that it's not a linear response. So it's not like we need to go all 18 months to see that gain. You're going to get your most in the first year, and then it starts tapering off. So you can use that to help guide this. Is that at least if you get your 1 year of therapy in, you're going to get probably the biggest improvement in bone density. Now, whether that translates to quality and whether you need more time to improve quality, it's not really clear. But if you can at least get a year, you're going to get the biggest kind of treatment effect from a bone mineral density increase. And with respect to romosozumab, the anabolic window is in the first 6 months. So there are thoughts about cycling that every 6 months. So from Evenity romosozumab, by 6 months, you're going to gain most of your bone mineral density. So that's also keep mindful as you can consider that. Because that'll be a little bit of a shorter window.
Thank you very much, Dr. Long.
You're welcome.
Really great talk. So next up, in continuing with the theme of multidisciplinary approach, I'd like to introduce Deep Singhal to discuss some of the approaches to the underweight or malnourished patient. Thanks for being here.
Good morning, everybody. Hopefully we're all recovered from last night's festivities or activities, if there were any. Great. Pleasure to be here. I represent Stanford Healthcare and Stanford Medicine. I'm actually a registered dietitian there, inpatient, primarily transitioning into orthopedics as well as spine. Kind of reason why I chose this opportunity to speak here today was mainly because growing up as a bit of an athlete, played high school and college basketball through my years. And I actually had an L4, L5, L5S1 herniated disc, which eventually actually led to surgical procedure, went through the healing process. And it was actually something that I thought would have been more relatable to me. So I'm really honored to be here. It's a pleasure to represent Stanford and really hopeful to give you guys hopefully an educational presentation today. No disclosures whatsoever. So I'd like to start with this quote here. First and foremost, Hippocrates did not say, "Let food be thy medicine." That is totally false. Remove that from your brains today. It's not published anywhere. It's actually, what he did say is that, in food, excellent medicine can be found, and in food, bad medicine can be found. And I think that's a great way to kick this off in the sense that this is a reminder that nutrition is not just a objective, but rather a subjective support. And in therapeutics, it's important that in surgical patients, we work through getting a smooth transition, especially after surgery, and reduce the risk of any kind of complications that may arise. So to kick it off, malnutrition is actually one of the modifiable surgical risk factors that we obviously look for. Yet it's often under-recognized in a lot of spine surgery cases, unfortunately. Now, today's approach is really about the underweight spinal patient undergoing that procedure and obviously optimizing the nutrition status for that patient. So what we look at is when underweight, we refer to the BMI of below 18.5. And frequently, these patients typically do present themselves with sarcopenia. And I know we've kind of double-clicked on that several times today, which was actually really insightful. So I do appreciate the conversations around that this morning. Quite a bit of evidence shows that the malnourished patients actually have a higher risk of surgical site infections, the longer length of stay, and of course, even higher mortality or casualty rates. Now, according to most CNS guidelines, we actually look at prealbumin. and we ask not necessarily to be or not to be, but to consult or not to consult. And I think that's really relative in the sense that we see patients who are underweight, we see patients who have a low BMI, we see patients with tons of micronutrient deficiencies, and this will be, of course, subjected to or dependent upon your clinical judgment. And so it's not necessarily always the albumin that we look at, but we look at the pre-albumin range, especially if it's less than 20. That actually significantly increases the risk of surgical site infections. So that's a key threshold that I would like to flag for everybody here today. So spine-specific evidence snapshot. Now, in spine literature, there's some support that's saying general surgery and data has shown that low pre-albumin does correlate with a higher risk of infections and certain complications, as you all know and see in your respective practice. Now, there's a large database of studies, especially in the New England Journal of Medicine, that does show quite a bit of malnutrition can predict prolonged hospital stay, as well as more reoperations or the opportunity to go back and redo the procedure. Now, vitamin D does play a very important role in that. And as you all know, typically it's still debated. There's still a bit of a kerfuffle around whether or not there's actually some sort of supportive evidence, but some studies do show that faster fusion rates do occur. And I'm sure you can all attest to that with repletion for vitamin D. So from a perioperative screening standpoint, we want this to be fast and feasible. This shouldn't be something that's overly time consuming, but something that you can all use in your day-to-day practices. It should be short and sweet. So we look at certain studies and tools such as the NRS 2002, which is the nutrition risk screening. We look at the malnutrition universal screening tool, or MUST. And then we also look at the patient-generated SG&A, which, if it's available in your facility, certainly is a great tool to use to determine a patient's nutrition status and whether or not they're malnourished. And as about unintentional significant weight loss, some of the things that we look at is if it's over 10% in 6 months, we look at 5% in 30 days, and we also look at 7.5% in about 3 to 6 months as well. Those are some key indications and flags that we will use to maybe consult our interdisciplinary team and refer to the registered dietitian. Some key labs that we look at pre-albumin. Of course, that'll be trending over some time. CRP levels. We also look at, we do a CBC, vitamin D and iron studies as well, which could be beneficial. And although we look at the pre-albumin that is less than 20, it's also important to be mindful of intake PO. If it's less than 50% of needs, we highly recommend, or at least in clinical studies have shown that it's actually risky to wait. We recommend early feeding as possible, and it can actually increase post-op complications if early feeding is actually not initiated. So we look at some of the things that we can do to optimize before surgery. Now, according to ESPEN, which is the European Society for Clinical Nutrition and Metabolism, guidelines recommend about 7 to 10 days of nutrition therapy for malnourished patients before any major surgery. And even if it means delaying the process, certain days or so. If we have a patient that's severely underweight with several deficiencies in sarcopenia, it's actually indicated to rather wait about 7 to 10 days. Most patients will go about a 5 to 7 day window, at least from what I've seen at Stanford in our clinical practice, but at your discretion, of course. And it's also important to prioritize either the oral or enteral route. For whatever means necessary, if there's no way to eat by mouth, then we look at the enteral access and see what we can do from there. Typically, we combine that with parenteral nutrition only if PO intake and enteral can only meet less than 50% of needs. And a short delay optimized nutrition therapy is actually a much better outcome versus delayed onset. So we look at some of the modern fasting and carbohydrate loading and why that's important today. Modern fasting protocols are somewhat a bit psychological. Typically, as you all know, you'll see clear fluids up to about 2 hours pre-anesthesia, and then solids up until about 6 hours. Now, preoperative carbohydrate drinks, we all know our Ensure Clears that we give to most of our patients. That's actually a great opportunity to drink prior to surgery. Typically, the recommendation there is about 800 milliliters in the night before surgery, and then 400 milliliters 2 hours pre-op. What that does is actually reduces the insulin resistance. That also helps with improving comfort for the patient as well post-op. And on the IDT team, so obviously, we are a multifaceted team, and we have our surgeons, we have our nutritionists, we have our anesthesiologists, we have our nurses. And so this slide mainly is just to highlight just a basic overview of what each discipline should be in charge of. Typically, nutrition optimization is a team effort, so it's not just going to rely solely on the RD. Although we'll write the tube feeds and TPNs, we do rely on a lot of the physicians, we do rely on our nursing team, and we do rely on the anesthesiologists as well to make sure we're implementing the correct practices. What we look at, for instance, with surgeons, they'll trigger the screens, they'll go ahead and approve short delays if and when needed. We look at the anesthesia team, we'll coordinate the fasting and carbohydrate loading with, especially with ERAS protocol. And then we look at dietitians such as us, we calculate the nutritional needs and provisions that'll go into whatever respective feeding or diet order that's typically processed for a patient. And then our nurses and PTs are always very helpful in terms of reducing intake and reinforcing intake and encouraging early mobilization post-op. So let's take a look at an inpatient plan here. Post-op nutrition should really start early and supplements with about day 0 to 1 or enteral feeds within 24 hours if intake is inadequate. And again, when we look at inadequacy, we look at about 50% or less. We also want to maintain glycemic control and pain management, as that's going to be supportive in helping a patient eat. We also have that if a patient is meeting less than 50% of their needs by day 3 or 5, you can create an initial bridge of parenteral nutrition, subject to clinical team's discretion. And it's always important, something to not forget, we should always monitor refeeding syndrome, especially if a patient is malnourished. More oftentimes than not, we see those electrolytes kind of get out of whack once we start introducing nutrition. So some basic optimization orders that we look at for the interdisciplinary team. Practical inpatient order set usually requires the following. It's about 2 to 3 oral nutrition supplements daily and a bedtime snack. If oral intake is below 50%, again, that's where we kind of get into the options of enteral versus parenteral feeding. And then nocturnal if necessary. If we need to do a cyclic feeding, that is an option as well for most patients. We also want to correct any kind of micronutrient deficiencies. That's going to be inclusive of vitamin D. We've got our iron, preferably, if IV, if it's an urgent case. We look at B12 and folate, and then we also look at calcium, and then of course our electrolytes with respect to refeeding. Now, repletion here is not optional. If it directly supports, healing infusion, that is something that we should always take precedent first. So, just some common pitfalls, here. Just for some estimated nutrition needs, what that typically looks like for underweight patients or malnourished patients. It's going to be dependent on the patient case. But what we look at is there should be anywhere from about 25 to 35 kilocalories per kilogram per day. And that's going to be subject to patient's weight. And now protein is going to be the most important for the healing infusion process. So we do look at about 1.2 to 1.5 grams per kilogram. But now if the patient is severely malnourished or underweight, that's when we can kind of up the ante and go to about 2. Especially if they're catabolic or in severely depleted states. And of course, we definitely want to monitor our hydration and electrolyte status, especially phosphorus and magnesium during the refeeding time. And just some common pitfalls to avoid and some things that might be common in practice but shouldn't always be practiced. Common errors include waiting for abnormal labs instead of screening early. I think it's really important for us to put our panels in, put our orders in, and get those lab results ASAP. And we also don't want to solely rely on albumin. As we know, we look at pre-albumin, given the shorter half-life. That's actually a better indication of nutrition status in comparison to albumin, which could actually be more of an inflammatory response. And we do want to avoid skipping any supplements. That is a very important one as well. Even if intake is adequate, we always recommend providing that just to provide additional K-cal and protein provision. And last but not least, don't let the patients stay in PO longer than necessary. We prefer to, as dietitians, at least at Stanford, it might be different in UCSF, we prefer early feeding ASAP as soon as possible. So just a typical pathway for an underweight elective case, this pretty much summarizes the pathway we use, and that's going to be a screening protocol that'll have the NRS 2002. We use the MUST, or we can go ahead and get baseline labs along with our subjective global assessment for patients. And then most importantly, begin 7 to 14 days of optimization in underweight patients. The sooner, the better. I think it's important to set clear protein and calorie targets, correct any anemia or deficiencies, if any. We definitely want to follow the ERAS feeding protocol. And post-op, we obviously monitor intake, we monitor labs, and of course weight. And if we don't see any kind of supportive, if we don't see any kind of uplift with just PO, it's okay to bridge with parenteral or enteral nutrition as needed. It's more work for your pharmacist, but hey, we've got to do what we've got to do. So just what a case study would look like here. Here what we have is a real-time example. This was a patient that I actually dealt with a couple weeks back, 65-year-old, got a BMI of 17.8 with a 12% weight loss over the course of 2 months. And there's a low prealbumin. I believe it was about 16, if I remember. Typically what we would do in this situation is you'd probably delay surgery anywhere from 7 to 10 days just for ONS, and then you'd probably include, if not able to meet needs by mouth, some sort of nocturnal feeding enterally, where those protein recommendations will be about 1.5 grams per kilogram, and IV iron for anemia if there's any corrective action needed there. And then with early feeding post-op, of course, you want to avoid the refeeding issues. So any kind of issues there with electrolytes, we would monitor the electrolyte profile for this patient. And then a brief delay pretty much is what saves significant morbidity or risks. So just some key highlights. Underweight and undernourished patients in spine surgery do benefit even from short perioperative optimization. We do want to use simple screening tools. I think it's important to initiate that sooner rather than later, follow our ERAS principles and protocol. And then most importantly, we want to make sure that we have the interdisciplinary team's support. You know, at the end of the day, this is a team approach, and it's not just going to take one. It really does take all of us. Those are my references for today. I really do appreciate you all. Thank you.
Thanks so much for that great talk. Super practical. We definitely have time for questions.
With the use of modern GLP-1 agonists that's being used significantly right now, there's an anecdotal understanding that these patients are malnutritioned, and I'm wondering if that's true or not, and if we should be undergoing a preoperative optimization with a similar 7 to 14 day nutritional supplementation like you do for the under BMI patient?
That's a great question. The GLP-1, that's become kind of a trend and fad in the past year. And, some patients who are taking that medication, there have been some studies. There is still a bit of debate on it, on whether or not that protocol should be implemented for a patient that's underweight or that's actually using it. The consensus from what we've seen from most studies is yes, you would want to implement and follow the same protocols and steps that I was able to outline today. But again, it's going to be subjective to your clinical judgment. If a patient's coming in and there's additional, complications or issues that we have, you would be more mindful of that. But the short answer on that, the consensus is yes, you would follow the same protocol steps.
Just have a quick follow-up, but for a different type of patient. We've had those patients that are under BMI that are potentially malnourished. You do think that by doing a 7 to 14 day, even though their BMI may not go above that threshold of 18.5, undergoing a very large surgery, you're still improving your risk of, infections or complications?
Absolutely, especially if there's sarcopenia and suggestive muscle breakdown. It is very important to get that nutrition in early. Not only is that going to help the patient from a repletion standpoint, but also from the healing process post-op.
I think for those of us that have taken care of these severe deformity patients, elderly female patients with BMIs in the 16 or 17 range, we struggled to get their weight up. And so one of the things that I've done over the last 20 years is a peg tube. And that is obviously, we remove it when we're done with it. But I've seen some success with that. And I know that when our nutritionists changed, they thought that was fairly radical. Thoughts about that? I mean, a lot of these patients don't have an appetite. They're in pain. They've lived, chronically malnourished to begin with. And so, giving them high volume feeds, or high calorie feeds through a peg tube seems to be, overpowering that. Any thoughts about that?
Yeah, no, Doctor, I appreciate that. You'd be our best friend at Stanford, I'll tell you that. It's not radical. We prefer that. If anything, what we do is we would do a very slow trickle feed, slow approach. Even if it's from a bolus perspective, we start off with maybe 1 to 2 boluses per day, see how the labs react, and then reassess, and then go back and up the ante from there. But typically, no. I think it's a great approach. We see it quite often.
Deep, thank you. Glad my wife was able to recruit you to do this.
Absolute pleasure.
Two questions. One is the pre-op setting in terms of what we should give to the patients. So we have trouble getting the patients to see nutrition.
Yeah.
It's similar to other fields. In neurology, we talked about that. So if we can't have them see a nutritionist, what should we, for that 7 to 10 days of optimization, give to them?
Yeah, I think it's a great question. More oftentimes than not, whether there's short staffing or issues or you can't get an RD or a nutritionist involved, the number one thing that we look at is if we can feed by mouth, PO optimization. We throw the supplements on there, primarily those clear drinks, whether it be an Ensure Clear or Boost Breeze, as I'm sure are very common in our hospitals. Those are actually still very good, still get some calorie and protein provision in prior op. I would recommend taking that route. Now, for example, if a patient's not able to eat PO and we're taking either an enteral or parenteral approach, then that's when we can kind of slowly start to introduce the trickle feed process and or a slow TPN infusion would be helpful. Yeah.
Yeah, we're doing this a lot in the outpatient setting. So having those boosts may be the way to go. On the flip side, post-operatively, I commonly get calorie counts and have nutrition weigh in pretty early. At least at UCSF, there is a significant resistance to putting feeding tubes in. We don't do the PEG tubes, we do feeding. And the main concerns are around cognitive status, altered mental status, et cetera. Can you talk to us a little bit about what is the real risk of these feeding tubes, what the resistance is, and then on the flip side, if we were to send patients out on a feeding tube, is it 2 weeks, 3 weeks? Kind of what do you recommend for duration of feeds?
Yeah, I think if we're using an NG tube, 18 French is going down, and I think the number one thing that you look at if a patient is maybe experiencing dementia or having some sort of agitation or issues, we always run the risk of pulling that thing out, and then we've got to call IR, do it back in again, and put it back in, right? And then you get a KUB. It's expensive, but it happens for some patients, and it's very common. I've seen it. We've got a patient last week. She pulls it out, I think, like over 8 or 9 times in a week. We've gotten to the point where we're like, hey, we're going to put the PEG in. Let's go that route. But I think you bring up a good point. If there are some altered mental status involved and a patient's unable to comprehend what's going on or be able to accept the fact that they're on this tube, you run that risk very highly. And I think your follow-up question to that was the timeline that you're referring with feeding. Typically, I prefer anywhere from about 2 weeks. I think 2 weeks is a very stable time. That gives the patient an opportunity to kind of replete themselves quite a bit. And in the event that PO, if it's still low, then I've seen cases where we've gone up to 3.5, 4 weeks. It's been pretty significant. Actually, at Stanford, I've seen quite a few patients that have run that month-long duration of feeds. Yeah.
Thanks, Deep. This was great. I think my question is there any, on the surgical side and the invasiveness side of it, is there any either threshold or different way you think about preoperatively optimizing these patients if we're doing a minimally invasive surgery that's already, we know is going to have a very low infection rate, very low wound healing rate? Is there invasiveness threshold with the surgery where you're like, oh my gosh, we have to take that 7 to 10 days. Oh, you're just going to do like a MIS, TLIF, maybe we don't have to worry about that so much.
No, that's also a great question. I think the severity of the procedure or the complexity of the procedure does play a key role. As you mentioned, if it's an MIS, TLIF or ALIF or whatever it could be that, you wouldn't necessarily have to take the extremes with, making sure that this patient is eating over 50% in the beginning. That kind of surgery and procedure is a little bit more minimally invasive, I would say, or not as extreme. That's when I would kind of maybe scale back from the protocol and not follow the 7 to 10 days. But in the event that you have a major surgery, that's when I would refer back to this. Yeah, that's a great point.
Super helpful. Steve?
Yeah, hi. Thanks for all the insights. It's really interesting for us. We have a lot of metastatic patients that come in and they need surgery urgently, and some of them are actually not all that fit. What is a good strategy kind of post-op on managing these kind of patients? We have to take them to the OR right away. We don't have time really to optimize, and we do, obviously, they're at high risk for complications, and especially wounds.
Absolutely. I think from the inpatient perspective, with what we discussed today, that's going to be kind of our first line of defense, especially if they're coming into the hospital. Post-op, that's when we start to look at, hey, what kind of outpatient resources do we have? Outpatient does, at least at Stanford, I'm sure UCSF does the same, is they do follow the patient extensively outpatient. There are typically what happens, there's a 1 month post-op from at least our protocol, 1 month post-op appointment, then there's a monthly follow-up thereafter. Now, let's say we get those patients who are 60, 70, extremely underweight, 16.5 BMI. Those patients will probably get followed a little bit more frequently. I'd say probably on a bi-monthly basis. But from an outpatient perspective, we would really rely on that until the event that they would come back into the hospital. God forbid they don't have to, but yeah.
Awesome. That was great. Another really, really practically relevant talk. So thank you very much.
Thank you all. Appreciate it.
At this stage, we're going to go to the opposite end of the spectrum. So it's really a pleasure to introduce Dr. Diana Thiar, who's going to be talking about the overweight patient and how do we optimize that patient for surgery. Thank you.
Hi, everyone. It's a pleasure to be here today. I'm a general internist and obesity medicine specialist. I run the medical weight management program at UCSF as well as our obesity medicine fellowship. Here are my disclosures. In terms of objectives, in this brief overview of how to treat obesity, which is a huge topic, I want you all to walk away with a really high-level understanding of how we think about treating obesity with different pillars. I hope you can walk away knowing the 6 FDA-approved anti-obesity medications for long-term use, understand these GLPs, which are not a trend or a fad, but really paradigm-shifting how we can care for people with obesity in the long run. And then understand the role of these GLP drugs in not just treating obesity, but the comorbidities associated with excess body weight. So I always start these talks with understanding what is our goal. When we think about treating obesity, our goal as medical professionals is not to hope that everyone looks the same. This is a room of very fit people, and I suspect, in your field, most people do look a certain way. But when we think about treating obesity, we want to help prevent morbidity and mortality associated with that adiposity. We don't want people to think they have to look a certain way to be valued in society or to be cared for by us as medical professionals. The other thing is that we shouldn't always assume that just because someone has excess body weight that they are unhealthy, but we do want them to understand the risks of long-term adiposity for health comorbidities. We also know that modest amount of weight loss can improve health. With 5 to 10% body weight loss, we start to see clinically meaningful changes in things like prediabetes and hypertension. And it's really above that 15% body weight loss mark that we start to see remission of some of those cardiometabolic diseases like diabetes, cardiovascular mortality, as well as HFpEF. While BMI targets drive a lot of what we do in medicine, we don't necessarily want to fixate on this idea of a normal body weight, because we know that it's really percentage change in someone's starting weight that can improve their health risks. It's not taking someone with class 3 obesity and getting them to an overweight BMI. It's trying to get someone that 15, 20% body weight loss to help them have a longer, healthier, more robust life. The other really important thing to note is as we think about treating obesity, we have to think about it with the perspective of any chronic disease management. If we take away the intervention that's treating our patient, that chronic disease will come back. It's the same case with obesity. When it comes to spinal surgical risks, we do want to try and optimize BMI and weight if possible. We know that there are higher risk of postoperative morbidity with a BMI over 30. And with anterior lumbar interbody fusion, the risk is really at that BMI over 31. And what are those risks? You all know this better than me, but it's things like surgical site infection, postoperative VTE, ileus, and UTIs. But on the other side of the coin, we also know that people have really improved functional outcomes post-op at any BMI. So we want to use our clinical decision-making and not be too rigorous and restrictive around the BMI cutoffs as we're thinking about how to treat our patients. Historically, as we've thought about treating obesity, we've thought of it as this pyramid. At the base of the pyramid, we have our primary care providers who should really be treating people with lower BMIs in that overweight category. As BMI increases and risks of comorbidities associated with excess body weight also increase, we have obesity medicine specialists like myself. At UCSF, we have a comprehensive care team of dietitians, physicians, nurse practitioners, behavioralists, and we focus a lot on the pillars of treatment: lifestyle change, which is diet, exercise, as well as anti-obesity medications. At the top of the treatment pyramid is surgery, but you have to remember that just because we have this escalated approach and options for our patients, we have to really follow what they want for their treatment protocol. Just because we have powerful medications or we have surgeries that work, it's really important to provide patient-centered care and patient-centered decision-making so the patient feels respected in whatever they decide to do. The other really key thing is that taking a medication will help people lose weight, but it's not going to teach people how to eat healthier or move their bodies more. So lifestyle change really matters. We want to make sure our patients are eating enough protein. It's a really big focus right now. I mean, at Starbucks, you can get a protein foam. But the reality is in the US, the average American meets their protein requirements, and it's the fibrous foods, vegetables and fruit that are lacking. So as we're counseling our patients to up their protein, move their bodies more, you also want to make sure they're actually getting the micronutrients through proper vegetable and fruit intake. There are currently 6 FDA-approved medications for long-term use in obesity management. The first 4 are sort of the older class of medications, and the last 2 are the newer generation of meds that we use. So we have orlistat, which is a lipase inhibitor. It's not very effective at only 3% body weight loss. The next is Contrave, which is a combination of bupropion and naltrexone, which is an oral pill, and you can see 5 to 8% body weight loss at 1 year, but there is some weight regain at year 2. The third is Saxenda, which was the first injectable GLP medication FDA approved for obesity management, and this was in 2013. 5 to 10% body weight loss at year 1 with maintenance of only 6% at year 2. Qsymia is an oral combination of phentermine and topiramate with 9 to 14% at 1 year, but again, some weight regain at 2 years. And then 5 and 6, what you can see is different, is with semaglutide 2.4, we have maintenance of that 12.5% at 2 years. And then with Zepbound, which is tirzepatide, we actually see more weight loss at the 88-week mark. Why does that matter? Maintaining weight loss is how we actually can improve morbidity and mortality. So numbers 1 through 4 have a certain amount of weight regain, which suggests in the long run, our patients are not going to have reduction in cardiovascular disease, sleep apnea, and things like that. But it's really this newer class of medications that everyone's hearing a lot about that are helping people lose weight, keep it off so that they don't have things like heart attacks, strokes, progression to diabetes, and so on. So why are these medications so powerful? It's because they act both centrally and peripherally. So we as humans evolved to have our hunger and satiety signals regulated in the hypothalamus, a very complex set of feedback loops between the gut hormones and the brain. But we all know that we eat now for reasons that have nothing to do with our energy homeostasis. So historically, medications only worked in the brain. Things like topiramate, bupropion, naltrexone, phentermine, they act in the brain to reduce those hunger noises, increase dopamine, and reduce cravings. But our brain is very powerful and can do things that outperform what is happening there. So people feel the effect for a couple months and then they go back to their favorite restaurant or watching their TV show with their partner or whatever, and those food signals start to come back. But what GLPs do is they do continue to act centrally on that POMC-CART mechanism to promote satiety, but they also act peripherally. So they act in the stomach to decrease gastric emptying. They act on the pancreas to increase insulin secretion, which is why these are so powerful for people with diabetes. And they also act via the liver to improve insulin sensitivity. GIP has an added benefit of increasing lipolysis and fatty acid synthesis. So it's important to note that semaglutide is a GLP monoagonist, and then Tirzepatide is a novel dual GLP-1 GIP agonist, and it is way more GIP agonizing than GLP agonizing. So it's only about 1/8 the GLP receptor agonizing as something like semaglutide. So while they are similar medications, we can't just call them the same thing. It's not like two statins. They're not interchangeable in that way. The side effects coincide very closely with the mechanism of action. So nausea is very common, especially at the beginning and with dose up titration. It's really important to note that being so nauseous that you can't eat or throwing up so regularly that you are having signs of malnutrition, that's not normal. Our goal is to promote a healthful lifestyle. So if someone is so sick that they're not able to go to their kid's soccer game or get out of bed and go for a walk, this is probably not the right medication or not the right dose for that person. The other common side effects are on the opposite end of the GI system, things like diarrhea and constipation. Those are managed very well with added fiber supplements, even in your patients who are taking in a lot of dietary fiber. Adding in a daily supplement can help. We also sometimes see things like fatigue, headaches, oftentimes associated with low PO intake or dehydration. And the rare but serious side effects are things like pancreatitis and cholecystitis, seen in less than 1% of the study population. Suicidal ideation was not seen in the RCTs, but in the post-hoc FDA reporting, some people have reported it. It has not panned out in looking at the secondary studies, but we still bring it up with our patients just to make sure they're aware that mood changes can occur. There are two absolute contraindications to use. One is personal or family history of medullary thyroid cancer, or MEN type 2. This contraindication has given the entire class of medications a black box warning, but it's important to note that these effects were seen on rat thyroid studies, and the rat thyroid is not a good human surrogate. So we haven't really seen it pan out, but we're also very vigilant about screening for these personal or family histories before initiating drug. The other thing is that this class of medication is contraindicated for use in pregnancy. It is not a teratogen, but it does increase fetal loss through placental disruption. So it's important for our patients who are trying to get pregnant, actively trying to get pregnant, to understand their risk and come off the medication before trying to conceive. I think the other side of the coin is that we've actually seen increased fertility rates and accidental pregnancies in women on these medications, because with weight loss, we see more better reproductive ability. So as we counsel our patients, we tell them of the risks, but also sort of the reality that it's still possible. In terms of the results, we talked about what it looks like at 1 year, but what's really key to note is that for both classes of medications, there are hyperresponders. So for semaglutide 2.4, about a third of patients had over 20% body weight loss. And for tirzepatide, over a third of patients had more than 25% body weight loss. That's the low end of a sleeve gastrectomy. So something like tirzepatide in these hyper-responders could be a quite powerful medication that's nearing what we can see with surgical interventions. And how are these medications used? They are single-dose pens that are weekly injectables. You can up-titrate in 5 months, but you don't have to. So if a patient is having a lot of side effects, you can spread out the timing between injections or wait 2 months, 3 months before up-titrating to make sure they feel better before you go up on a dose. So how do you think about this? If you have a patient who's about 250 pounds, 5'11", that puts them at a BMI of 35, which is class 2 obesity. To get below that BMI of 30 to decrease those surgical risks, that patient would need to lose about 14.5% of their body weight. That's higher than what we would expect with something like semaglutide 2.4 for the average person, but it's definitely within range for something like tirzepatide. Now, what is the time course of this weight loss? If your patient needs a surgery, but they have to lose weight beforehand, unfortunately, it is a quite long duration. So we see max weight loss around 68 weeks for something like semaglutide and closer to the 88 weeks mark for tirzepatide. So this is something that requires planning. If your patient urgently needs a procedure, bariatric surgery will be a quicker way to get weight loss. We see those rates of weight loss really peak around 6 to 12 months for surgery. So that's an important thing to remember. The other thing is that we know when these medications are taken away, people regain their body weight back. So both with the Step 1 extension trial and SURMOUNT-4, both studies had slightly different designs, but when patients were removed from drug, maintained on lifestyle change, they regained 2/3 of their body weight back. Now that matters both clinically because you're taking away all those potential benefits, but the reality is that that person's body composition has also changed. When we lose weight, we lose fat and a little bit of muscle, and that's okay. But when we gain weight, it's our adipose reserve that grows. So when that patient gains 2/3 of their body weight back, that's all in their adipose tissue. And so now their body composition profile has changed to be more fat and less muscle than before they had initiated therapy. And that's what's key. We know that women are likely to be in that hyperresponder group, specifically for tirzepatide. So with the tirzepatide SURMOUNT-1 through 4 trials, they did sex-specific weight loss trends. And what you can see is that women were on average losing closer to that 24-26% body weight loss, where men were lower, closer to the 15 to 20%. And when you further subcategorize this based on hormonal status, it's really premenopausal women that are losing the most amount of weight, and they're losing a lot of visceral adiposity. So premenopausal women are having really profound metabolic changes with this medication. It's also important to know that they could be hyperresponders and overshoot the mark. So you want to make sure you're treating your patients very carefully with these medications so they don't lose too much weight and become malnourished, as you had mentioned. I'll be very brief. You have these slides in case you want to unpack the data here more. But my goal as an obesity medicine provider is not to treat someone because of the way they look or just to help them lose weight. It's because we know that treating obesity can treat all of these other cardiometabolic and mechanical diseases. So by treating this one condition, we can really knock out all of these other things that really reduce people's quality of life and their lifespan. There are really 3 main trials that you all should know about that have shown reduction in morbidity and mortality and have gotten secondary FDA approval for these class of medications. The first is the SELECT trial. It was the first trial showing a medical intervention for obesity that can reduce MACE risk. So this was a very large study, 17,000 participants with a BMI over 27 and known ASCVD defined as MI, stroke, or PAD. Why does that matter? Because the FDA shows really high fidelity to study design for obesity. And so the patient has to have MI, stroke, or PAD as their ASCVD diagnosis, not just an elevated ASCVD risk, hyperlipidemia, hypertension. None of that works. It's very clearly these 3 indications. This was about a 4.5-year study. People lost about 8.9% body weight at that 5-year mark. And what you can see in box A is that there was a 20% risk reduction in the primary composite endpoint, which was the combination of time to first MI, stroke, or death from any cardiovascular cause. Metformin for diabetes has about a 20% MACE reduction. So this is a really profound finding. For tirzepatide, they're doing the trials right now. We're hoping to see that data come out in early 2028. Unfortunately, there's not just a class effect FDA approval for this cardiovascular outcome, so they're going to have to study this for every medication that comes out. The other big trial in the space is SURMOUNT-OSA, which is looking at tirzepatide for OSA. And in this patient population, it's people with a BMI over 30 and moderate to severe OSA, defined as an AHI greater than or equal to 15. Again, a large trial. And over the course of the year, people lost around 18% of their body weight and had a profound reduction in their AHI by about 50%. And almost everybody in that moderate sleep apnea group went to either no sleep apnea or mild, and even in the severe group, over half the patient population regressed to the mild or no sleep apnea. And it's this SURMOUNT-OSA trial that got tirzepatide's secondary indication for use in obesity plus moderate to severe sleep apnea. Again, very strict with that definition of BMI and AHI cutoff. And then the third is the study in MASH with semaglutide 2.4. It's the Essence trial. It was a very long study, 240 weeks. It's ongoing, but they published their 72-week data because it was so powerful. It showed pretty significant improvement in steatohepatitis with no worsening of fibrosis, and also reduction in fibrosis with no worsening of steatohepatitis. This got FDA approval in August for semaglutide 2.4 with MASH in the absence of a BMI cutoff. So that's pretty important because it isn't necessarily just related to obesity. Any of our patients with MASH can now get semaglutide 2.4. The insurance companies are still requiring a lifestyle change component, and they are requiring a specialist be involved in the care. So there is a lot of gatekeeping around these medications that is frustrating and really limits our ability to care for all of our patients appropriately. There are other trials that have been done looking at NEOA that have shown improvement, but no FDA indication for that. And then there are tons of other things being studied, and I'm sure you all see this in the news or on social media or hear it from your friends, family, anybody, but they are looking at these medications with substance use disorder, and they have been very powerful in animal models. We're seeing more data come out in dementia, Alzheimer's disease, and Parkinson's disease for these medications and diabetes, and they are now doing prospective studies for obesity. We're also looking at these medications for autoimmune disease like psoriasis, RA, IBD, and then a lot of the reproductive hormone diseases like breast cancer, HS, and then also separately in the cardiovascular space, we are looking at these for AFib. And then as a San Francisco person, I call this space the gold rush because there are tons and tons of medications that are being studied and will likely come on board in the next 10 years. What we will probably see in the next year are the oral GLPs. I'm sure you all saw the news about Orpho getting fast track approval, and then we have high-dose semaglutide as well. There are other dual agonists that are being studied, things like GLP amylin and GLP glucagon. There's a very powerful triple receptor agonist called retatrutide that's completing phase 3 trial. And then we have completely other mechanisms of action with the activin receptor inhibitors that are looking at promoting muscle growth. So this is a very rapidly evolving space. It'll give me a job for the next 10 to 20 years, but it's really important for everybody in the medical community to be aware of how powerful these are, how well they work for the right patient, because it's probably the most popular thing in medicine right now, and everybody's going to be asked about it. And with that, I'll leave time for questions.
Dr. Freed, thank you, that's very helpful. Question about, there's not necessarily a lot of size with respect to songs and demonstrations, but is there like a 1-2 punch in terms of, like surgery would be room environment, gastric sleep, and then you couple that with GLP-1, for example? Is there one procedure that you prefer or that you see more success in?
Because of all of the supply chain issues when these medications came out, there have been massive delays in these secondary studies. So the question is, should surgery or a procedure happen first or the medication first? And I think you can probably expect that the internists say medication first and the surgeons say surgery first. But then there's also this third procedural group, which is endoscopic. So I think, an endoscopic sleeve with a medication for your patient who has class 3 obesity, but still 40 to 50 is probably a reasonable approach if you need an intervention quickly. But if someone has a BMI over 60, I do think that bariatric surgery is probably the better first line. Some people are not having the same response, and we wonder if there is so much adiposity that there's not the correct bioavailability of the drug. But you really have to go with what the patient wants. And everyone has a weight story. If you're thin, if you're not thin. And so this is one space where it's important to tell your patients all of the pros and cons and say what you personally would do if they ask. But at the end of the day, you have to go off what your patient wants because everybody has a story.
Do you have a knowledge of what percentage of bariatric surgery cases, like how much they've gone down, let's say in the last 5 years, and do you think there will be any bariatric surgery left 5 years from now?
There's no data that I'm aware of. I don't think they would want to publish that, but the BMI criteria did go down in 2021 at the same time that Wegovy was FDA approved. So there's clear signs that the higher cutoff wasn't going to be enough of an output. In the Bay Area, I don't know how many people are Bay Area people, but bariatric surgery is not super common, but in other parts of the country, it still is. And a lot of medical weight management is housed within bariatric surgery. So I think there's definitely a home for it. I personally think that the laparoscopic procedures will potentially gain in popularity if academic centers, gastroenterologists are able to build up that practice, because they just have fewer side effects and less sort of long-term issue with malabsorption. So the malabsorption after bariatric surgery is the problem. And the problem is not that we don't know how to treat it, it's that patients stop taking their multivitamins. They graduate to their PCP, they move to a different state, and people just totally stop tracking all of those deficiencies.
Thank you for your enlightening lecture. I think this is really refreshing. It's a paradigm shift from where we were 10 years ago. And it's great news. I'm just thinking long term. You mentioned that if they come off, they gain 2/3 of the weight back, and it's not healthy because it's mostly adipose tissue, not the muscle is the hardest thing to build. And we talked a lot about frailty today. So can you give me an idea what happens to these patients long term? They just are on maintenance drugs forever, or I have no idea. So can you enlighten us on that?
It's a tricky question. Some real-world data is showing that with intensive lifestyle intervention, people can maintain the weight loss, but the question is for how long. When we look at other data that we have from previous medications, there is a subset of patients who can keep their weight off. And what we know from sort of correlational studies is that really high levels of activity and doing ongoing monitoring of your food intake is what's going to keep you most likely to only regain less than 5% of your weight back. We live in a healthcare system where insurance changes a lot, both what they decide to cover, but also each individual's insurance plans when they switch jobs. So people can't stay on these drugs indefinitely in the current ecosystem. And so what we try and do is say, let's go down the way we went up. If your hunger noises increase, if you start gaining a lot of weight, we either need to put you on a different class of medication, or maybe you should do something like surgery. But we follow those patients really closely. And when they start to gain 5-10 pounds, they know to come back to us. That is not realistic in the primary care population, though. So I think there has to be a bigger shift around how health systems can provide this wraparound care for people who have obesity.
What's the idea around this hypothalamus reset that I read about? And again, I'm not even 10% as smart as you. So I read that that a lot of this is resetting the hypothalamus. So is it that once the hypothalamus doesn't see the drug, it goes back to where it was?
So people who have chronic obesity, the thought is there's a couple things going on. One is that there's a hypothalamic dysregulation. The other is that we know through both fMRI studies and other MRI imaging that there's a different response to dopamine in the brain. We don't know if it's less of a dopamine release or if it's decreased dopamine response in the brain, but it's a combination of both. And so with the medications, we do see some improvement in that hypothalamic response because the GLP receptors are being activated more. But I just was at Obesity Week this week, and what we saw in the fMRI studies is that even with that weight loss, there isn't an improvement in dopamine response, at least in the short term. We don't know years 5, 10 are people who lose weight, do they have that improved dopamine regulation? It's really disheartening to see that that doesn't happen. And that food noise is what is really troubling for people when they lose weight, and that's why it's so hard to maintain it. So if you come off the medication and you lose that hypothalamic benefit and your dopamine response system hasn't changed, you're really just going right back to where you were when you weren't on the medication. That being said, people who don't have chronic obesity, so think about that person who gained a lot of weight during the pandemic, they might not need such a long-term intervention, and they might also benefit from trying some of the earlier class of medications first.
Just
with regard to bone health, this ties in importantly. One of the patients that I treated, a young male in his 40s who had had a gastric bypass about 10 years earlier, and you talked about supplementary vitamins and things. He had not been taking that and had perhaps one of the most severe cases of osteoporosis that I've seen. How do you monitor that over time? I've seen two people with bypasses, one with a copper deficiency that resulted in neuropathy, and one with pretty severe osteoporosis.
It's really unfortunate because what bariatric surgery does a great job following their patients, but you all understand that there's a maximum amount of time that it makes sense for a patient to stay with you. Very few PCPs in my own practice, which is a high functioning academic practice, know how to do the labs. And the other thing is patients, they don't even tell their doctors. I just got a transfer patient. I do primary care as well. She never mentioned to me she had bariatric surgery, but I knew because that's my job. But the fact that the patients don't tell their doctors, the doctors don't know what to check, it leads to these really intense complications. And I also think, this is anecdotal, younger patients are not as good about staying on medications in the long run, whereas an older patient who already has some chronic disease and is used to taking a medication, they do it regardless of if they feel any different. And so that's really the tough part about having a young person have a surgery that requires labs twice a year, multivitamins for their entire life, and making sure that they're really staying connected in the healthcare system and also advocating for themselves.
All right, well, thank you again. That was really amazing. We appreciate you. So we're going to transition now from the preoperative stage to the more perioperative, intraoperative, postoperative phase. And it's really a pleasure to introduce my friend Raj Sethi talking about his enhanced recovery protocol for complex surgery at Virginia Mason. Raj.
All right. Thank you very much. It's a pleasure to be here. I've been in this meeting, I think, for at least 10 or 11 straight years. So it's a great honor to be here. And this is an area that I'm very interested in. First off, I want to really highlight two people, one of whom is sitting in the room, Kellen Nold. Kellen, raise your hand so everybody knows who you are. And Takeshi Fuji. I've had a number of fellows, research fellows from Keio University in Tokyo who have come and worked with me. And Takeshi just completed a year, and this is one of his highlights. This is the topic of this lecture, so that always helps. So here's what I'd ask you to think about. You've heard some really great lectures thus far on what our conundrums are. This is a 75-year-old retired physician. He has a non-fatal disease, but he's severely disabled. He's had a couple of in situ fusions. He's profoundly malaligned, and he undergoes this major operation. And let's not talk about the carpentry here. Let's just think about how are we going to get this patient through this operation with fewer complications. And that's really what ERAS is all about. I've spent the better part of my career talking about this problem of quality, safety, and value in adult deformity surgery, and particularly how do you optimize these patients who have all of these problems that you've heard about this morning, and then how do you put all of these disciplines together to deliver a better product. And the product for us is a sustainable operation as the one I just showed you with few complications. Now, health economics is another major area of interest for me. I went back later in my career and got a PhD in health economics because I was looking at these problems, which is that we spend a lot of money in the United States on healthcare, $86 billion on spine care alone, and that spinal fusion accounts for 7.1% of the costs for hospital stays of any inpatient procedure. So this is a major issue for us to discuss.
There's a couple of organizations that I'd like to highlight that I've worked with now for the last 20 years, and one is the SRS. I was the inaugural chair of the Safety and Value Committee a long time ago now, and this was our charge that year to put this together to give people essentially a menu of what they could do in their practices and in their organizations to optimize outcomes. And there's a lot of ERAS principles in this area. The other two organizations that I'll mention here, number one is the Spine Safety Foundation, called S3P. I ran the adult side. I continue to run the adult side, and Mike Vitale runs the pediatric side. We do a meeting in New York every year. And a lot of these principles are front and center there. The third one is the National Spine Health Foundation, which is now doing a very patient-centered approach to all of this and what do patients need to learn, right? If we go back to the S3P meeting, the Spine Safety Summit, this is a pretty amazing guy. His name is Stanley McChrystal, and he led the raid on Osama bin Laden in Pakistan in 2012 or 2011. And he really talks about the importance of teams. And I think that teams are going to be very key for us to optimize patients. I think Dr. Walker's talk from earlier about where AI is going to take us and risk stratification is very important to think about too. But we don't really have those tools today, and we need a lot of work to get there. So today, what you can do is you can build these teams, because these teams combat stress in many arenas. And if clinicians argue the value of this approach, they argue that multidisciplinary teams are resource intensive, they erode independence. That's kind of yestercare thinking. Really, the future is we need teams, and we deserve a significant effort to standardize care for these patients, because we haven't even seen the start yet of how inundated we're going to be with patients demanding these procedures in an era of unsustainable healthcare costs. This work was led by one of my former fellows, Vijay Yanamadala. This is essentially a systematic review of multidisciplinary approaches. You can look at that if you're interested. Doug Burton and I led this work at the ISSG, I think almost a decade ago, also about what factors are modifiable and what factors are not. I will tell you that regardless of anything we say, surgery remains the only option for most of these patients. So we've got to do something better. We talked about this a while ago at Virginia Mason about this spine team approach. I think many of you are aware of this. It's written about also in JBJS reviews. You can look at that in further detail. The whole idea about conferences was, how do you standardize care, and how do you move the whole lot towards improvement, as you see in this a lot here. A lot of these criteria that are being optimized are things you've heard about today. And how do you do that if you're a lone surgeon without a team and you're just trying to do it by yourself in your clinic? It's impossible. You're not doing it. If you think you're doing it, you're probably not doing it, right? So you have to put a team around this, and more importantly, a process. I'm really waiting for the day that the computer is going to tell me what to do, right? I think there will be a future for that. Risk stratification in that way is going to be the future, and it's going to be hopefully a lot more foolproof. But right now, optimization is really team-based. So back to what Takeshi did. The reason that we did this was I was asked by one of the SRS committees a couple of years ago to if we had looked into this. And we said, well, is there really any evidence that ERAS protocols help in adult spinal deformity patients? And we said, we need to do this meta-analysis and a systematic review, and Takeshi took it on, right? And so the idea is all of the same things, right? We want to reduce risk, and we want to put a pathway in process to reduce risk. So obviously, these protocols have been shown in certain areas, as you can see at these bottom two highlighted papers, with opioid use, 90-day readmission rates being the two major areas, right? However, what we found is that there was a lot of variability in different institutions as to how these ERAS protocols were being put into place. And so that's why we started with the systematic review. The next part of this is really going to be putting together a Delphi group, and we're in the process of doing that at the SRS to really understand what those differences are and what are the best practice areas. Here's what we know today, right? These are our methods for this analysis. We looked at TL patients. We looked at those that had implementation of ERS protocol, and we looked at comparison between pre-ERS and post-ERS in these 4 areas: medical complication rate, 90-day readmission rate, opioid use, and length of stay. There were 62 articles that were part of this. We included 8 of these studies, and the commonalities for those of you that know ERS are preoperative optimization, intraoperative stress minimization, and postoperative recovery facilitation. This was all in the original Seattle approach from 15 years ago. That was the first analysis to really talk about doing this in adult deformity patients. But now it's codified a lot better. And what we look here is on these studies, right? We see this trend toward improvements in this post-ERS group in length of stay, medical complications, 90-day readmission rate, and total opioid consumption, MEDs. The length of stay discussion deserves a little bit of a side discussion here, right? 4 studies showed a significant reduction in length of stay. 2 studies actually revealed an increase in length of stay. And so that's really not perfect here. I mean, it's clearly controversial. While the result was there, the observed difference, it was only nearly significant. So there's some disagreement there. So in agreement, right, postoperative outcomes in terms of medical complication rates, 90-day readmission rates, and opioid consumption, that's what we found in the original Seattle approach. That's what we originally published. And so that was really your first ERAS of adult deformity patients. This length of stay, again, it's controversial for all the reasons I just discussed. What are some of the reasons? This is why we need further work in this area. This is why we need a working group to look at ERAS and adult deformity, because there's a heterogeneity in the primary goals. There's a small sample size and short-term outcomes. What I found also is if I talk to all the major institutions here who do a lot of deformity surgery, there's probably significant variability between St. Louis, Toronto, San Francisco, Los Angeles, right? San Diego. There's just so much variability in how we're all doing this, right? So going forward, we need these working groups. So in conclusion, I think that these protocols for ASD surgery are very important. And the 3 areas that you need to take away are preoperative optimization. You've heard some amazing talks this morning about that, bone, obesity, et cetera. Intraoperative stress minimization, which is really teams, dual surgeon approaches, an anesthesia protocol, things like that. And then postoperative recovery facilitation. The interventions and the primary goals of the ERS protocols varied across the included studies. That's the need for having more work in that area. I think that it clearly shows us, though, that there is reduction in readmission rate, medical complication, and opioid consumption. Length of stay remains to be seen. Different hospital systems may prioritize other factors when designing their ERS protocols. I don't know if that's going to be from the perspective of a center of excellence contract. I don't know if it's working within a Teams bundle. Whatever that hospital system wants to do, you may find that you'll prioritize different factors. But we really need a consensus-based Delphi on this area, so that at least when it comes to adult complex spine surgery, we have a better way forward. Thank you.
Thank you, Raj. Questions, Martin?
So that's a phenomenal talk. And I think I've read that book, Team of Teams, which is also a really great book. For some of the fellows or the young faculty in the room, what would you tell them on how to approach their health system, approach anesthesia or the other spine surgeons to get them invested in building a team, right? Is it looking at prior outcomes? Is it setting an agenda? How would you advise them?
Yeah, so I think that's a great question. A question I'll just repeat is how do you teach fellows and young surgeons how to get buy-in from your organizations to build teams? And I think that is an important, very important comment, very important question. What you should do is at the institutions where you're learning, go and learn from those people that can facilitate bridges and those that are able to help others see the perspective of these patients or the perspective of the service line that they're leading, right? A lot of surgeons think that, you can walk into an office and just say, I need this and I'm doing a lot of work and, bringing you a lot of gravy into your institution, so you got to do it. Doesn't work like that. I think it's really trying to facilitate those perspectives and learning how to speak the language of the people that you're trying to bargain with. And so what I mean by that is there's a financial equation in almost every scenario here, right? And so if you can show that you're reducing length of stay and you're able to tabulate what that means to the organization, you can speak the administrator language to maybe get a part of that team established, right? If it's throughput in the operating room, we want to do more cases, right? So therefore, this is why we want to use a dual attending surgeon protocol, because we want to do these cases faster and do more of them. That can translate into a very good economic equation, right? So learning what those areas are, I think are very key. The second part of my answer to you is really, as surgeons, we really need to grapple with healthcare economics, and we really need more curriculum and more curricula in the medical school phase to teach us about this, particularly as it gets more complex. So focusing on some of those topics, I think, is important. Manish.
You've obviously done a great job in Virginia Mason to convince the administration and getting this done. I think one of the biggest problems is financial explanation and motivation. So if you are a young person, you have no idea how to get that information. So how did you find partners in administration to put dollars and cents to convince the administration, because that's the only language they really speak?
Totally correct, Manish. So just to repeat what Manish is saying, which is filled always with immense levels of truth, is that when you're young and you may not understand the entire value equation, and you may not understand the health economics around all of this work, how do you convince administrators who really only care about the bottom line? And what I would say is, I totally agree with you, you have to speak their language. Right. And so you have to start to understand what things cost, what metrics they're looking at, how they're getting judged. So to answer your question specifically, right, we think about longevity, right? Most of us surgeons, we go to a practice and we stay there for a decade or 2 decades or maybe even longer, maybe our whole career, right? We don't move around every 2 to 3 years. How many of your administrators stay in their positions for more than a year or two? Right? Let me ask theologians, like, you've been at UCSF 10 years, right? If you take any of the administrative jobs that you or administrators that you deal with, I actually SIG's been there even much longer. You've probably dealt with double-digit administrators, because guess what? They have a different command chain, number one, and their metrics of success are sometimes completely opposite of yours, right? They're short-term deliverables and they're short-term spreadsheets. So you have to somehow bridge that gap, and to think that you're not going to have to speak that language, you will fail. You'll fail miserably, and you'll be very unhappy as a surgeon, particularly if you want to affect major change going forward. So I think it's trying to speak that language, but maintaining your integrity at the same time.
Yeah. Thank you, Raj. One thing just to get
back there.
Oh,
Yeah.
Go ahead, Zach.
Yeah, I just had a question. You mentioned in medical school, like increasing the education regarding the policy aspects. And there's a lot more programs nowadays that have like MPH, MHA, MBA. And I was wondering if you thought that is like a good step in terms of increasing your understanding, or if the degrees like aren't necessarily as important.
So Manish and I both went and did executive training very late in our lives. Okay, I was probably the oldest PhD student in the history of this university. I went back much later, close to the age of 50, and did that. Right, Manish went and did an MBA. I think your question is amazing. If you could do that earlier in life, if I had to go back, I asked Manish the same question. Would you have done it earlier? Absolutely. Right? I would have done it earlier too. If I had understood all of this at that time, I just didn't. There's also other pressures, right? You're in debt, you're trying to build a practice, you're trying to raise a young family. There's so many other things that are going on that it's maybe hard to take another degree, when you're in your first 5 years of practice. But I think your question is totally spot on.
Awesome. Thank you so much.
Yeah.
I would add a comment to that. I would say don't do it too early. So don't do it right after your training. I think you have to have 7 to 10 years of some sort of world experience to do the executive MBA to make sense out of it, because you need world examples. So sorry to interrupt, but I think 7 to 10 years is perfect.
Raj, terrific work. And I think what you're putting together here is really key to a value-based healthcare system and the sustainability in spine surgery. One of the things that I didn't see as an outcome, I saw length of stay, I saw complications, 90-day readmissions, but was basically cost of care. Mm-hmm. And now probably length of stay is somewhat a proxy for that, but I think that there are probably other things to think about the cost over a 90-day period or cost over a 2-year period. So where's the cost effectiveness of these programs?
Yeah, so that's a great question, Sig. The 62 papers that we reviewed for this systematic review, there was almost nothing about cost or cost effectiveness. And as you correctly point out, length of stay was the surrogate in some of the studies. I think we can do better work in that area. And to Martin's question from earlier, how are you going to convince healthcare administrators to do this work? We're going to need to do that actually, to show them that, this is your upfront investment for this team, but down the road, this is what we're going to save, right? And I do think the second part of your question, the second part of that, which is, we've talked about all these interbodies that all of us are putting in, right, at all these levels. I would really give some caution to some of that, because bundling of these surgeries is already here in certain ways, right? So when they're going to pay you X number of dollars for the adult deformity reconstruction, right, based on however many levels you're fusing, right, T10 or T4 or high, whatever, I think that cost effectiveness equation is going to come in too, right? Whereas Hanjo Kim, my friend at Special Surgery, is doing some pretty amazing work at looking at doing these operations really quickly with an all posterior approach with no interbodies, right? And so part of that is length of stay, part of that is cost of implants, part of that is patient satisfaction. So I think all of these things are going to get increasingly measured.
I'll just put it very briefly. I don't know how many people know that UCSF on January 1st, mandatorily, we're going to be included in CMS teams, which is for our Medicare population that's non-HMO. We've got bundles for all of our posterior and front and back fusions, so excluding decompression, excluding cervical, but we're actually mandated to be in bundles for our Medicare population starting January 1st. About 750 hospitals across the country, UCSF's one of them, and that's going to have a big impact on how we think about our cost of care.
To add to that, I highly recommend that particularly young surgeons, have a look at a paper that was published by Jeff Gum on something called the MAR, the Medicare Allowable Reimbursement, about how much money we're losing on every Medicare patient on these long constructs, right? So right now, including at UCSF, your administrators know that if you have a certain uptick in a commercially insured business, right, you can pay for all that Medicare work, right? But as these teams bundles take effect, and as they realize that you're losing money on every single patient, you may not care because you're getting compensated by RVU, right? things are going to change, and so we have to really grapple with this as a community going forward, so that we can maintain access for our patients.
Thanks, Raj. That was great. Maybe you can post that link somewhere we can access it all.
Yeah, absolutely.
All right. Well, thank you, everybody. We are running quite far behind. This is going to be my topic here, tailoring thoracolumbar deformity surgical strategies to the frail. A lot of this has been covered in really great detail, really eloquently so far. So I'm going to, for the sake of time, move through this fairly quickly. But I do want to show how some of these concepts really particularly influence me in my minimally invasive spine practice. These are my disclosures, not really relevant to what I'm talking about today. But again, looking at adult spinal deformity surgery for some of the work done by all you guys out in the ISG out there, we know very high complication rates in the 50 to 70% range. But what we also know is, in these complex surgeries, if we give patients through this, there still is in any related, outcome measure that you look at, these patients do much, much better in the long term compared to those that don't have surgery. And so associated high complication rates, but still great improvement with these types of operations. These are some of the work done by Chris Ames and John Burke when he was our fellow. First of all, defining the problem. In these complex surgeries, frail patients and the complications they're experiencing, how do we categorize these types of failures? And we wrote a paper about this that you can reference to talk about PJK mechanical failures and those sorts of things. Now, at UCSF, we do, for these frail patients, we do have order sets built into the EMR where you can activate a prehabilitation order set. And so for patients that fall into these categories, there are options if you have the time and the resources to get these patients somewhat more optimized in the preoperative setting before undergoing a deformity operation. Now, I'm going to talk about some of these concepts by way of history. And first is a relatively straightforward case, is a 78-year-old female, overall very healthy. If you calculate her frailty score, she's in the not frail category. She's had multiple years of back pain, some leg pain, and although intact, she does have a fairly complex deformity where she's sagittally imbalanced, coronal shift, type C curve, and decompensated with an elevated pelvic tilt. She's had an onlay fusion in the past, so solidly fused in this deformed alignment, and does have stenosis explaining her leg pain. And again, autofused both anteriorly and posteriorly at the lumbosacral junction. So this was our plan. What would be our standard plan at UCSF, an open T10 to pelvis with an asymmetric L4 PSO, multi-rod construct, cement augmentation of the UIV and the UIV +1, and ligamentoplasty. I'm typically using navigation for all these operations and employing the two-surgeon model. So I do all of these cases with Elecos, and we really do believe in this model. Some of the data behind these techniques, Chris has written about multi-rod constructs and decreases in revisions in PJK to a very highly significant level, and we really have moved towards these multi-rod constructs for all our deformity. Mike talked about this earlier. He's really kind of the leading edge of a lot of this research, ligament augmentation to prevent PJK, PJF. And in several of his papers that I'll reference here, using this particular technique, again, to your talk yesterday, you can get significantly decreased rates of PJK, and this holds true through the long term as well in this minimum 1-year follow-up data set with a large group of patients. Now, cement augmentation, this is alluded to a little bit, particularly Chris's and Vedat's technique of more or less fluoro, less vertebroplasty, so adding efficiency and decreased radiation exposure to the patient and the surgeons. And if you look at this, even on multivariate analysis, looking at PJK and PJF, the vertebroplasty at UIV and UIV plus 1 really does stand up to that multivariate analysis, independent predictor of PJK and PJF. This has also been alluded to even just right now with Raj, but we do believe in the two-surgeon model. And Chris and Vedad did publish this. Similar radiographic correction with 1 versus 2 surgeons, but significantly lower blood loss, shorter surgical time, and overall less major complications, less return to OR. And so again, we're applying this strategy to all of our deformity patients. This is what this particular patient looked like during surgery. You can see the deformity, and after the instrumentation, decompression, and ultimately the correction. Multi-rod construct, you can see the ligament augmentation, and the closure of the PSO. And this is what it looks like intraoperatively. So this is alluded to a little bit yesterday as well for complication avoidance. Intraoperative reconciliation using the O-arm and getting basically a long plate during the operation. You can measure all the things that were really well described yesterday by Mike and others. L4 to S1 lordosis, PILL, and both spinal hip axis measurements as well. These are done at the end of every case and corrected if needed. This is what it looked like, both intraoperative reconciliation, pairing very, very well with what the ultimate construct looked like in the postoperative setting, both sagittally and coronally. Now, this, again, up front, that patient was not frail. Now, Corey gave a really amazing talk this morning on frailty, but just to define it one more time, because it's such an important concept, frailty, it's a medical syndrome with multiple causes and contributors characterized by diminished strength, endurance, and reduced physiologic function that increases an individual's vulnerability for developing increased dependency or death. Basically a measure of physiological reserve and the ability to recover from an insult such as adult spinal deformity surgery. It does increase in prevalence with age. And this is critical because in the general surgical literature, now moving into the spinal surgery literature, it does correlate better. Frailty correlates much, much better than chronological age, the rate of infection, dehiscence, any type of infection, delirium, adverse events, length of stay to what was just discussed, discharge location, and mortality. The frailty index that the ISSG came up with was the first deformity and spine-specific frailty index. The way this was defined is at least 30 to 40 variables. This is how you select a frailty index in any setting. It has to be related to health status. The prevalence increases with age and doesn't saturate early. And it does cover a wide range of systems, in this case, systems that are specifically important to us as spine surgeons. And this is what it looked like. I borrowed this slide from Chris. I don't know what poor pre-med student had to design this for him, but ultimately this was how the 30 to 40 or the 40 adult spinal deformity frailty index categories were defined as the overlap of multiple pre-existing frailty indices and figuring out which one of those were specifically relevant for spine surgery. And as Corey mentioned, this was published in Neurosurgery Focus, and frailty, particularly when codifying it into different severities of frailty, does predict complications. And the importance, and this will ultimately get into how we're tailoring these strategies to the frail patients, but a frailty index does really need to be paired with an invasiveness score if you're looking to predict outcomes based upon frailty. And so the ISSG also worked on an invasiveness score based on their data set. And ultimately, when figuring out if the invasive score works or not, it has to be correlated with things that you would think of with invasiveness of surgery being increased blood loss, increased length of surgery, and then comparing that to some existing invasiveness scores like MIRSA. It did actually really pan out extremely well as far as being able to describe the surgical invasiveness of our operations. So in thinking of that with the background and under the mentorship of Chris, I was really interested in how this applied to minimally invasive spine surgery. And so we worked on this paper, again, John Burke, when he was our fellow, comparing open and MIS TLIF patients in both the frail and the non-frail categories. And what we found when looking at different outcome measures, the two that really panned out were discharge location other than home and revision surgery at 2 years. And what we found is that frail patients, if they underwent open TLIF, they had the frail patients did significantly worse in these two metrics compared to the non-frail patients. But if these patients were treated minimally invasively, it kind of leveled the playing field. So frail patient did just as well after this as, or you know, they did the same after minimally invasive TLIF with irregardless of whether they're frail or not, indicating that that may be an important application of minimally invasive spine surgery, particularly when treating frail patients. And so thinking about ways to apply this to the spinal deformity population was, to me, the next thing that made sense. And I love that we have Martin coming up to talk next, and we had a great talk by Coy yesterday about this. But just how we think about this in this, again, a case here, an 82-year-old male, multiple medical problems. He falls into the severely frail category. He has severe mechanical back pain, normal exam, and he does have both sagittal imbalance as well as coronal deformity. And multiple levels of stenosis contributing to his leg pain. And this is ultimately how we came up with our plan. So trying to apply as many of those principles that I discussed early from open surgery to a minimally invasive surgical strategy. Again, 2 surgeon models. So Alekos and I discuss all these cases and we do them together. Started with a stage 1 L2 to S1 OLIF. At L5-S1, a patient-specific ALIF cage, left lateral approach with the vascular surgeon using navigation. And then as a planned second stage, I'll show you some of the imaging. I get the thin cut CT in between stages, which helps with robotic pre-planning and custom rod designs. T10 to pelvis, minimally invasive fusion with some minimally invasive tubular decompressions to treat the radiculopathy, robotic screw planning and placement, patient-specific rods, and this is done through a midline incision, muscle-sparing screw and rod placement. I was lucky enough about a year and a half ago to spend some time in San Diego with Martin and learn that technique that's been really beneficial for me. Some benefits to doing in frail and obese patients and operating on them in the lateral position. You can see the abdominal contents migrate forward. This is a technique for the L5-S1 lateral ALIF in the lateral position. Incision planning anterior to the ASIS. And in planning your incision between this triangle that's described by these vertical lines. Ultimately, this does have some benefits. It's muscle splitting, possible less hernia, possible less pseudo hernia, wide exposure to the disc space with less peritoneal retraction, so perhaps minimizing ileus. And this is what the 5-1 custom implant looks like. So being able to take into consideration end plate anatomy, particularly in patients that may have bone density issues, as well as being able to target both foraminal height reconstruction and lordotic targets. And to some of the questions that have come earlier, there has been some research that's been done based on this. Chris has been involved in a lot of this. But looking at ability to treat successfully your target focal lordosis using patient-specific implants, whether it's ALIF, lateral, or TLIF, and this can be done with very, very high reproducibility. And this can be also translated more globally, looking at realigning and improving upon spinopelvic mismatch using patient-specific interbodies that can help you achieve these goals. And this is the third paper that was published upon this from the same group. This is what it looks like with that reconstruction. We've seen cases like this before. I do think it's important to get this CT scan in between. It helps with robot registration and planning. It does streamline that second stage and getting standing x-rays to see how close you've come. With custom rods, we can plan our corrections, we can plan our screws using robotics and that preoperative CT scan to facilitate correction and rod placement. And this can all be done before the surgery starts. This was kind of hot off the press, but we've looked at our series of patient-specific rods. Similar theme here when we looked at our series at UCSF, there was a significant decrease in rod-related mechanical complications when we use these custom rods. This is what it looks like. I'm working with Tony Makula, my past fellow from Mayo Clinic, and then doing the components of the case with Elecos, as you can see there. And similar concepts, intraoperative reconciliation, making sure that we hit our targets. And, potentially, I mean, these are costly surgeries, but we may be getting some cost savings on the back end. No ICU stay for this patient, no blood transfusions, went to rehab post-op day 7. And by 6 weeks, it's off all narcotics and is feeling better. So these are how I'm thinking about frail patients. I am going to rely or try to, if I can, to use some form of minimally invasive technique for these based on some of our work on frailty. Thank you very much. All right, I think, guys, let's get some coffee and we'll just in the sake of time, we'll go straight into cases, and then we'll get done in time for lunch.
So, first case is going to be a patient with thoracolumbar deformity with severe osteoporosis. We'll talk about ways to address the osteoporosis preoperatively. So this is a 75-year-old female retired pharmacist. She presents with back pain, difficulty standing upright, limited ability to do ADLs, and she's having escalating amounts of narcotics for back pain, and now she's on pretty high-dose MS-Contin. She has a history of known osteoporosis. She's currently on calcium and vitamin D, and she's had multiple fractures that are atraumatic in nature: metatarsal fracture, acetabular fracture, pubic ramus, proximal humerus. She also has hypertension and hypothyroidism on levothyroxine. You can see that she's had surgeries for the majority of her fractures and some non-fracture related surgery as well, Achilles tendon repair. And she's also had a bilateral oophorectomy. So this is her preoperative DEXA scan of both her spine and hip. If we look at the worst T-scores, you see the left femoral neck is negative 2.8, and you see the associated FRAX results and her risk of osteoporotic fracture. These are her radiographs. We won't belabor, that's not really the point of this session, but she has a pronounced thoracolumbar deformity with some instability and driving her disability. Her MRI demonstrated no significant neural compression. And we're looking at a CT scan using Hounsfield units. We see that the average here is 51. Anything really below 100 is no bueno. This is really bad. So plan. So I'll kick it to the group here. Maybe Roger, you want to start on, and I can go back to any of the previous slides.
Yeah, I'm happy to start. Yeah. Just so you're aware that we're seeing the cases for the first time, as are you. So we're trying to formulate a plan on the fly here. I would say that this patient has a very, very high risk for fracture. So independent of the surgical issues and the spine pathology and anticipatory interventions, her BMD levels with the DEXA, her history of fractures combined paint a picture of someone who's got a very, very high risk of fracture. And so if this patient's coming to me in clinic, I'm very concerned that she's going to have a fracture within the next year or two, an imminent risk of fracture. She meets criteria, as far as I'm concerned, for being aggressive, as aggressive as possible in the front end with respect to management. Now, as an endocrinologist and these patients that come in, they all get an evaluation just to make sure that they don't have a secondary osteoporosis concern diagnosis, because we do want to make sure everything that we can optimize is optimized in order to have the best response to therapy, in order to have the biggest fracture risk reduction. So there is a lab evaluation that was kind of standard for all patients that are going to come in which we're basically trying to check the boxes on various different conditions that could adversely affect bone health. And so this patient would get essentially our kind of a standard panel that we have that just reflexively on our referrals to the clinic, it states, have you done this, to try to expedite this process. And so we really want to get all those labs when they hit the door. And then we're essentially optimizing non-pharmacologic interventions while we're then presenting pharmacologic treatment options to the patient to decide, and working through what would be at times a laborious authorization process, as we are all familiar with. And then we try to optimize non-pharmacologic interventions for this patient. So that's optimizing calcium, optimizing vitamin D. There's really not necessarily a significant fracture risk reduction with those interventions, but it does paint or set this foundation for what we think will optimize the response to pharmacologic intervention. So it's important to just be mindful. Sometimes people think the calcium, vitamin D is somehow going to magically improve the bone mineral density significantly and reduce fracture risk significantly. It's really not that much of a reduction in fracture risk, but we do want to make sure that those are optimized in order to get the best response to therapy. That is my ideas.
Just a couple follow-up questions. And I think one, just from a really practical perspective, from a surgeon's perspective, if we were to see this patient in clinic and then refer to skeletal health, if you had like your perfect world as an endocrinologist, when would the surgery happen? After, to do everything as perfectly as you felt like you could?
Well, if the patient can afford to get, I would say, at least a year of therapy, I think you're going to see the really significant gains in bone strength and fracture risk reduction. So if that is possible, at least a year of therapy would be, in my mind, an optimal time to then consider an intervention. Now, keep in mind, in my mind, it's not necessarily clear whether there's going to be a significant change in surgical outcomes at this particular moment of where we stand with the publications. There's a lot of mixed results, and so I don't think it's necessarily definitive. You can certainly cherry pick different studies that would suggest that there's going to be a dramatic improvement, but then there's also a number of studies that may not show a difference. But if you want to have a situation in which the bones are significantly stronger and the fracture is significantly reduced, a year of therapy would be, in my mind, optimal, at least. Yeah.
And then what would be like the low end to where it wasn't like as if we had done nothing, but we at least made like a little bit of an improvement?
Again, that's a tough hypothetical. You don't see, if you look at from a fracture rate difference, you really don't see much of a separation in the first kind of 6 months. So if you imply from the response to osteoporosis medication, bone protective therapeutics, and looking at fracture risk reduction, you're going to start seeing that kind of separation in essentially in the first 6 months. And so the implication would be that there may not be a difference within the first 6 months. That said, certainly osteoanabolics are fairly immediately active, and so there may be some benefit within that window, but you really start seeing the separation about the 6 month mark.
Okay, Raj, if you saw this lady in your Seattle spine pathway, what would you think your evaluation of her would be? What would your group recommend?
I think a lot of the points that you've discussed, Elikos, are front and center. One is how are you going to optimize this patient to get to surgery? Surgery is really the only endpoint here with this type of deformity, and patient's pretty miserable with it. She's also quite educated. I think I read she's a retired pharmacist, so she knows what she's getting into. I like that Hounsfield unit picture that you showed where you circled. Was that UIV that you circled there? Was that lumbar spine?
Mid-lumbar, yeah.
So, part of it is getting her on the right pathway and having Bone Health living with you now for a year. That's a really great news. We did not have that in Seattle. We tried to employ. It wasn't even an endocrinologist. It was actually an APP that was working with an endocrinologist, but never happened. So we would actually refer to an endocrinologist and then wait. The problem that we saw in many of these was that the insurance wouldn't pay for the medication, even after they saw the endocrinologist. So we were looking at writing that up. I'm looking at Kellen, but we saw a high rate of rejection even after they went to the endocrinologist from the payers really. That being said, I think putting this patient on some type of a bone optimization pathway would be ideal. I didn't see any other were there any other red flags except for that?
Mainly it was the MS Contin, escalating narcotic doses.
Yeah. So, and did you calculate an MED level?
I did not. No.
So we've published a lot of work in that area too, about MED levels and what levels portend to patients not being happy. Some people have talked about getting that MED level down 50% and then operating. The data, science behind that's kind of soft, so you have to make that decision. We would refer patients above a certain MED criteria to the anesthesia pain service. They would manage the weaning protocol. They do all that. I don't know of any surgeons who would do that themselves, but if there are, is there anybody in the audience that would wean this patient from their narcotic themselves? No, right? You'd want some enhanced expertise for that, and so that's probably the next optimizable factor before going to surgery.
Definitely. To the MIS guys in the room, Martin, Aaron, what do you think about MIS reconstruction for this?
I think that, similar to what Coy was talking about yesterday, I see a, more or less de novo deformity. I think taking a harder look at CT scan to look at areas of potential autofusion would be important. But beyond that, I do think that the parts of this that are going to be challenging are not necessarily going to be not less challenging with open surgery. There's a lot of stuff that need to be navigated around in important fixation points. But I do think that she would be a candidate for a hybrid anterolateral and MIS approach posteriorly. Martin, what do you think?
Yeah, I think I would do the same. Provided her bone quality is optimized and all the other factors. For her, how I would see this, she's leaning onto her convexity. So, Peking University just came out with their new classification existed in braiding in 17, so she's at high risk for being malaligned. I think I would place interbodies at 4551, and if I don't level that out, I would actually just do a release. So since I'm there, I would release those disc spaces from the side, like probably how Manish would do, but not place interbodies, and then just do a mini open PCO at that area to realign.
Nice.
So, I think it utilizes all the skills. You get the benefits of an open exposure where you need it, and you leave the muscular envelope closed and moving on that. But I definitely think I'd still do a staging case for her, especially.
Does the degree of osteoporosis give you concern about the disc space, placing cages?
It does. I think for MIS, that's probably the greatest limitation, just because the risk of subsidence or flappings is much greater. because that's just what you have to leverage. I think because the interbodies too, you're lifting the bone. And for any patient who comes to see me, they always get a DEXA, look at their Pounds fields. And when they're on the cusp, I tell them about that. And it is still going to be tactile experience on how much you can lift or how much you just.
Yeah, Steve.
Distal fixation is such a big problem in this case. I mean, to build anything without having a strong foundation to the art. What are you guys' strategies working around these implants that are already in there?
Yeah. So I think Steve is bringing up a really key point. Is this an old suicide attempt or car accident or?
No, but he raises the question of whether that was the case because she has the acetabular fracture too.
Yeah.
But no, I think this is all insufficiency fractures, sacral fractures.
Really?
Yeah.
That acetabular reconstruction is from an insufficiency. I find that hard to believe.
Sorry, the sacral fracture.
The sacral fractures, yes.
But the acetabular fracture, that was from a car accident.
Car accident, yeah. I mean, I think Steve brings up a good point that when you have this amount of pelvic hardware and you're going to need a solid base of your construct, you're going to have to utilize some important strategies. I think this would be a navigation case for me. And I've used a number of them over the years, but for me, it would probably be either stealth or 7D or augmented reality. One of those three is what I would use for this. If you can't find a corridor, which I think is what you're alluding to potentially on the, I don't know what's left or right there, Lekos, but which side's the acetabular reconstruction? Is that left or right?
Right.
Right. On the right side, you might have to do only unilateral pelvic fixation. I've had to do those before, but obviously that pushes me more towards putting an ALIF at L5S1, either primarily or secondarily.
Mm-hmm. Okay. All right. Well, what we did was we sent her to a pain specialist to help wean down on the narcotics. I referred to endocrinology, and then we considered this operation in an open manner. So she saw an outside endocrinologist. Sorry, this is a little bit small font, but they summarized the DEXA scan, which you saw before. They stated that there was no steroid use, no hormone replacement therapy in the past, and no stones. And then she had been on alendronate and then stopped in 2019 because of some dental work and had not restarted. And she was on calcium. The dosing and vitamin D is shown there. Her BMI is on the low side, 20, and actually deep. I realized it's not on the panel, but not sure where he is. Anyways, so on the lower weight side, and Dan, if you want to comment on either optimization of the underweight. I know you talked about losing weight, but if you have any comments on how to help people gain weight, we'd love your thoughts as well. Yeah.
There are weight promoting medications like mirtazapine, but when we are trying to promote weight gain, we want to make sure it's done also through healthful things, focusing on protein and minimally processed carbohydrates. Carbohydrates are an easy way to gain weight, but you don't want to then induce diabetes or elevated A1C if you're not having a appropriate balance. But really getting a food log from a patient can help because most people just have their own sense of normal. So what I do is normal to me. What you do is normal to you. But for a patient who's underweight, they're so used to not eating much and their food cues and hunger signals are probably so low that you have to have guardrails. So at a bare minimum, have this number of protein shakes, but in an optimal setting, do X, Y, and Z.
Okay, great. And then this was the endocrinologist's plan, which is to restart Fosamax and continue with calcium and vitamin D. And then through some private discussions, communications, we asked them to start a bone building medication. So, Roger, what do you think about this?
This is not me as the endocrinologist.
No, this is not.
Yeah. I'm just
outside hospital, private practice endocrinologist.
Yeah. So the Fosamax therapy ended in 2019. So you've got it sounds like a 4 to 5 year basically a drug holiday. And so you're now in a time window when there's expected to be a pretty significant washout from the medication. So you can almost kind of envision there's somewhat naive bone because we're always concerned about how well you're going to respond to an anabolic in the setting of a prior antiresorptive, because you're going to blunt that response. And so the sooner that treatment is to that antiresorptive therapy, when it's bisphosphonate, keep in mind this is not the denosumab, but the bisphosphonate, you will not see the response as if it's a de novo patient. So it's important to keep that in mind. But I think there's enough time here that you're likely to see a pretty robust response to an osteoanabolic with that past history of the Fosamax. It's a little bit challenging in this case because I was looking at they were looking at the DEXA scans. They've changed different sites, so it's hard to know how this BMD has changed over time. You in order to make longitudinal comparisons, ideally the patients have the DEXA done at the exact same facility, honestly, the exact same machines, exact same tech, the exact same as much as you can reproduce in order to see these longitudinal changes and accurately report them with a test that has some built-in inaccuracies to it. But in situations where you have different scans, you can look at the T-scores to give you a sense, and so there is an implication that there has been a significant change in bone mineral density of the hip. You've gone from a T-score of the hip of -1.8 now to -2.5, and that's a pretty significant change. So it would suggest that there is some degree of active bone remodeling. There's some loss of bone mineral density, which in my mind sets the stage for a bone that's likely to be much more responsive to an osteoanabolic. And again, I'm a little biased in the setting that I'm sitting here towards leaning towards the osteoanabolics, but it is a patient that I think would respond really well. And I think that it's entirely reasonable. It really comes down to how you value that fracture history in gauging that fracture risk. And I think that there's more of this evolution of about thinking about that and really putting them into a category of this high risk category, and then you leveraging that basically fracture risk towards pushing for therapy. It's still, we get a lot of pushback. Even though I'm an endocrinologist, we get it denials, and it's an iterative process to try to work through it. But a lot of times we can justify with that history of fractures, and I think it's reasonable. I don't know if the question was about combining the two. Is that, or would you say adding it or switching?
I think it was a switch.
Switch, yeah, okay. Because and so I think she's a candidate that I think would respond really well based upon the information provided.
Okay. So soon after she started Tymlos, she started having abdominal pain and diarrhea. She thought this was food poisoning, and then she stopped it and then tried it again and had diarrhea again, and then also noted decreased urination. Is that a common side effect?
Some of it is. Some of them. I would say you can see this. You can see some nonspecific abdominal discomfort. Usually there's palpitations or orthostasis, dizziness, and the symptoms last a few hours after the injection, and then they seem to resolve. The nice thing about Tymlos is it comes in a delivery device in which you dial the dose up to the full dose, and as opposed to Forteo, which is basically get a full dose or not. And you basically pull the plunger out and you give the dose for Forteo, but Tymlos, you can dial it. And many times in situations like this, we have the patients pull back on the dose and actually try to titrate up just to build a little bit of a tolerance. And very, very often it's very successful. And so you can actually, just because of that first response is pretty dramatic, you just basically counsel through that and work towards just working your way up. And a lot of times that's successful. So I don't feel that this symptoms and these events necessarily preclude the continued use of Tymlos.
Okay.
And there is a difference between the two products. So sometimes there may be a different response to Forteo. So I would consider if for whatever reason, even with the dose titration, smallest dose still having issues, I think it's worthwhile to try Forteo to see whether there is a similar response and whether this is basically drug specific or within the class. And so I think that would be a reasonable next step.
Okay. Yep, and that's what happened. So they switched her to Forteo, and without any further side effects. And she took this for 3 months, and then we did surgery. These are her reconstructive post-operative films, and we were able to navigate actually dual iliac fixation on both sides. Amazingly, there were quarters in between those big screws, and we cement augmented the top. She had some proximal junctional kyphosis, but no frank failure. And she's about 2 years post-operatively. She has very little back pain. She's weaned off all of her preoperative MS Contin, and now only on ibuprofen and Tylenol is needed. She likes her posture. She gained 2 inches of height. I'm not sure how much weight she gained or lost, but I don't think it was significant. And as I said, the PJK was asymptomatic. So she's walking a mile per day, and she completed Forteo for a year. So I think the outcome so far has been relatively good. I wanted to ask you about the stopping of the Forteo. Is that a good idea?
I was going to say, is there another line that says that she switched over to something else? My concern is that in this situation, if the Forteo, if you stop within a year, you will lose any of the gains within a year. And
would you go back to a Fosamax?
Yeah, I would go back. I would go to some degree, you can also, if you, unfortunately, she's losing sites to really monitor her bone mineral density, which makes it a little bit challenging longitudinally following her. If there was a significant decrement that you're really trying to make up, you could argue for continuing therapy for a full 2 years and even adding additional osteoanabolics. But regardless of whether there's sequential osteoanabolics after that treatment's done, she needs a antiresorptive. And I would say, given the past use of alendronate that tolerated well, I think that's an appropriate option, or giving just a single infusion of reclass and just covering it for a year. But definitely needs an antiresorptive. Otherwise, you're gonna lose the gains.
All right, that's something for. Go ahead.
So I was going to say, it's interesting, with her gain in 2 inches, you probably dropped her BMI below 20. The plan you had mentioned a 3-to-1 AVA, but I see a 4-to-1. Happy with horizontal accident, or was it just a typical accident?
Yeah, good eye. We will definitely follow up on the Fosamax. Rosa, we need to make sure she's on. Yeah. So we did a 3-to-1. We only put structural cages at 4-to-1. This is going to Dr. Gupta's point of releasing a level. So in this case, I get concerned about fixing that obliquity with a cage at 3-4. She's a little bit listheased laterally at that level. So I'd like in these types of situations to put structural cages 4-to-1, horizontalize 4 to the sacrum, put just morcellized graft in, and BMP at 3-4. It loosens it up, and so it's easier to bring it around. So that's a common technique that I use for these types of deformities.
I mean, that's actually what I was referring to earlier in lateral.
Mm-hmm.
If 4 is not horizontalized, but since the patient's in lateral, I would essentially do that same thing and just release probably up to 1-2 because I can, and then just leave graft there.
Yeah.
Just so whenever it shifts back posteriorly, it'll also have a chance to do it.
Yeah. It's a nice technique. We didn't talk a lot about coronal plane deformities, but if we were to touch upon this lady's balanced. So the bow classification would be A, but if you look at Obaid, her trunk is starting to shift to the right, to the convexity. So this is the type of patient, if you straighten out that mid-lumbar curve with too many releases, make it a little bit more flexible than it already is, and the lumbosacral fractional curve is not corrected appropriately, she's go decompensate to the right. So a lot of the work for this needs to be at the lumbosacral fractional curve. Okay, well, thank you. Let's go on to our next case. And if we can bring up the slides. Rahul, you want to come up?
Morning, everyone. We have a complex topic, but probably relatively quick presentation because this case is still yet unresolved. But in context of what we talked about, we have a case of a patient who's then 75 when we saw them in clinic. They had a history of a T8 to S1 fusion that was done at an outside hospital. And the presenting complaint actually when they came to our clinic was that they'd had multiple months at this point of hardware protruding through multiple cutaneous defects, along with significant worsening back pain and inability to maintain upright posture. Patient's medical history, at least in terms of things that are listed, is not super remarkable, except for the fact that they have a low BMI, which we'll talk about. The surgical history is as you see up here. The patient underwent in 2021 a T12 to S1 fusion, which I think was complicated by early failure and fracture at the UIV of the fusion site of the fusion construct at T12. So they were taken back just a few months later for an extension and revision of that construct to T8. It sounds like they actually did quite well for a little bit of time immediately after this. They had good relief of their preoperative back pain, but sometime in early 2024, I should say, they had worsening of the back pain, and they started to notice the protrusion of the hardware through the cutaneous defect. They were initially seen in our clinic in November 2024. At that time, in addition to the pictures, which I'll show on the next slide, the patient weighed 85 pounds, which was down from a previous high of 130 at some point over the previous year or two, which corresponded to a BMI of 14. Apologize for the quality, but this is a picture that the patient themselves submitted through the patient portal to us of what their back looks like currently. And I'd say the picture tells you a lot, but there's actually rather a lot more going on if you look at these upright scoliosis x-rays. I don't have the images that were obtained kind of at the various intermediate steps before she had her previous surgeries to comment on kind of like to what extent this has progressed or what it looked like before we all started. But if you kind of look closely at the CT here anyway, you can see sort of the kyphotic apex is located at about T11, which is also approximately where you can see that there's a cutaneous defect, or at least where the screw heads are starting to protrude through the skin. Same is true here as well. So I think at this point, we did a couple of things, but it might not be a bad time to pause and see what members of the audience or the panel think about what we should do reconstructively or preemptively for this patient.
I've seen this case a couple of times in my career, unfortunately. BMI 14, profoundly malaligned, miserable. So I think there are three things that you have to think about. One is obviously this BMI of 14, and in a patient who's in chronic pain and not eating, how are you going to get that up, right? And so I mentioned earlier about putting in a peg tube and having that monitored and done for some time. I've done this 3 times where once the nutrition is optimized and we are ready to talk about a plan. Soft tissue coverage is going to be the most important thing, second step here. And so in the original operation that you do, once you get this nutrition situation fixed, is a debridement, because there is an infection. Spine is open to the outside world, so there will be an infection here. Debridement, and then a flap closure with a very good plastic surgeon who can then go back into the same flap. And so I work with the same guy for 20 years who's really good at this. And so he was able to open up a flap that he put in, and then doing your reconstruction at a 3rd stage. That's how I would tackle this.
Covered first,
Covered first, clean it out, let it heal. So that's, however, it might be lifelong antibiotics here, right? But at least a period of IV antibiotics followed by transition to some lifelong oral plan. Coverage, get it cleaned, get your CRP and everything normalized, and then come back and do the reconstruction. At that time, you're giving her a year of optimization. I think that's the best scenario for that. I mean, I have an N of 3 or 4 of something like this. But that's going to give you, I think, the best long-term plan. Now, if that's not possible, you could do your I&D, your reconstruction, and your coverage all at the same time. That's hard, though, in a patient who's very frail and who may not tolerate all of that.
Raj, what do you think? I mean, to me, one of the big considerations here is antibiotics lifelong or not. And so if you're you're going into it kind of like no matter what, she's on lifelong antibiotics, then to me that kind of pushes me more towards just let's just get this all fixed all at once because she's going to be on lifelong antibiotics anyways. Do you see that side of things or not as much?
I think, Aaron, I think that's a very reasonable thing to do, right? And it really depends on your plastics team and how they want to approach this. I think it's very reasonable to do it that way. I think the challenge is going to be, BMI of 14. We were talking about 17 and 18 before and rolling our eyes at that. BMI of 14. That's a tough position. And how are you going to, get this poor lady to at least an 18 or 19 or 20? That may take a year or longer. Now, again, if you just put a feeding tube in this woman, send her home, a nasogastric feeding tube, I mean, that's not going to work, right? I mean, because you're talking about months and months and months. So I think the more staging you can do here, the more you can kind of monitor her and get her to a point where, if this patient came and saw me, I would, and I've had patients come from Alaska and crazy places with these problems where I say, look, we're starting a 2-year journey here, right? And so some of that is also, do they have, no pun intended, skin in the game here? Because this is a really, really challenging thing to deal with. Manish, what are your thoughts? I'd love to hear your thoughts, and Steve also.
I think the best thing to do for her to get the implants out and decrease the infection burden. So remove everything, clean it all out, and then get some sort of soft tissue cover. And PEG tube is absolutely, I agree with you completely. And once you get the healing of the soft tissue infection burden under control, then go reconstruct. What's going to kill her is sepsis, If you don't do anything, it's going to just get worse, and they get worse. So the first thing is to get the infection burden off, remove instrumentation, get nutrition and closure of the wound. The back pain is not going to kill her. So that's number one. And then number two, once the CRP set rate, like you said, are normalized, the nutrition is better, they've gained weight, then you can reconstruct it at a second stage. But that's like further down the line. I would not reconstruct at this time because what's going to happen is the same bacteria are going to find these metal and their biofilm, and they're going to have a party. So once it's infected, it's always infected in my book. There's some literature now, when you look at the histology and electron microscopy, the bacteria are in those lacunae. And once the immune system goes down or whatever, they come out again. So I think once you're infected, you're always infected.
Manish, before you comment, Steve, I'm also interested to know, I have one patient like this about 10 years ago where I actually discussed end-of-life care with her. So if she's 75 and she's had 8 spine surgeries and she comes to you like this and she's unwilling to do, I agree with Manish 100% on the plan, and it's a long plan. It's an 18-month to 2-year plan. If she's unwilling to do that and she's at the end of her road, I think supporting end-of-life care is very, very important. It's a humane thing to do for somebody like this. And I think you have to discuss that also.
I would say as a general internist, the fact that she lost that much weight in a year is a sign that end-of-life care is a really good thing to bring up early on. Like that person has basically given up on everything if they've lost that amount of weight that quickly.
Do Manish or Raj, do you guys have any concerns about stability of the spine with, an extended period of time without hardware? I had one patient where I did that and they came in and their spine completely fall apart.
That's there's 2 options in that scenario. The first option is clean it up and let it be and put them in a brace. The second option is, what I have done is I've taken everything out and put very minimal titanium implants just to kind of give some stability, like top to bottom, not screw in every hole, and that has helped me. But there are people that will come back with recurrent deformity. So there's no, those old days of Harrington fusions are gone. When they had Harrington fusions, they were really robust fusions. Now these fusions are stress shielded and they're wispy. They're not as good. So they will fall apart. But you have to watch out for that. But ideally, it would be no metal, and then once everything is healed, you put metal. But there are cases where you have to go in and put temporarily some titanium. Don't put anything else but titanium. It's a little bit more resistant to bacteria, biofilm. So I would do that temporarily to tie her over. And it's not as prominent, because if you go way up top and way on the bottom, the kyphotic part is like not prominent. So then you can come back with a third reconstruction.
Steve, let's ask you.
Yeah, I agree with Manish. The only, I take everything out and just like he did. And then coverage is the biggest problem here, which needs to be addressed. By the time you finish debriding and things, you're not going to have coverage on this. And so I definitely, this one would have a VAC treatment with me and a plastic surgery assessment. And then when I can get it mobilized or closed up, then it may take a few surgeries to get to that stage. And then consider a Jewett brace after for a little bit until we can get things under control. Because if you're not going to have coverage, you're not going to be able to go back again either. So.
With that amount of soft tissue loss, you guys, do you think even with long-term nutritional supplementation and a good plastic surgeon, is that going to be enough? Or is there a situation where even then you've got to do something more?
I think that this one is tough, and I agree with you. At a BMI of 14 and in this situation, I still think, and I really want to echo what Steve and Manish said, even if you can get this wound cleaned, right, and get coverage, and let's say this patient is, I didn't ask you the ambulation status of this patient. How much is she doing at this point?
I don't actually remember, but I think she was capable of it.
So, again, if this is a wheelchair-bound patient already, and you could just get her cleaned out and get her covered and get her on a nutrition plan, you've still won. Even if you didn't do a big reconstruction afterwards. I just think you have to prepare this person for the length of treatment way up front. They may have waited to see you for 6 months, and they came from a rural location somewhere, and they think I'm going to go see Dr. Clark. He's a miracle worker. I've been waiting for 6 months to see him, and he's going to fix me. I think expectation management here is really huge. And then, if you hit a stop point in your treatment, you take the implants out, you debride it thoroughly, you get her flapped, and then, she's either not following up properly, or you got to send her back to the medical deserts. This is a complex thing. I don't know if they have medical deserts in Canada, Steve, but we have medical deserts in the United States. You go 30 miles east of Seattle, Washington, you're in a medical desert, right? So I don't know where you're sending her back to. Right? This patient probably doesn't live in San Francisco. So you got to think about all that stuff.
One thing I wanted to bring up is the social network. So the social backup for this patient is already big time failed. So I would never see this patient alone. I would require them to bring family members or friends, because it's the only way you're going to get her out of this. If she's already shown that she's failed miserably in her social situation, personal situation, she needs a lot of help. So that's very important. That's going to determine your success or failure.
You can't make up for love with titanium. All you young surgeons, listen to that. You cannot make up what Dr. Gupta just said. You cannot make up for love with titanium. So if you don't assess this stuff when they come to see you, you can do the most beautiful reconstruction and show the greatest X-rays at 1 week, but will that actually heal and work in the long term? The answer is probably no.
Question for Roger. Any contraindications starting bone or medication in the segment infection?
I'm not aware of any contraindication in that with respect to that situation. That said, I have no expectation that she would respond with this nutritional state. I mean, yeah, an anabolic therapy requires an adequate nutritional, foundation to build upon. You're laying down new tissue, and so I think it would be likely on people's minds to try to help the situation, but unfortunately, I think it's just going to be a wasted effort until a lot of these aspects are dealt with. But in and of itself, the infection shouldn't be an issue. But that said, in the setting of infection, you're likely blunting that response because efforts are being directed elsewhere.
If you were, when you reconstruct her, how do you reconstruct her levels? Do you deep the pelvis? Do you do any shortening operation to help?
I would do a shortening osteotomy at the apex of the kyphosis. Yeah, I would have to look at what the fusion looks like at the top there. If she's got a robust fusion mass at the mass at the top, I am not going above that. I'm stopping in that robust fusion mass and shortening the spine through the apex there. That's it. Manish, agree? Steve?
So I think one thing is not very clear for this, but there's a telltale sign that her right leg is short. And that's contributing to a lot of the coronal deformity. So you have to take that into account when you do the reconstruction. So, but I agree with Rajiv, less is more. Get her lined up and get her like stabilized, because otherwise she's, if they stop walking, they stop eating, they start dying.
So as I alluded to at the beginning, this is still a yet unresolved non-surgical case, but we did a couple of things. The patient was seen by a plastic surgeon with whom we collaborate rather frequently at UCSF, and we talked about a couple of options for soft tissue coverage, including a free flap, which didn't seem reasonable for a variety of reasons, including the fact that the patient would have to offload for a long time after surgery, versus local advancements. They also were able to see nutrition outpatient, so to everybody's comments about a G-tube and various options for enteral nutrition, they were actually able to implement essentially like a high protein, high calorie plan just by mouth. And to some of the points that were raised earlier today, it should be noted that this very obviously nutritionally deficient patient who would be pan positive in any screen actually has an albumin above 4 and a prealbumin above 20 at baseline. But nevertheless, I didn't write down the exact number, but have gained at least like 15 or 20 pounds over the course of 1 year of nutritional supplementation. So yeah. Here we go, 20 pounds to BMI of almost 18. And sorry, didn't mean to go through all of that, but this is our proposed plan with, as commented, partial VCR at T11.
So question for you. So the wound is still open?
Correct.
So this was never debrided and preliminarily flapped. It's still open to...
We were planning on having her gain weight first before trying
Yeah.
soft tissue construction. Because the plastic surgeon was concerned with the current state.
Yeah, you may want to let us do some debridement and wound coverage first, and then do this, and maybe you can get her from a BMI of 18 to 22, right? I mean, you've shown that's just with oral, right? You've already shown some success. She's not septic or sick from this, from this open wound, so you have time. Consider that, but I think your plan is otherwise going well.
I don't know, actually.
Yeah, we're going to skip the last case.
Okay.
Sorry. Let's break the watch. Thank you.
All right. We're going to finish up our last session with a very important topic, more on complex sacral pathology, and I have the honor of presenting my colleague, the person who I can actually credit for bringing me back to UCSF, Sig Bervin. He's going to be talking about problems with stopping at S1 and long thoracolumbar constructs, lumbosacral non-unions, and sacral fractures. So get ready to be wowed.
Thank you, Lucas. Yeah, it is an important topic. This section on complex lumbosacral pathology, I think, is really the foundation, literally, of complex deformity. These are my disclosures. I don't think they'll be relevant here. But when we think about challenges in adult spinal deformity surgery, in general, we talked yesterday quite a lot about alignment, choosing levels, UIV, LIV. Complications are certainly really important, especially junctional, which we're going to talk about now. And then the question, when can we do less? When should we do more? And that's fundamental to our value-based care. And I think sometimes doing less really is going to be a better solution. So again, just think about any case, the first, if we're going to be operative, how high, how low, and what type of technique, when to go front and back. And there's no area of medicine, I think, that's characterized by more variation than the approaches to spinal deformity. And to some extent, having this interdisciplinary group together, I think gives us a great opportunity as a community of physicians who take care of disorders to learn from each other. So the overview of what I'm going to spend these 15 minutes on is, first of all, my strong preference is to fuse to the mobile lumbar spine. So my strong preference, when possible, is to avoid fusing to the sacrum. Having said that, in adult symptomatic deformity, most commonly there's symptomatic deformity involved in the lumbar sacral junction. So it's unusual that we're able to stop in a mobile lumbar spine. Certainly in the adolescent and the growing spine, that's characteristic. Patient with primarily thoracic deformity, that's characteristic. But my strong preference, even in the adults, is to leave mobile segments. The challenge of the lumbar sacral junction is basically can be summarized by the quality of the bone and the fact that there's high strains on the S1 screw. And if we think about any metric of biomechanics, think about what we're trying to do with augmentary techniques is to actually reduce strain on the S1 screws and get a solid fusion at L5-S1. We'll talk a bit about the role of anterior column support, and Chuck Eichler is going to talk about some challenges there, and I think Manish is going to address the anterior column as well. And with regard to pelvic fixation, how many points of fixation and when do we use it? And I'll tell you about scenarios both in degenerative as well as deformity where I use pelvic fixation pretty routinely. So again, in terms of broad categories of deformity, the junctions are hazardous. Cervical thoracic, we heard about a little bit yesterday. Thoracolumbar, we heard about a lot in terms of PJK things. And again, we're focused now on the lumbar sacral hazards. And when we think about the modes of failure, in general, there could be symptomatic degeneration below a fusion that stops above the sacrum, non-unions or screw loosening at L5-S1, loss of correction, and then finally implant failure, which is a mode of failure that we see most commonly going to the pelvis. So I want to start with the case of when can we avoid going to the pelvis? What's the case for stopping short of the pelvis? There's some evidence, weak though, that we might have better function, less complications, good survival of the L5-S1 segment. I'll show you some work that Ganesh Swami did when he was a fellow. And leaving the option open for new technologies, maybe even motion-preserving technologies at L5-S1 if we stop short of the sacrum. With regard to function, this is a paper that came out of the Spanish group. Ferran Pellicer was part of this. But looking at patients fused to the thoracolumbar junction with an LIV, thoracolumbar L3 versus lower sacrum, or L4 to S1. And in general, the longer the fusion, the less mobility, worse SRS scores, more spinal pain. So there is some evidence to suggest that fusing short of the sacrum may make a difference. This is a paper, again, that Ganesh Swami, who's now Fred's partner out in Calgary. We wrote about some of the advantages of stopping L5. We maintained lumbar sacral motion, decreased the operative morbidity, and decreased complication rates, including revision surgery, rod failure, and infection. There was no clear functional advantage that we were able to demonstrate, but having said that, the survival of the 5-1 disc in this series was about 70% at 10 years, and this is the Kaplan-Meier curve that we came up with. This is a classic paper that was matched cohort analysis. Actually, when I was a fellow, this paper came out. Charles Edwards and the group at St. Louis, Larry Lenke, comparing fusion L5 versus S1. And this is where I've talked for a long time about the L5-S1 paradox, right? Is that when we're fusing L5, the fate of the L5-S1 disc isn't necessarily good. And they showed about 61% of these cases developed advanced degeneration. And when people developed advanced degeneration, they lost their sagittal alignment and they had worse scores. About 18% actually lost fixation in L5. But the paradox is that stopping at S1 had more rod failures, more infections, and a higher revision surgery rate and more complications. So again, there's not a clear right versus wrong. This is a nice multi-center retrospective study that came out of the ISSG, some of the ISSG sites. First of all, propensity matching, because it tends to be a very different population who you stop at 5 versus 1. It tends to be older people, more severe deformity when you go to 1. But propensity matching, stopping at L5 at less PJK, less OR time, but they didn't show a big difference in other outcomes, including revision surgery. This is a nice meta-analysis that included 11 studies, over 1,200 patients. Stopping L5, less non-union, less PJK. Again, the number one risk factor for PJK, fusion into sacrum, lower implant complications. There were some advantages to going S1, that if you really need to restore lumbar sacral lordosis and overall alignment, there's less loss of correction and better restoration of alignment when you go to S1. And interesting, again, no difference in function or pain was shown in this meta-analysis. A lot of times when we're thinking about stopping and shorter the sacrum, we got to really identify where pain's coming from. The MRI and CT scan can be useful for here. Sometimes dynamic imaging to look for any instability, and sometimes even some provocative evaluation with facet blocks or even discography, which we don't tend to use now, but evaluation of where pain's coming from. Here's a case that was fused at another hospital. You see the patients in significant malalignments. They had a double major deformity. Typically, the thoracolumbar curve is more flexible than the thoracic curve, and you see how they're fused in a coronal and sagittal malalignment, junctional kyphosis above T6, and clear malalignment. And this is one, she was, I believe she was, 48 years old or so at the time of the surgery, and she was very interested in surfing and water skiing, and after the surgery, she had lost the ability to do all of that. So one of the things I want to do, we actually talked about sexual function as well, which may be compromised with long fusions to the pelvis. And what we ended up doing for her, and I'll just show you pre-op versus post-op, is I actually did a asymmetric PSO at L3, but the bottom line is I kept the fusion to L5, so I avoided going to sacrum. It's so often, or so rare, that we can avoid stopping at 5-1, but I realigned her without going down to the pelvis. And that can be a little tricky, but the bottom line is she got back to snowboarding, surfing, and water skiing was actually her big thing. Here's another patient, a 56-year-old male. He got injured in college. He went to school in Maine and flipped backwards over a balcony drinking beers and had a conus injury when he was in college. But very functional, hiking, camping, gardening, and he does a lot of four-wheeling. So he's got this pickup truck that comes up to my chest to get into. And so mobility at the lumbar sacral junction is important for him. Presents with progressive neurogenic claudication. You can see he's got junctional stenosis, both at L3, 4, and at 4, 5. There's the MRI scan showing the stenosis. So again, this is somebody who I tried to stop short of the sacrum. Went down to L5, so did direct laterals or anisosas approaches at 3, 4, 4, 5. Stopped him at L5. Did well for a while, got back to four-wheeling, got back to being quite active, but unfortunately, within about a year of that, progressive degeneration of 5-1, some loss of sagittal alignment, lumbar sacral pain, and I ended up taking him down to the pelvis with the front and back. Now part of the solution, that helps his lumbar sacral pain. You can see the type of four-rod construct I typically use in that construct down. So failures of fixation of L5, we all recognize, and there's any number of examples. So when do we have to fuse down to the sacrum? Well, number one is we recognize symptomatic degeneration of 5-1. Spondylolisthesis, I think, is an indication to include the sacrum. Symptomatic stenosis. When we need to get a major sagittal plane realignment, stopping at L5 can be difficult. Patient with bone quality of insufficiency, stopping at L5 is challenging. Certainly when there's fixed obliquity, I think going to the pelvis is a lot easier to correct the coronal plane. And neuromuscular disorders. These are all where I really tend to go to the sacrum. But it can be a very slippery slope, because once we go to the sacrum, that's where we're really opening up the door to even more complications. Why? Well, it's got a lot to do with the poor bone quality of the sacrum. It's got a lot to do with the loss of compensation that we might get at the lumbar sacral junction. Some of the things that I think are well proven, trying to get tricortical fixation of your S1 screws. So I tend to do these I do most of my screws freehand, but I'll actually use fluoroscopy to really get the screw right up into the intersection between the end plate and the anterior cortex, and I'll use screws that go right through that anterior cortex. And the insertional torque, you can really tell when you go through that anterior cortex. This is an important study to have in mind is Brian Cunningham took a look at what is a long fusion to the sacrum. And that the strains in the S1 screw, when you're at L3 or higher, that significantly increases the strain on the S1 screws. And specifically what he showed is using an ALIF, well, that'll reduce the strain on S1 by about 30 or 40%. But we think that a strain on S1 is why we get screw loosening and why we get loss of fixation non-unions. Reducing strain is why we use pelvic fixation. And the power of pelvic fixation actually reduces strain by up to 300%. So that's dramatically better than circumferential alone. And again, this is what we want to avoid, just kind of haloing around our S1 screws without pelvic fixation. And that's something we see too commonly in patients who don't have pelvic fixation. I think the other classic study besides Cunningham and McAfee study is this study by McCord, where he actually used bovine specimens, and it was more of a biomechanical study. But the take-home message of this is to recognize that we want to get our fixation as anterior and as lateral as we can. That's what reduces strain on the S1 screws. And in terms of how do we get that fixation, how many people have put in a Galveston screw, Galveston fixation, right? So bending that's using a unit rod or trying to bend in Galveston screws, that can be really challenging. So the evolution to iliac bolts and then sacroiliac fixation, that evolution has been significant. We actually looked at Galveston versus iliac screws and showed that the failure rate was a lot better with iliac screws than with Galveston. But still 20% of these patients required a revision because their iliac screws were prominent. This is a technique we used to use, get rid of PSIS, rongeur down, and try and get as medial as you can. But oftentimes these screws, especially the older screws from that study, were symptomatic. So I think a lot of us now are using the sacroiliac iliac technique. This was really described by Sponseller and Kabash and a group at Hopkins. And looking at this in a meta-analysis, some significant advantages of sacroiliac iliac screws over traditional iliac screws, both in terms of infection rates, where 25% of the iliac screw group had infections compared to only 2.5% of the S2AI screws. Need for revision surgery due to screw prominence and overall revision rates were all better with the S2AI screws. That meta-analysis, I think, was pretty compelling. And this is sort of the evolution of techniques that I've used over the course of my career, from Galveston to offset iliac screws to S2AI screws. And now you'll see a lot of these constructs are going to involve multiple points of pelvic fixation. So let me get to the issue of when to use pelvic fixation in spine fusions to the sacrum. And an overall summary, if you want to take a picture of this slide, this might be the most useful. Long fusions, the long fusions above L3 down to the sacrum. In shorter fusions, I often use pelvic fixation, including patients with osteoporosis, established pseudoarthrosis, high pelvic incidence, a high-grade spondy. And the interesting thing that we're recognizing, I think, more now is maybe people who have recognized SI joint pain before surgery. So a couple examples. 84-year-old who years ago had a fusion T12 to S1, no pelvic fixation, progression, loss of alignment, progressive pain, progressive weakness, actually. You see the sagittal malalignment, the haloing around the S1 screws, no inner body at L5 S1, no pelvic fixation. So this is one that I revised front and back, and even though she was 87 with a lot of comorbidities, got her realigned. What about in shorter fusions? I think this is a great paper that came out of the group at Cedars, looking at essentially sacral slope, but that's sort of a proxy for pelvic incidence. But recognizing that a patient with a high sacral slope, high pelvic incidence, a lot more strain on S1. And those are instances where, for example, a dysplastic spondy, 17-year-old with a dysplastic spondy, high pelvic incidence, routinely I'm going to be using pelvic fixation on these, not stopping at S1. Here's a patient with metastatic breast cancer. I'd actually done a T2 corpectomy on her a few years before. She developed symptomatic degenerative changes at 4-to-1. Osteopenic, not osteoporotic, did a 3-to-1 fusion front and back. So there's a 3-to-1 circumferentially. And she came back for her 4-week visit. And at the time, the fellow with me, I remember this very distinctly, said, Well, she's doing okay. She's got some pain in the lumbar sacral area, and I was thinking that seems really unusual. That's most of the time these patients got a dramatic improvement in their pain. These were X-rays, and if you actually look closely, and you see it on a CT scan, she's got an insufficiency fracture. So even though it's a relatively short construct and circumferentially fused, she's got an insufficiency fracture below the S1 screw. So I revised that. This was a while ago with 2 points of pelvic fixation. What's the evidence that pelvic fixation fails often? Well, comparing iliac screws and sacroiliac screws, this is an ISSG paper that showed 23% of the time sacroiliac screws are either breaking or loosening or painful. And so we could do better than that. Here's an example of a case of mine, and I didn't talk today because I don't have enough time, but 1 screw versus 2 screw is historically, if people were well aligned, I'd use 1 screw at the lumbar sacral junction. We did some biomechanics on this. This is a patient who 2 years after my surgery ended up with a non-union thoracolumbar junction. But what was interesting was all of her pain was at the lumbar sacral area. So when I revised her, and that's a SPECT scan, when I revised her, I actually revised her down to the pelvis and augmented this with triangular osteosynthesis devices to actually fuse across the SI joint. And that is the definition, that is the background of the Sylvia study. So is there an advantage? And this is important to understand. Smooth screws with or without a triangular osteosynthesis device. The important conclusions here to summarize is that the primary outcome was the new onset of SI joint pain. There was significantly less SI joint pain. That's something I probably under-recognized, but there was less SI joint pain. Importantly, there wasn't a big difference in patient-reported outcomes or in revision surgery. And that brings up the next question of, well, what about using a screw that's going to fuse the SI joint? And that's the next round of this clinical trial. And we don't have any data from that yet. But what about fusing the sacroiliac joint? Does that help us more than the Sylvia type technique? I'm going to wrap up just with, I think, one more case. Here's a patient, 67 years old. Turned out that she had hypophosphatasia, and I think Roger's gone, but DEXA score is minus 3.4, presents with sagittal and coronal malalignment. This was her pain diagram. Preoperative optimization was quite interesting for hypophosphatasia, but I won't go into that much. But this was her realignment, and this is more typically what I'm doing now, is 4-rod constructs with 2 points of pelvic fixation on each side. So S2AI screw and an iliac screw to get that realigned and robust on both sides. Last case is a Charcot spine, maybe one of the most challenging pelvic fixation cases. 40-year-old, had a thoracolumbar injury, prior fusion down to, I think, L2, and down L2, 2-3, complete dissociation, Charcot spine, very challenging biomechanically. And this is one, again, I repaired with a 4-rod construct. So 2 S2AI screws, 2 iliac screws, 4 rods. So in conclusion, I think that fixation in the lumbar sacral junction is challenging. And I think it's really important to get this right because this is where we see a lot of failures in reconstructive surgery. Think about strategies to reduce strain on the S1 screws. Anterior column support is one of them, and good pelvic fixation anterior to the osteoligamentous complex is important. Supplementary SI joint fusion really remains to be proven. I think the Sylvia study suggested that there's less SI joint pain, but more work needs to be done for the role of more robust screws and actually fusing that with 4 points of fixation. So thanks for allowing me to set that off, and I don't know if we have time for questions. We'll take questions at the end. Sure. Any questions? Yeah, Rich.
So, in 2025, almost going into 2026, is there any role for stopping at S1 long segment fusions that are L2 and above?
Yeah, I really don't see it an advantage to stop in S1. I think L2 and above, L3 and above, there's too much strain on that screw. And even with the circumferential fusion, even in a younger person, in a young female for a high-grade spondy, for example, I think about maybe putting in iliac screws instead of ST2AI screws to not actually fuse the SI joint and maybe even take them out down the road. Those are the sort of things I think about. But I don't see an advantage in the adult with deformity to not going to the pelvis. even with the circumferential fusion, even with the patient who's well aligned. Yeah. I think we got some more talks on the topic or questions.
Your preference on S2AI and iliac, are you using combined on both? Right?
When I use 4 rods, I'll use S2AI and iliac. I tend to really bury that iliac screw, so it's a really medial start point, so they're kind of almost parallel. But when I use 4 rods, I'll tend to have 2 points on each side. If I'm just using 2 rods, which I'll often do, and I look forward to our SMART study, but with 2 rods, I just use S2AI screws because of the advantage that meta-analysis showed.
Perspective, you have seen instrumentation stop at S1 and the failures distally. Pelvic fixation prevents that, but it may transmit the stresses proximally.
Yeah.
What do you think's worse for the patient from a revision standpoint? Do you think a distal failure is worse or a PJK?
Yeah, really important question. You know, one of the things that Keith Bridwell used to say, and you and me certainly know this, is he said, I'd rather have a rod break than a screw loosen, which is sort of an interesting paradox, an interesting trade-off. So if we had to choose between a failure of pelvic fixation versus a junctional problem, in general, why I'd say, let me stop at L5 is if I've only got a revision rate of 30% at 10 years, I'll stop at L5 because going down to the pelvis isn't that big of a deal. Having said that, I think, junctional problems tend to predispose to more junctional problems. So if I had the choice, the one thing I'd want to avoid, and I think Raj was alluding to this and stopping it at without iliac screws, is I want to avoid that sacral insufficiency fracture with a deformity. That's, and you're going to see one of my cases soon one that I revised with an S1 osteotomy, but you'll see one of those soon, and that's a tough problem. That can be a really tough problem.
It's an interesting question too, because by avoiding one, it may not necessarily be a logical one or the other, because once you fix to the pelvis, I wonder if then they'll just have the PJK risk moving forward right afterwards. So they could just end up having both in that way too.
I find once they're stable and the fusion's stable, even
At the
if
top?
on the bottom, I find I don't get the same PJK.
Really? Okay.
And the primary I would, but as a revision I often don't.
That's interesting.
Yeah, and the other thing about that is not actually dissecting all the way to that thoracolumbar junction, so leaving that soft tissue envelope as intact as you can, so just doing the work down below L3.
Yeah.
That's great. Well, thanks. Thanks for letting me lead that off.
Okay, so the next talk will be given by Martin Pham on posterior open and MIS lumbopelvic options, past and present. We got a little introduction to the open or the options, and love to hear the comparison between the two.
All right, perfect. Well, again, I appreciate the opportunity to come and speak on this topic. Again, to be included in such phenomenal faculty over the past 2 days. So again, what I'll be talking about is open and MIS pelvic fixation. Here are my disclosures, not really relevant, although I do discuss the robotic systems of which some of these companies are represented. Now, I remember when I was a resident being so excited to put in a pelvic screw, right? It's like the largest screw you can put in the spine, and it's such a important thing. And it's because usually if I was in a case as a resident putting a pelvic screw, it meant that we weren't just doing something small, we were doing something large and complex, right? And essentially, this is the whole purpose of this course, techniques in complex surgery. And I was able to dig back into my time as a resident and actually find some of the x-rays that I participated in, right? So of course, a T10 of pelvis or sacrectomy. Here was actually a spinal pelvic dissociation for L4 to pelvis. And in all of these, naturally, as complex cases, we had to do something strong at the bottom. Now, I know that Lee has already left, but when I think of strong, I think of Lee because he has just an absurdly strong bicep on that side. And it's just, no matter what we did, we just cannot. So really, if I were to modify this, it's, he must have like a dozen pelvic screws in there if we're thinking about how strong things are. So, for this, we're talking about pelvic fixation. There's lots of ways we can do it. Open. We can also do it MIS, and then in very niche circumstances,
Now, leveraging technologies, we can use this in single position lateral. So for the folks who do lateral surgery and you're just doing, lateral cages and you're going to flip prone, with technology, we can actually put this in single position lateral. So that's, something that we'll discuss here. So as an overview, why it matters, which Sig did a great, deep dive into how to place it, what it can look like. So why it matters. Again, indications, most people in here would agree that, to put pelvic fixation, we're doing long spinal fusion to the sacrum L2 or L3 and higher, adult deformity, including 5-1, so now to protect that S1 screw, high-grade spondy, so now we're talking about people, as Sig had mentioned, with high PIs, with a lot of shear stress there, or if there's some issue with the sacrum, right? So sacral fracture or sacrectomy. And again, there's a lot of ways to do that. Traditional iliac screws, S2 alar iliac screws, S1 AI screws have been discussed as bailout options. So that's always an option, although not typically done up front. And, as Sig went through, there's a lot of data that shows that S2 screws probably as a primary choice are a bit better than iliac screws. If you're just putting 2 screws total, 1 on either side. And so when we go into how to do it, right, 3 main ways. The first is freehand. So freehand or use of fluoro. This is actually a video of me with Larry Lenke when I was his fellow in 2018, and we would freehand all these, right? So you identify the starting point, right lateral and distal to S1, create that burr, you drive the gear shift in 50, right, across the SI joint, turn around, and then drive it into the ilium. And so we would do this every day because he operated 4 days a week. And he was very good at it and very efficient at it. And naturally, if you do a lot of these and you do them freehand, then it becomes very efficient. But the problems come when you miss. You have to go back and you troubleshoot. So I think many people in the room would agree that navigation is also another good option. And this was a video I published as a resident back in 2016. But it shows, right, so same thing, that starting point, usually just distal to S1. And then with nav, then you create that starting point. And then you find that hole, and then you tap, right, all the way across the SI joint. And then once you have that path, then you can put in your screw under navigation. And again, the benefits, of course, are 1, it's highly reliable, or it's highly predictable. And then you can put in your screw and then move on with the rest of the surgery, right? Because the surgery is not putting in the implants, like that's important, but it's the osteotomy and it's your correction. And you don't have to use up a lot of time troubleshooting. Now, last is going to be robotics. So this was a video we published back in 2020, a revision case, actually from a single iliac screw from a long segment correction that the patient had prior. And this was also presented as a part of the case-based approach for a robotic supplement. But in general, all robotic systems have planning software. So now you can plan your quad S2 screws, so 2 S2 screws on each side. You can make sure it lines up with the prior instrumentation. And then now we talk about being highly reliable and something that's very predictable. And you can see here with the robot guidance, I put in those screws, 2 on either side, and it becomes very easy, no different than putting in any other screw within the spine. And this also becomes, again, very predictable and reliable. And when you think about this particular case, this is what I was trying to avoid, right? So that was the iliac path that I'd haloed out, and certainly could have done this with a nav. I certainly wouldn't have been able to do this with freehand, but with robotics, and you can plan this now, like 10 out of 10, it would hit this every time. So the ability now to really put that screw wherever you want it really makes the day a bit easier as you move on with the rest of the surgery. So, moving on to cases, and this is sort of the meat of the talk, on tips and tricks. So for open surgery, I think as we've discussed, like there are situations where you have 2 iliac screws total. I think many of us now would do 4 iliac screws total, but there are sometimes situations where you need 6. And this is the case that I'll go over a bit into a deeper dive, which is this patient here had a prior T12 to S1, transitional S1 segment, and that completely haloed out. So my solution for him was an S1 PSO. Now to do S1, you need 6 iliac fixation points total. And so this is an example. This is not this case, but it is an example of how you can plan 2 S2 screws just stacked right on top of each other. And again, nav is really no different, but here I'm in the comfort of my home or office, and I get to plan exactly where these go. You can see in all different planes, I put in the first S2 screw. I avoid that path, as you saw in the CT scan. And then once I'm happy with this first screw, I drop the second one just below it, and then it just goes in parallel, right? So now I match it, and then just like you would on a post-op CT, I scroll through it, and I make sure that I'm happy with where that screw is going to end up, because it's going to be quite accurate on where it goes with the robot guidance. Now, with the prior revision, I can also have an opportunity to make sure it lines up with the prior rods, because there are other screw paths there, and so I want to be sure those all line up, and so I'm not having a bad day trying to make sure everything fits in. So this was this patient's robot plan. So again, you see the two S2 screws, and then you see the iliac fixation points as well as more traditional iliac screws. They line up. So this way, when I take out all the rest of the stuff and then do the S1 PSO, everything lines up here, and then a 3D recon to confirm it. So really, in the surgery, once I expose, we expose all the metal, these are the iliac screws. So again, I use the robotic system. It's like maybe 3 minutes per screw with all the taps, but it's a single pass each time. So I don't have to worry about missing or something not lining up or troubleshooting. I just put in the fixation points that I know are in good position, and then the rest of my cognitive path can be doing the actual S1 PSO itself, which is already going to be potentially difficult. So S1, and then I put in my 4 rods at that time with the main rod hooked up to both S2 screws, and then you have the correction, right? So again, an open example of how multiple fixation points can be done, typically 2 S2s on one side and then the iliac on the other. Now, I think, a large part of this is also now MIS. So a question comes up, it's like, well, how do you put in iliac screws in general MIS, or how do you put in multiple? And, we published this back in 2022, because again, my bias training with Dr. Lenke in 2018, I saw every week very complex constructs because we knew that multiple pelvic screws, multiple rods help to prevent failure. And so we demonstrated that with robotics now, you can do that, because now there's this opportunity to plan this preoperatively. So we did a case illustration and then released an early case series that with software now, we can, instead of doing this in the operating room and trying to recreate it in your brain, you can set it down on, paper in a way and create these constructs that are just as complex as an open surgery. Because for me, open surgery is the gold standard. MIS really has to reach that. Here's an example of a circumferential MIS case, 2 fixation points, an MIS case, 3 fixation points, and 1 with 4 fixation points. And all of these were circumferential cases where the screws were passed through the fascia, because this is what I see, right? I don't see the spine at all. And so when I put those screws, they are single incision, transfascial. Those are just the fenestration cannulas for cement. So I do also fenestrate my upper screws and then vertebroplasty. And then once the towers go in, again, I never see the spine. And so the questions that came up when we were protocoling this is, well, how do we do these screws then? So here's an example of a lady who came to see me. She had a prior 3-level ALIF that was standalone, but her main problem that the prior surgeon tried to fix but aborted is this prior osteomyelitis causing this kyphosis out of TL junction. And so I wanted to treat this, as MIS as I could. So she actually got a 2-level corpectomy first. So lateral, retropleural, retrodiaphragmatic. I took down those 2 levels of bone and reconstructed with a corpectomy cage. And then the posterior then would be MIS. So this is her robot plan. And you can see her fixation points at the top going all the way to the bottom. That corpectomy is highly destabilizing. So I wanted to be sure that I had 4 rods across there, which then would require 4 pelvic fixation points. You can see the S2 screws lining up with the rest of her screws. And then you can also see the iliac screws off to the side. And what I'm zooming in on is to make sure there's no collisions. Because again, it's not an open surgery. I'm gonna have towers like coming out all over the place. And so I wanna be sure that none of those are in my way, just as like a working tip. And so for the actual screenshot itself, you can see the accessory iliac screw down on the right, and then a close-up view. And this is the view that I make sure that as I put in the screw, the towers that are coming out don't collide. And so there's these small things that we never really had to think about if it were just an open surgery. And again, this is what it looks like putting in an S2 screw with the robot. It's no different than putting in any other screw. So the advantages of leveraging technologies, that's my PGY2, the analogies in leveraging technologies is this ability to be reliable and reproducible and predictable no matter the complexity of some of the cases that we all treat. You know, this is my side, and you can see the robotic system there matching the iliac screw to the plan. And then this was her finals, right? So straightened her out, and then you can actually see her femurs, of course, they straighten out as well. We don't have an EOS yet, although I look forward to it. And then collapse of her T4 and L1. And again, an MIS case for something that's a bit more complex. Now, it's funny because I put up these x-rays, and you might think at a glance they're like the same x-ray, but all of these are different. And it's funny because just like how Alikos showed, you know, so many phenomenal x-rays, all of us have a bit of a signature in what we do. But I show this because these are all circumferential. So the question that comes up is, well, how do you pass that third rod to the third iliac screw? Sometimes I'll use domino connectors. Sometimes, as you'll see here, I'll use outrigger screws. So these screws are coming out just a little more lateral to medial, and it lives outside of the main rod, and then I use that then to connect that third screw. So for the domino connector, it can be helpful. In this case, for example, this was that left-sided case presented as an abstract. This is the kickstand rod. So typically I'll use the domino because it'll allow me to get that final correction. And this was a gentleman who sagittally was also well realigned, but really I was concerned on the coronal plane. So what that looks like as a domino is this, right? So you can see everything is transfascial. You have the dominoes, and I open it up just over the part of the rod that I'm going to be putting the dominoes on, and then I seat those two dominoes. Once those are in, I create the kickstand rod itself, which has an MIS passer. I pass that, so you can see the third rod holder there, and then I seat that down. And then just like in any open surgery, you distract, right? So just like you do any kickstand rod, you distract the hemipelvis down, you distract the spine over, push the spine over, and you can still do this technique, right, even in an MIS setting. And this is how we ended up doing it. Now, if you use outrigger screws, then they are just planned. Again, you can do this with nav. It's just harder to make sure that every screw is really lined up. But at least this is what the schematic looks like. If you're putting in a third iliac fixation point and you don't want to use a domino, you can just put in outrigger screws and that will just pass. So now you don't actually have to open up the fascia at any point to pass that third rod. Now, to end, again, single position surgery, I want to say that this is a very niche indication. I probably do this maybe once a year. But the idea is that, well, with robotics, there is now an opportunity to potentially do iliac screws in single position. So if you're familiar with lateral surgery and you have a patient with a very minor deformity, you're gonna do in my hands, right, a 2 to 5 O lift, 5-1 lateral A lift, and then flip. Well, if you're not gonna open up the back, well, why not now place those screws in lateral position if there's a capability to do so? And really, the only way you can do it is with the robot. I don't think it's ever been reported with nav. I don't think you do it with freehand, to be honest. But this gentleman came to see me, very minor deformity, 28 degrees. Arguably, if he was doing well, you would do nothing. But he came to see me because he was getting weak in that right IP and quad, right? He couldn't walk up the stairs. So he's having foraminal stenosis on the right main curve. And what really brought him in, because he'd had 6 months of that, he started having a foot drop for the past month on the left, right? So his fractional curve on the left was starting to be symptomatic for him. So for me, in looking at this is an inner body reconstruction, right? So 2 to 5 O lift, 5-1 lateral A lift. And then at this point, if I were to just flip him and put in screws minimally invasively, why not now, because we have the robotic system, place them in while he's in lateral decubitus. So it's much more efficient, and we essentially skip the flip. So here's the robotic plan. You can see all the screws line up, which is the benefit of doing this with robotics, is you can see this up front. And this is what that looks like, right, in the operating room. You see L2 to S1, right? There's a single paraspinal incision, and then S2 screws are a single midline because they go from medial to lateral. And what that looks like in placing the screw is this. You'll notice, again, there's really no difference in putting in this screw in lateral, right? A little bit different kind of mechanically where my hands are, but it's a very rigid system. So it's no different than putting in any other screw, right? We had done L2, L3, L4, L5, made incision for S1 and then made incision for S2. And you can see this is his reconstruction, right? So again, circumferential MIS for restoration of his scoli. And I got a delayed MRI a little bit later, more for like educational purposes, but he felt better already. And so you can see restoration of the foramen as you would expect. And, sagittally he was doing fine, but we certainly didn't make that worse, which is my concern. So brought his T4 to L1, and we're just watching that next junction, which I'm always worried about anyway. So again, in conclusion, I would say the takeaways, as we've discussed, S2 screws are typically more advantageous mechanically over iliacs. If you're experienced, freehand and fluoro is very efficient, right? Especially if you do this often. But I will say that if you have technology, whether it's nav or robotics, it makes things much more reproducible and it opens up other applications such as MIS or potentially, and again, very niche circumstances, single position. Again, I'd open up this talk just in great admiration of Litan's pelvic screw, biceps. But I will say that there is one thing that no matter how many pelvic screws you have, 2, 4, 6 in there, there's one thing that will always overcome pelvic fixation, and that is going to be flat backing someone. So really make sure, as is the whole purpose of this talk, put people back in alignment, and they'll do well whatever you do. So thanks you guys for the time.
Any questions here, guys?
Martin, great cases. Very interesting the way kind of incorporated MIS into deformity really nicely. I see, I guess on your open, you're using the dual-headed screws, but on the MIS, you're not. Is that what I'm seeing? Or is that,
yeah.
Can you add, because it seems instead of an outrigger, if you add the dual-headed screws, it would be kind of an easy fall in.
Yeah, I have tried. Again, this was before for Medtronic, the Modulec system, so the modular head system. But I tried. It's just that you can put in, say, if I wanted a dual-headed screw at like L1. For the robot, I can put in an undersized screw, like a 4-5 screw, to mark it. And then later on, I would take it out, and then I put in a dual-headed. But the thing is these cases I showed, which were more illustrative, like he was very thin. Sometimes they're not that thin. And so when I put that screw down, with at least the system I use with Medtronic, that dual-headed doesn't stay there. So then I would put it in, and then it would fall off, or I would put it in, and the hex would come off. And so I tried. With the new system now that you can put on it after, when you put in the post, you put on the head, I haven't tried that yet, but it's certainly something that I think would be more intuitive, I think, to add that third rod.
Martin, again, great talk. Really precise preoperative planning. But my question is, when you're doing this percutaneously, we heard yesterday, I think a number of people, Manish, maybe Steve as well, were actually fusing the SI joint. Are you ever augmenting this with fusion?
So the SI joint specifically?
Yeah.
I do now. So again, I know people have been doing it for a long time. I'd seen Dave Pauly's talks for about a year. It wasn't until repetitive exposure. It was the recent SRS conference where I saw more data. So now I've started doing a formal fusion. So I will put down like a SI joint screw across that. Uh-huh. So, what's nice about the robot is because you can actually find the space. So I know there's a lot of ways to do it. There are dedicated SI joint screws that some companies make. You can do triangular implants you come across from the side. I've been using the SI joint dowels, so the titanium dowel screws that Medtronic has. So I've been trying that. Just out of the data that I've seen reported, I don't have my own data yet, to be honest. Yeah.
Excellent talk, Mark. How do you avoid collision where your robot sits?
What do you mean specifically?
Like for the Medtronic robot, you got to put in a Shan's pin into the pelvis.
Yes.
So that can sometimes block your ability. Well, maybe not yours, but I'm just saying in general.
No,
what are some best practices?
No, that's a great point. That came up several times in our early experience. So as you may have seen in the pictures, I do put Shan's pins on both sides. The company engineers will say that one is enough, but they're not clinical. So if they're wrong, it's no big deal. If I'm wrong, it's a big deal. So I put in 2 on both sides. I found that initially, sometimes the iliac screw would collide. So I put in the drill, and then I tap, and then I run into the metal. So in that case, at that point, the S2 screws are my last screws. So I will just take out that pin, typically, and be able to leave the other side. And then if I have to take that one out, then you're careful. What I've done now is I just go more out widely. So if the more wide I am, I still get that pin fixation for the Medtronic robot. Because again, the Medtronic robot pin is more for stability. Right? You don't need it. There's nothing attached to it. There's no nav frame attached. So it's for stability. So technically, if you remove the pin and you don't move the patient and you have good technique on the robot, it's still just as accurate. And so that's typically what I found has worked recently. Yeah, great. Thank you.
Well, we're coming to the end here, and we're saving some of the best for last. The next speaker will be Dr. Gupta, and he'll be talking about options to repair L5S1 non-unions, anterior versus posterior or both. Before he does this, I just want to share my relationship with him. I was up at UC Davis as a fourth-year resident at the Shriners Hospital. And there was a patient who had done an anterior release on a thoracic spine, had a chest tube in, and the patient had been in the hospital for about a week. And I'm calling him, he's not answering. And I was just I've never met him. I just came on the service, and I kept seeing the patients and the outcomes that he had. And I decided to do fellowship with him, and it was the best decision of my life. He is a wonderful person, the best mentor that I've had, and I get a little emotional because I'm so happy that I met you, and thank you for teaching me the right thing to do. For your new job.
Well, it was great for Alekos to come to WashU because I felt so bad. I was having a going away party at the Shriners Hospital, and Alekos came up. He goes, "I came here to work with you, and you're leaving." So he caught up with me at WashU, and it was fabulous. We had a wonderful time. Anyway, so the topic today, options to repair the L5S1 non-unions, anterior versus posterior versus both. Interesting topic, right? So it depends. So how do you repair a non-union? It depends on the deformity and some of the other factors. And I made it a very clinical talk to give you some examples of how you would do cases, right? So if there's no deformity, ALIF, right? If there's a sagittal plane deformity, then you have to do an ALIF, and then you have to do a PSO because you have to realign. And then if you have a TLIF cage or whatever cage in the foramen, you can do the correction sagittally, and then you have to do an ALIF and remove that TLIF cage from the foramen to free up that nerve root. And then if there's no gross non-union, you can do posterior only and just kind of repair the non-union from the back. You don't have to do a formal ALIF. So that's the summary slide from the beginning. But anyway, so how do you get to that decision-making algorithm? First, I think we've talked a lot about this. Look at the standing radiograph. And if you don't have EOS, don't sweat. You can look at the patient. If you don't have EOS, you can look at their knees. Their knees are bent, you know. You don't need an EOS to tell you that. And then supine x-rays and bending x-rays just to see how flexibility is in the non-instrumented spine. And of course, the next step is CT scans. You want to look at the screws where they are, evaluate the instrumentation. Sometimes you'll miss, like there's a broken screw, and when you get in there, you're like, oh my God, it's a different problem. And look at the non-unions, define the non-unions, have as much information you can before you go to the operating room. And if the discs are ankylosed and the facets are ankylosed, you know, that has to enter into your algorithm and plan. So let's start with case examples. So it's a 68-year-old male, and he had pain and he had S1 radicular pain. And he came with this construct. You know, this day and age, we still see patients with this kind of long fusion with just S1. And it doesn't make any sense. I mean, I think 20 years ago, we wrote a paper on biomechanics of S1 screws. It was published 20 years ago. The S1 screw, you know, I think Sig quoted a different study, but we put strain gauges in the S1 screws. And if you put an ALIF versus a distal fixation, the ALIF only decreased the stress on the S1 screw by 30%, but distal fixation by 70%. So I think adding distal fixation in the long construct is absolutely essential. So, you know, he had a previous fusion L2 to 5, and then he was having pain at 5-1, and then what did they do? They just extended him to S1, but nothing else. So he had these little bent knees. He couldn't extend because he was hurting his lumbosacral junction. And you know, when they can't extend their hips anymore, they have to bend their knees to look forward for forward gaze. So if you look at the CT scan, he has a non-union at L5S1. And then you can see the halos around the S1 screws, right? Not a very complicated issue. But I get CT myelograms on some of these patients. And the reason he had S1 pain is because he had stenosis. Okay? So he not only had the S1, L5S1 non-union, he had stenosis. So always watch out for things like that. Remember, you want all the information. So he has stenosis there. He had loose pedicle screws at S1 and no pelvic fixation. So these are the things that we had to fix. So what did we do? Was simple anterior fusion L5S1, posterior fusion, revise the S1 screws, and then put iliac screws, and then he was on his merry way. So that's the first scenario. Second scenario is a patient who has some proximal junctional disease, right? S1 screws and leaning forward. And you can see that if you lie down, majority of the time, those junctional things are very mobile. You seldom need a VCR or any big 3-column osteotomy. So that's the first thing you can gauge from your supine X-ray. And then coronal plane is not bad at all, right? It's only the fused segment that's fused flat. So you have a non-union, you have your proximal junctional problem, and you have a flat spine. So you have to fix the alignment, right? So, and this is the typical posture, right? They're bent knees. You don't need EOS to show you. It just shows you the same thing. And then the CT scans show you loose screws. You can see, so, you know, the fellows do this. And it's a big learning experience because everybody has this imagination that these pedicles are huge, round, cylindrical things. But after they're done with the fellowship, they have a much better idea of what pedicles are really like. So you can see the halos around the screws, loose S1 screws, loose screws. So we did a posterior, we extended up higher. And some people might think it's too high, and I think that's fair. I tend to go higher just because I've had, over time, figured out that the thoracolumbar fusions are not always the most durable. And I think sometimes maybe I'm doing too many higher fusions, but that's my fault. So we did a pedicle subtraction osteotomy and then fixed the L5S non-union with an ALIF instead of doing a TLIF. So if the S1 disc is not fused and you can mobilize it, I prefer to do ALIF just so I get a little bit harmonious correction there. And then if you see now his head is between the femoral head and the sacrum. Before, head was way forward, right? And that's what it looks like now, okay? So, you know, in practical sense, you know, Alekos knows that I take a lot of pictures because I think the pictures are valuable. So when you first start doing these cases, by the time you do this exposure and you expose everything, then you take everything out, you're already exhausted. And then you have to do the PSO. And one of the things that I can tell you is that I started doing this concept of short rods in 2000, so 25 years ago. And I think I presented it here in the first some of these meetings. And a lot of people have adopted this because it makes so many things easier. Because once you're done with that correction, you lock it, and then you can put your long rods wherever you want. And so that's what happens. You do the PSO, you correct it, and then you put the long rods around it. And that's what it looks like afterwards. So that's the flat one with the L5S1 non-union. So you do ALIF, and then you do the PSO to realign, right? Now it's a little different animal now. This one had a previous fusion, and there's obviously failure of instrumentation. Again, notice there's no iliac screws, and you can see the bent knees and really kyphosis at the non-union site. So this patient had a T12 to the sacrum fusion with large laminectomies, and then failure of instrumentation with non-union at 2-3 with kyphosis. And I think even if you fix the kyphosis, it would be flat. So you have to add something to fix the malalignment. But again, this is if you want to read the numbers, the PI is 67, so quite high, right? So, and look at the flat sacrum. She's maximally retroverted her sacrum and still can't stand up straight. So supine X-ray shows that there is some mobility at that level. It does come apart some, but the sacrum is still vertical. And if you look at the CT scan, there's a non-union at L5S1. And then if you look at this one of the screws is medial. Now, if you don't study these CT scans ahead of time, you're going to put the screw right in the foramen again, or right in the nerve root, and then you'll wonder what happened. So make sure you study them. And then broken screws. So broken screws add some time to your OR because you have to drill that out and take it out and add a bigger screw. So you have to know that ahead of time too. So the coronal plane shows you the non-unions above and below where the L2-3 and 5-1. And then there's a cage in the foramen. This patient had 5-1 L5 radiculopathy with the cage. And I'm not sure if it was placed wrong or it slipped back. I have no idea, but it needs to go. So this is a tough problem. And if I were to ask you right now, who would to remove this cage from the back? Okay, who would remove this cage from the front? Okay, yeah. So I've tried both, and I'm much better at it from the front because there's so much scar and there's so much tension on the nerve roots. I'm more likely to damage the neural elements if I try to do this from the back, although I have done it. So I think, my approach for this would be to remove the cage from the front. And then of course, I would do a PSO to realign the lumbar spine. And then of course, I would use multiple rods, especially around the PSO site. So that's what we did. So the first stage, we removed everything, did the PSO. And then in the second stage, I went back, removed, so all the alignment was already good, went and carved out the cage, took it out, make sure everything was good, and plaqued a femoral ring and bone in there. So now you can see that the sacrum is in a much better inclination. You have the lumbar spine with the right lordosis. And then I guess I can be criticized for going higher, but I like to control the thoracic spine, especially if they're way off. So here you are. You can see that the femurs are now straight up and down, and the head is going through the femoral head to the ankle. That's sort of my gross test in a sagittal plane. And this is what she looks like clinically, and then on the clinical exam as well. All right, so the last case scenario I was going to share with you was this. This is a patient who has rods broken in the lumbar spine and the lumbosacral junction. And you can tell the sacrum is again vertical and it's flat, right? There's no lordosis here really in the lumbar spine, and a non-union. So this is what she looks like. She's young, that's why she can still stand up straight. Your muscles around your gluteus, your pelvis, kind of determine that, and the weaker you are, the more you'll bend forward. So she was able to, she's young, she's in her 40s. So what we did for her was we removed everything and did the PSO. And I did not do a formal A-lift because the 5-1 was relatively stiff. There was no gross non-union on the CT scan. So we just realigned her in the sagittal plane. This is what it looks like when you first open up, and you have to deal with the scar. And I'll give you a few tips. Remove the scar. If you don't remove the scar and you do the PSO, you're going to get buckling. And it's much better to get multiple buckles than one single one. Otherwise, you'll get problems with your quota. So this is after we remove everything and we're doing that big decompression and the PSO preparation, do the PSO and then put the long rods in. And then I use a lot of bone. And I use a lot of, people make fun of me because I use so much bone. And they say, well, you know, that's one way to counter the prominence of the instrumentation. You cover it with bone. So, but I think it's important. I use BMP off-label, I guess, but still, and bone, because I think to me that's very important. So this is what it looks like. So if you look at the pre-op and then up to 2 years, you can see the head over the femoral head and the ankle lined up. That's the clinical photo. So in summary, for the evaluation part, I think standing radiographs and then clinical exam, and then supine bending radiographs, and then CT scans to look at the non-unions and the instrumentation with the screws. And then just to reiterate the sagittal plane, I think start with the pelvic incidence, build the low lumbar lordosis, and then use the arches to build up like from bottom up. And then if you don't do pelvic fixation and long construct, you'll have some trouble. Don't forget that, it's critical. So to review the summary slide I had from before, if you don't have a deformity, do an ALIF. If you have sagittal plane deformity, you have to do an ALIF and a PSO. That's the for sure way of treating an L5S1 non-union. If you have a cage in the foramen, I would do the PSO, realign, and then do an ALIF. But if there's no gross non-union, and you line up the biomechanics, I think you can still get a good fusion. Thank you so much. Yes.
Thank you, Dr. Gupta. Can you hear me?
Just fantastic talk. It's beautiful carpentry. When I do these revisions, I found, especially at S1, the haloing and screws really not being big enough.
Yeah.
Your experience in terms of requesting, you know, a lumbosacral pelvic revision set where you can get 8.5s, 9.5s, 10.5s. I've definitely haven't had those conversations ahead of time and been, you know, we didn't have anything really to fill the gap. And then I noticed in some of your revisions and constructs, just no cement. Just make a comment to that in your practice with getting fixation and abandoning that little extra kit. So.
I rarely use cement. And I don't know why, because I think that, I know that UCSF is like a thing that you guys always cement the UIV +1. I'm always worried, like if I do UIV +1, it might be the +2 that falls apart. So where to stop, where to begin? That's number one. Number two, I've seen the ones with cement, they still do a spondylolisthesis. So if it's gonna go, it's gonna go. I think it's gonna degenerate. And I know that your data shows it's better. I tried it a few times and I just was not satisfied with that. So that's number one. So I don't use cement. I use cement in like an 89-year-old that needs something done and there's no time to fix anything in terms of bone. I'll use cement with a fenestrated screw and put cement through it. But I don't cement routinely big holes and put screws in. I've done that occasionally where there's no size iliac screw that will fill the hole of the ilium because it's all bad, and then I'll put cement and then put the screw in. So very rarely I will do that. But my practice is so bad that they have a huge cadre of humongous screws that they have in the back, and then when we need them, they just bring them in. So I don't have to call for them ahead of time because every week there's a lot of revisions. So lucky or unlucky.
Manish, question, what are your thoughts about patient-specific pre-contoured rods? And also maybe in that, talk a little bit about rod diameter and rod material.
Yeah, I used to love quarter-inch stainless steel because the failure rates of quarter-inch stainless steels are really low. But then the companies went away from it. It was sad because they had some data saying that stainless steel is bad, infection, all that stuff. So then I still use quarter-inch titanium rods. Those actually have better fatigue than 5.5 cobalt chrome rods because of the diameter. Engineering-wise, any engineers in here, if you increase the diameter, the fatigue goes up significantly. But now I use mostly 5.5 cobalt chrome because that's the stuff they have. And then I add from thoracolumbar junction down to below S1, an additional rod. I haven't done the 4 iliac screws that you guys are doing, and I haven't done S2AI screws very much. I remember doing an S2AI screw about 15 years ago because there was nothing else left, and I just went from the sacrum into the ilium, and I realized afterwards that it's a real thing. But I've traditionally used iliac screws forever, and I haven't had the same problems. Maybe I'm ignorant, but I haven't routinely used 4 screws. And I think the only time I really use them is if in a trauma situation where this is lumbopelvic dissociation, I use 4 screws in the ilium or sacrum ilium, or like a big time revision. But routinely, if all my constructs are basically 2 iliac screws. Yeah. And then the 5.5 rod. Yeah, go ahead, Steve.
I love seeing your talks, so thanks for sharing. And just can you go over roughly when you think you should do the front first versus doing the front back, front last? So.
Right. So I think if you want correction in the sagittal plane, then you should do the front first. If you don't need correction and you're doing it just for fusion or removing that cage that's a problem, you're getting all your alignment already, then do the front after that. To me, it's that simple. Yeah.
Again, great talks, and you have such beautiful pictures, right? Just like from earlier, from yesterday. Slightly off the topic of of the title of your talk, but can you talk about when you expose?
Yeah.
Do you use like controlled hypotension? Do you use TXA? Because in your photos, what's beautiful about it, they're bloodless at that point in time.
Yeah.
I know you clean off the bone and everything, but can you talk about how you prep the spine before you start doing all the work?
So, Alekos can talk about this. All my fellows are allergic to operate on dirty spines. Because I tell them, are you gonna eat dinner on a dirty plate? So they have to thoroughly clean the spine. All the soft tissue has to be removed and all the landmarks have to be exposed because it takes a little bit of time. Because you remember, we use freehand technique with surface anatomy. So if you can't see the anatomy, you're gonna make more mistakes and it's much harder. So it's from day one, they learned that. Second, the bleeding. I use TXA and meticulous hemostasis as we go around. But these pictures are a little bit fake because we wash the wound out, we put the lap, we dry it up, we take the lap off and take a picture. So, because if it's bloody, nobody's gonna be able to see it. So that's why it looks so good. But the pictures are worth taking. And this was a tip that was given to me by Art Steffi, you know, the Steffi screw guy. He goes, if you're going to give talks, you can say words, but they don't mean anything unless you have pictures. And x-rays don't mean as much as real pictures. So that's why I take pictures, and I got tons of them. And my secretary has PowerPoints in every case I've ever done with pictures.
Last question.
Yes.
So you brought up the S1, stopping at S1 has very historic data showing that it's not adequate, but it continues to happen.
Yes.
And I think that's an area for our field that we need to do a better job of teaching how to do pelvic fixation. I think the pelvis anatomy is very complicated, and the orthopedic surgeons get it with trauma. The neurosurgeons, I don't think, get much pelvic anatomy at all. And I think that it's where we should focus a lot more attention to prevent a lot of these issues for the spine world of S2AI screws, the anatomy around that, how to expose the PSIS. And I just think that it's more of a comment than a question, but it continues to happen because I think there's a lack of training around how to do it correctly.
But I think things are changing. You know, I remember when I first went to the Orient, nobody was putting any kind of pelvic fixation. It was only S1. And then we started giving talks in China, Thailand, Asia, everywhere. And then they said, oh, wow, this is a good idea. So they started, so things have changed. And part of it was the companies weren't giving them iliac screws or S2AI screws. So it was availability and also knowing. So things have changed. And ortho neuro, I think there's no difference anymore. I really think that we're all the same. And it's just a matter of training.
I agree. Wonderful. Thank you.
Thank you.
So the next talk is going to be given remotely by one of our vascular surgeons at UCSF. His flight was canceled, and he's going to join us by Zoom. He's going to give a talk on approach to complex anterior approaches to the lumbosacral junction. So if we could key up the Zoom. Okay. Chuck, can you hear us?
You won't be able to hear us.
No, okay. Let me let him know.
Okay, hi. Well, thanks. If you can't hear me, please put it in the chat. Thanks for allowing me to present this virtually. I had a lot of travel issues and just couldn't get there in time. But I'm excited to talk about a subject that has always been dear to my heart, and I've been involved in spine exposures for many years with a lot of you. So we're going to talk today about how we approach complex problems, specifically at L5S1, but to some degree in all of the lumbar spine. And these are my disclosures. As we know, anterior approach provides direct access to 5.1. It's broadly applicable to fusion, tumors, trauma, infection. It gives great visualization, but obviously the challenge is vascular management and vascular access. That the aorta, the bifurcation of the aorta, but specifically the iliac veins, overlie the lower lumbar spine and L5S1. An injury to these vessels is the primary morbidity of this operation. When we looked at nearly 1,000 of our cases several years ago, there was almost no neurologic complications of any sort. A vast majority is related to the exposure, and the most serious being venous injury. And so we're going to talk about that and how we accept the risk in some more complicated cases. it's certainly critical to understand the anatomy of the spine and its relationship to the veins. And we keep coming back to that if we want to expose these vessels safely. When we look at complicated problems, I think that we can separate this into two different types. One being what I would call contraindications that are not spine related, and the others are spine related problems. So what are the contraindications that we think about when we're doing access surgery, exposure surgery? The first being if the patient has vascular disease, if the patient has aortic occlusive disease or aneurysm problems, this can make it difficult to move these blood vessels around. Patients who have had prior vascular surgery or prior endovascular procedures, the arteries are really stiff and hard to retract. If patients have had previous retroperitoneal surgeries, especially lymph node dissections, colostomies, kidney transplants, obviously there's a risk. Previous ALIF creates a lot of scarring, as does radiation therapy to the retroperitoneum and inguinal hernia surgery. Now, as opposed to these contraindications, high-risk pathologies are something that does involve the lumbar spine. In particular, we're talking about pseudoarthrosis, transitional anatomy, spine infection and tumors, and cases that require hardware removal or revision. So how do we treat these problems? Well, how do we, safely? And first of all, what we want to do is just a lot of cases that are fairly routine. And when we teach people how to do spine exposures, we talk about that all the time, that you want to get a lot of relatively straightforward routine cases done before you try to take on the more complicated ones. And again, most of you have seen us do these, that there are the routine cases, supine ALIF, especially at 5-1 is usually pretty straightforward. There's a variety of incisions. We tend to use the left paramedian approach, but whatever incision you use, you want to get down into the left rectus sheath and mobilize the rectus muscle so that you can expose the retroperitoneum. And once you do, you just work your way around the spine, around the abdominal wall until you get to the spine, staying retroperitoneal. And for L5S1, this is pretty routine. Again, you can pretty much get down there to the point that you're doing the discectomy infusion in 15 or 20 minutes. When you want to do upper levels, obviously, it's a little bit more involved, and it requires dividing the segmental artery and vein and iliolumbar vein and pulling the vessels toward the patient's right. And so 3, 4, and 4, 5 can be exposed, but it is a little bit more involved. The lateral approach has been used by us and to get more upper level exposure in sometimes in more complicated cases. Remembering that there is this, what we want to call the avascular corridor between the aorta-iliac vessels and the psoas. And in this corridor, you can get access to the lateral disc spaces, 2, 3, 3, 4, 4, 5, without too much difficulty, because the segmental artery and vein is on the body of the vertebra. And so if you have a technique where you can drop onto the disc space, either with navigation or fluoroscopy, it's very safe. You don't even need any vascular work at all. And so this allows you to do this, and that the OLIF 5-1 or the lateral 5-1 approach was developed to allow you to do this all in one position. And again, those of you who have seen us do this, the lateral exposure to 5-1, the ultimate exposure is between the iliac vessels with a left lower quadrant incision. And so sometimes an all lateral approach gives you good exposure in cases that are a little bit difficult to do from the front. So it's a good technique to have in your armamentarium. The takeaway is do a lot of cases, a lot of straightforward cases at first. And that when we have to then do these more complicated cases, especially what we call the contraindication type cases, it may require a bit more pre-op workup, but most of the time you can get it done. The pre-op workup is usually some kind of imaging that we do with contrast, either a CT or MR, that allows us to think about the cases preoperatively and get these exposed. It helps with the understanding of the vascular relationships of the iliac veins, the iliolumbar vein, and the middle sacral veins, and allows you to think about it preoperatively and go after these successfully. If we do get vascular injury, unless it's a direct injury to the artery, it's almost always venous. We can repair the veins in a variety of ways, either with hemostatic agents like Tacocil, using hemoclips on the vessels, or suture repair. Sometimes we've even used an endovascular approach, but whatever we do, usually we can get through it. Remember that sometimes there can be a DVT post-op if you do an extensive venous repair. So our experience has shown us that if we have to do a lot to the vein, either with suturing or what have you, that may cause some mild narrowing of the vein, we always want to get a ultrasound DVT study within about 24 hours just to confirm that there is no DVT present. If there is, then we need to decide, do we want to anticoagulate the patient? Is it safe to do that? Or for a bit of time, should we put in a caval filter? But that's sort of our algorithm for approaching these patients. And typically we can, with careful preoperative evaluation, deciding if we want to go supine or lateral, and sometimes going from the right side. Remember, we can get the L5-S1 disc space just as easily from the right side. And so if there's a lot of things going on the left, such as a colostomy or a previous ALIF or OLIF done from the left, we can often approach the L5-S1 interspace from the right without too much trouble. So a right-sided approach, again, is something that we could think about and help in these complicated cases. But again, when we look at the complex problems related to the spine, those kind of are a little bit different, and sometimes that requires a little bit more work. We're totally comfortable doing degenerative cases or deformity cases. But the complicated cases, the complex pathologies, are the pseudoarthrosis requiring an anterior revision, transitional anatomy, reoperative exposure for hardware removal or revision, or infection or inflammation. And each of these kind of carries a bit of a more unique problem. The pseudos, often there's really dense scarring and some bony overgrowth that may make exposure difficult. How do you do that? You probably want to get some kind of a cage or graft in there. The transitional anatomy, the location of the interspace in relation to the vein, especially the left iliac vein, is difficult and requires fairly good understanding of what level we're going after, as well as intraoperatively what level we're looking at. The reops, again, there's obliterated tissue planes. The vessels could be displaced. You need to try to identify the disc space and sometimes work inside of it. And the infection, there's contaminated planes, often with a fairly thick covering on the disc, on top of the disc space. So all of these can create greater risk of bleeding and certainly require careful tissue handling to prevent venous issues. The venous bleeding can be either from not identifying branches of the vein and getting into the branches, or tearing the branches, or that the vein itself is so stuck that as you mobilize it, either you get into it directly or it just shreds on the tissue. And so all of these carry a higher risk of problems. Transitional anatomy in and of itself, the literature would identify that there is a higher risk of bleeding. And part of it is that by having this extra lumbar disc space, that sometimes what we're calling the 4-5 disc, as opposed to the 5-6, is directly under the left iliac vein. And so that it's difficult to get after it either from the lateral approach or from the medial approach. I often find that the 4-5 and the 5-6 discs can usually be exposed below the left common iliac vein and inside the iliac bifurcation. But it requires careful preoperative imaging. I think that for me, I want to find some disc space between the iliac veins early on in the exposure, put a needle in it, and do fluoroscopy. And then with the spine surgeon present, identify exactly which disc that is, and then say, okay, we need to get that disc in one lower, or we need to be higher, but try to identify where we are. More than even the aortic bifurcation, it's the left iliac vein. Remember that the left iliac vein can be tethered by the hypogastric vein, and sometimes it requires dividing that to be able to pull the vein up so that you can expose the levels necessary. But I think with careful imaging, you are able to do that. Infection and inflammatory cases are often difficult to expose. Often, especially if the L5, the body of L5 is involved, you have to mobilize the left iliac vein from above and below. The upper levels we have found are often more easily exposed laterally, that it's really hard from the straight anterior to move the artery and vein enough to the patient's right. And so often the upper levels can be done laterally, but it's really hard to do a 5-1 lateral ALIF or OLIF. And so typically for 5-1, we're going to want to do that as a supine ALIF. You absolutely want to work in a subperiosteal plane, not getting too close to the vein or the artery. Typically in infection cases, we will put in a preoperative ureteral catheter because the ureter can get caught up in the inflammation. Even if there's no abscess, just the inflammatory rind around the spine will, it'll be hard to move the ureter away from this, and you're just protecting yourself by getting a catheter into it. Once you do get down onto the spine, we want to debride it widely, and typically we will drain the patient afterwards. Cage removal is another problem that carries in some of these articles, they're describing a significant risk of venous injury. Both of these articles had a relatively high risk rate of venous injury. We reported our cases. Mike Safi wrote up our experience a couple of 4 years ago now, and we had really good results going after cages that had been put in either posteriorly or laterally. We reported 84 patients, but we had 16 multiple cages we removed for a total of 99. 55 were at 5-1, 43 were at 4-5, and we only had 2 venous injuries, which is great, and a 96% fusion rate. So we did find that we were able to get these out. Again, careful preoperative imaging, usually with contrast imaging, is helpful. We typically did not require ureteral catheters, but again, you want to work on the spine, staying away from the vessels if possible. I do think, especially for 5-1, if you see that the cage is on the patient's right, that it is doable to approach 5-1 from the right side. Again, you want to localize where you are early, and we often find that once you remove the cage, working from inside the disc space is the best plane and safest plane to do this. But again, our experience was really quite good. We've got most of these cages out and did it, as you can see, pretty safely. So again, 5-1 exposure, either anterior or oblique, is pretty routine, but in revision and deformity cases. But when you get into complex cases, it gives you your fallback to be successful and reduce vascular risk. In these complicated cases, we always want to work together in terms of the incision. We want to try to maintain hemostasis and not rush through the infected or scarred field. And again, working careful communication with the spine and vascular surgeons. Again, I think one of my favorite rules is failing to plan is planning to fail. And if we think about these complex cases in advance, we are able to get them done safely. Okay, so
we're going to skip questions.
Okay, anyway, thanks a lot. And I really appreciate you allowing me. I'm going to stop sharing my screen. Thanks so much.
Thanks, Chuck. He can't hear us, so I think it'll make it simpler if we just move on. All right. So last talk, Steve Lewis. Thanks for everyone for sticking around. I've known Steve for the last couple of years through the AO, and I've found him to be a very thoughtful leader. He asks important questions, puts out papers that are very relevant and help guide clinical decision-making. More importantly, he's Canadian, and my wife is Canadian, so I have a soft spot in my heart. And I probably, the last week in my house was a very painful one because of the Blue Jays. Yeah. So I'm sorry. Okay. This color reminded me of the Blue Jays.
Yeah,
so
thanks a lot.
Thank you for joining us.
Okay. Thanks a lot. Thanks for having me, and thanks for everybody for sticking around. I know it's been a long weekend, especially for those dancing like crazy last night. So, The highlight was actually seeing Manish all plastered up all over the club there. So it doesn't get much better. So thanks a lot. I'll go over, I know there's no coffee I saw outside, so for you guys to rush out to, but we'll go over some of the things and for failed pelvic fixation. And I've been doing single iliacs for a good part of my early career, and I didn't really have much problems with them. And then there's, realize that most of it is, a lot of the work is getting L5S1 fused, because if you can do that, it really takes a lot of the load off your pelvis. But there's a study that came out showing a 22% spinal pelvic fixation failure, and I was kind of like a little bit appalled by that. And when I looked at them, they include a lot of other things. So a 4-to-1 suit, fractures of the rod, sacral fracture, set screw dislodgement, which I haven't seen, thank God, very much. Iliac screw failure, which I've seen a few broken ones, loosening. Probably SI joint pain is probably the most common thing, that they have this kind of low back pain despite your spine being fused. And then the prominence, which we've kind of helped out by burying them as low as we can. So I'll go over some of the things that the way I look at it. So when I look at it, did I have a failed fusion? So do you have a suit at 5-1? And then the more recent I've been looking is really a suit at the SI joint, which is probably very common. Lack of S1 fixation is a problem, deep infection, tumor involvement are some of the reasons that we saw for this problem. But I want to alert, the main problem down there is really the soft tissue coverage. These incisions are very close to the bum, and you can see on these young patients where you have some decent muscle, but you still, down when you get very low, there's really not a lot of muscle there. And then on these older ones with a little bit of sarcopenia, you can see the coverage that you have down at the bottom is really a problem. And you got to really make sure that you have very good dissection and keep that muscle plane as good as possible. So you see a young patient, an old patient, you can see what you're going to be dealing with is going to be a lot less and something to look at. Then you have to think about your bone stock. So are you going to have, is there a sacral bone? Is there iliac bone? And how are you going to manage these deficiencies in the bone stock, which is kind of a really major problem. And then are you fused or not fused? So if you're not fused, then really address that. So, here's a pseudoarthrosis at 5-1. You can see the failures, broken screws. These are all things that you want to try to avoid, but really fusion will help a lot. And then really this risk of infection, because of the proximity to the bum, this is kind of one of my patients had C. difficile after, and you can see that having, what I learned from this is really the importance of having a barrier dressing at the bottom. A lot of these patients have big surgeries, they're a little clumsy in bed, they can't get around very much. They're constipated from narcotics, so they throw the bombs at them, and this is something they can't avoid very well either. And if you can protect them from themselves, is really, really an important thing, and saves a lot of the aggravation for these. We looked at my personal series of infections. We just looked at fusions to the sacrum and pelvis, and you can see we out of about 500 cases, had about 20 of them. And the interesting part was 13 of them were either Enterococcus fecalis, E. coli, Klebsiella. They were not the usual things. These are all outside-in infections. And since we've kind of gone to these barrier dressings using these off-site plastics, really sealing the crack from the rest, it's really helped a lot. We haven't seen as much. The key for all these is to get good distal fixation. And how do you get it? Well, you need good S1 screws. Having iliac without the S1 is not a substitute. Increases the length, the stiffness on the construct goes way down, and the motion at the 5-1 will precipitate a lot of failures in your iliac fixation. And then I've switched to S2 AIs, but now I've actually switched to both, and I do an S2 AI and an iliac now as a routine for most of my distal construct. This is kind of what I like. I like the dual-headed screws, and we kind of run them up with the thing. And then make sure that you save that soft tissue on your dissection. Make sure you're really careful on maintaining as thick a soft tissue envelope as you can, and then do your best to get fusion. So when you look at pelvic fixation, we kind of look at, right now, the common ones are the S2 iliacs and the iliac wing screws, and then there are iliac sacral. And I kind of think if you look at this teardrop here, probably the worst thing you can do is put the first screw dead center, because that leaves you with very little options. And even if you're going to be a single screw person, you may be a double in the future. Okay, so you never know. Put that first one as low as possible. Put it right down at the bottom. It gives you options down the road. And so I think split that, share the real estate. Get that one, the first one at the bottom, and then you can put the second one on the top. And otherwise, this is your corridor where you can get your screws. And so I usually try my S2A right over the notch, and then it gives me room on top. But don't put it dead center. It leaves you with very little options down the road. For the insertion points I usually study the CT and I look at the straight line. And so, there's the modified. I'm going to go over the way I look at it. So if you have your CAT scan, for example, here, so you look at here's your 5-1 facet. So you keep going down. Now you have your S1 pedicle start points. That's where you're going to go. And then I look at this one as the S1 foramen's going to start for me here. So I have some sacrum till I get to the S1 foramen. And you can see that the sacrum is still ventral to the pelvis. So it's very hard to reach the pelvis because you have to wait for the sacrum to come posterior. And so as you go more distal, you can start seeing how, now here's the PSIS. Once you get really past the distal end of the PSIS, now your sacrum is now going to be posterior to your pelvis, and it puts you in a much better position to get your thing. And that kind of goes with what you're trying to do anyways. You're trying to plan out distal as possible, just as Martin showed very nicely how he was planning his 2 screws in that area. But it's important to know, because if you're going to start too high, it's really hard to get your S2. I mean, you're going to start here, you have nowhere to go. You really want to wait till you get, and usually I study the CT to see, in this case, it's right at the S2 foramen, and you can see you have a nice notch of bone there, and that'll give you a straight shot. So that usually, I basically plan it out on my CT scans like that. So I end up with this kind of triangle here. I have my S1 screw, my iliac screw, and then my S2II. If I have room, I'd like to put a dual-headed screw on my S1 too, because that really strengthens it. In this case, we used it on an L5 in this particular case. So that's kind of the way I look at it. And then I do have the modified, I want you guys to know too. So sometimes you can just cheat a little bit starting very medial. You have to be careful because when you start on the medial pelvis, you end up aiming to the lateral wall. So you have to aim a little bit more medial to get that. But it is good. It kind of gets you lined up a little bit better, especially on males, for example, when their pelvis is a little more narrow and your S2AI is going to be a little more medial than you want it to be. The modified is a good version. Still, if you can jam it in, either distally or proximally, so that you're able to get your 2 screws. But I think the key is plan for the future that you may need 2 screws, and then get that first one as low as you can. And so it's kind of where I'd put my iliac. I bury the heads, as everybody says. I don't take a corner off because I think it makes it really prominent. So those are kind of some of the tricks that I use. Now, if you're going to use an iliac wing screw, it's really important. I think the connector is important. If you have a bit of an offset on 5, you can really precipitate a lot of coronal offset. And a few degrees at the bottom will really translate into a lot. And I think it's a lot easier to just use a connector. If you're not going to line up, just a connector will help center you better so that you don't create this coronal offset. That's easy. And, it's hard to try to arrange some of these, even the modified. If it's a little bit off, just don't fight it. Use your connectors if you have to. And we wrote our paper on how not to do that. We kind of how to correct coronal balance and really how to really level out L4 is really the key, especially if you're going to fix your main curve. So getting that the sacral fractional curve by leveling 4 is a key component of getting this straightened out. So let's look at some different cases. So how about a suit at 5'1"? So here's kind of a classic case, undercorrected. I showed him yesterday. So he had a suit at 5'1". And so you can see he also had, this is him, so you can see his sacral screw. He's got a big chewed out S2 kind of here. So there was a little room more distal. You can see the big holes he's going to have when you take out these screws out in the bottom. And so what we ended up doing is finding where our bone is and getting, you can see try to get the first one distal. So we doubled up his screws on that one side. I couldn't get the second one because that first screw was dead center. So we ended up not being able to get a second one on this one, but we ended up being able to get a second one on this side. getting good distal fixation and working hard and getting the fusion, and then aligning him later on. Now, what happens if you have this large defects in the iliac wing? And I think Michael was talking to me about a case before that's a little bit similar to the kind of what we're looking at, and this is an infected Charcot spine that my ex-fellow sent to me as a present, and I appreciate him trying his best to help fix it out. So, he did a lot of cement reconstructions, and I saw some of the brainwashing that I gave him did help a little bit, and he got some fixation. But you can see now you're going to have these big holes in the sacrum. Patient had an old iliac crest harvest, so there's not a lot of iliac wing to work with on that side, and really study how much bone stock you have. So here you have issues, you have infection, you have wound coverage, because this is a patient had draining sinus from a sacral ulcer, a little bit more distal. Bone stock's a huge problem, fixation options, and you have some gross instability at the lumbosacral junction. So we kind of filled all the defects. So looking at, I had some bone distal I could work with, so we got our screws passed and used the navigation like was suggested to help get into some of the good bone. And then we filled, basically filled all the holes with cement. So you can see all this cement reconstruction around all the defects, put it in a kind of a moldy set, pack it in, and used a quad rod and got this patient quite stable, and actually healed his sacral ulcers too. A lot of care and getting him rolled and things like that to try to do that. So cement is really a good cheap option, especially when you don't have bone stock. It fills the defects, but you do need to bypass it. It's good as a filler in the middle, but it's nice to be able to have some fixation distally, at least to fill in. And the question is, do you actually need to fuse the SI joint? And there's been a lot of controversy. And I had this case here that we inherited. He's about 80. I think he's 89 now. We did him in his 80s. We didn't do crazy, just got him. I had to revise him because he had a suit at 5'1" that I inherited from someone else. And we just got him kind of fused. I didn't go crazy on him. Maybe I should have. But you can see that he broke right under his S1 screws later. And you can see he was solidly fused everywhere except for his SI joints, which was quite interesting. So it kind of made me think that maybe these are patients that need to have a little bit more work done on the sacral, that there is a real thing. Thankfully, at 89, I just did some SI joint injections, and I never had to operate on them again. But I have been, this has been something that Dave Pauly's been pushing for a long time. So when I look at the SI joint fusion, there's really just a few ways to do it. You can do an intra-articular fusion, fusing the joint itself. You can do an S2AI, which is a very common one. And then there's the iliosacral versions, where you go from this posterolateral approach or the lateral approach. And those are kind of the techniques that are well established, and you can work around what you have in terms of your anchor points right now. So this kind of the techniques, the direct, I use grafting. So you can see I use I take a chunk of the iliac crest and just shove it in the joint. And you can see it looks quite nice actually. You can barely see the joint after, and we get a really nice anchor point. This is using kind of these cannulated bone fusing screws, and then this would be kind of a direct SI joint with an implant. I think if I'm doing iliosacral, I prefer the posterolateral, just because there's right here is the superior gluteal vessels and nerves here, and so I think that trying to avoid that, so I use that point here, and I try not to go past it if I can to get that in. I had one patient who wasn't happy when we dissected a little bit lower down, so it's kind of the anatomy. You can see where the notch, where the nerve is coming out and coming across. You also have some of the cluneal branches that come down, but I think the superior gluteal is kind of the most important to try to avoid, and so if I do an iliosacral, we're doing it from that kind of posterolateral kind of approach. And so here's a kind of patient we did just a late. He had some SI joint pain after a long fusion, and we did a percutaneous navigated iliosacral screw through this kind of approach right here. So right now I'll just show how I kind of do my incorporating into my cases. So here's a kind of a degenerative case. So here's kind of what we see. I dissect the iliac wing, leave the thing. In this case, we're going to use, I kind of have my triangle, I have my S1 screw, my iliac screw, my S2 iliac, all here. And then I take and harvest the the crest here. I clean out the whole SI joint here. And so basically clean out the whole joint with curettes, burr, and things like that. Once it's all cleaned out, and then I take the piece of bone and I jam it in the hole. And so kind of, you can see this is kind of the exposure that we have in here. We're cleaning out this part of the joint through this exposure. And then here's the iliac wing, there's the sacrum, that's the joint. And then you put the bone in, and you can see how nice, so this is before, and you can see after, you can see the bone jammed in nicely through the through both sides. So I think it's a direct fusion. There's no billing code in Canada for it, so I'm just doing it so that I have less, maybe when I retire, nobody will come back and fix my distal fixation failure. So, and then kind of here's the post-op construct that we had for this patient. So in summary, choose the one or combination that aligns best with your construct. Consider the shape of the pelvis. Fusion will protect your fixation, and I am currently fusing both the, obviously 5-1 always, but the SI joint is now part of my primary fixation, and beware of any offset so that you don't create these coronal deficits. So when you have a failed, fix the underlying cause. Is there a SUD? Is there lack of fixation? Is there inadequate pelvic anatomy? Do you have infection tumor? Figure out what you're trying to do. Make sure you preserve that soft tissue coverage as best you can. Sacral bone stock, iliac wing bone stock are key components. Fusion status, broken screws are all things that you need to address on your thing. So I do think SI joint pain is real. Stabilization without fusion, probably not enough in some cases, probably not all. And it's right now currently a part of my construct. So thanks a lot.
Can you speak to the bone cement that you use to build that? Because the only cement I know is the kyphoplast.
Yeah.
That didn't look like that.
No, so I think I use the Simplex cement, which is the kind of $50 cement off the shelf. I don't put it in a liquid phase. I put it in a doughy phase. So it gives you time to play. So we do it for our joint replacements. You need some time to play with it so you can get your implant in and direct it the way you want. So what I do is I kind of mix it up. Once I can roll it in my hands, it's ready to go. And then after that, you have about 5 minutes to play with it, to put your screw around it, pack it in, cut the extra off, and things like that. So it's really really cheap. It's called Simplex, the one I use. But it's like if you ask your orthopedic guys at your hospital what they would recommend for their hip replacements, and I would go in on a hip replacement for fun and just see how they use the cement. And I think it'd be very helpful for most neurosurgeons, especially if you're going to use cement in your practice.
No, I mean, actually, to Alex's comment earlier, as neurosurgeons, we don't see the pelvis at all. And I remember as a fourth-year resident, I had a picture on my phone of the pelvis, just so I could understand where to put the PSIS pin. Because in putting the PSIS pin for minimally invasive surgeries, you just feel bone, you put it in. I'm like, this feels dangerous to me because I don't know what the shape of this is.
Yeah.
And so for the longest time, I had three-dimensional views of the pelvis.
Yeah, it's
so
very
as a
helpful.
neurosurgeon, you can understand.
We have the same problem when we put pins in the head at orthopods.
Any other questions? Steve, I had one more question. What do you do to denude the cartilage from the SI joint? Are you using a burr? Are you using osteotomes along the edges?
So what I do is, first thing I cauterize it to get into it. Then I have Lexels, a 3 millimeter, a 5, and so I use those to clean it out. Then I curette the end plates, and then I burr the end plates. And then there's the, let me see if I can show you. I don't know if I can. Let me see, sorry. Is this the one? Just to show you, there's kind of the we call it the fibrous part of the joint, you see? Mm-hmm. And then you have the real part of the joint, which is more of that. And so it's much easier just to fuse this fibrous part. And so usually I clean out that whole fibrous part, which is quite big. And then I'll take the burr and try to get into this cartilage part right after. But that's kind of what you can see it right here, you see? Mm-hmm. So you have a big window to work with. I follow the iliac wing until I fall into the hole and then clean it out. And then you can see from that you can get in quite deep. And then with the burr, I'm going to try to burr a little bit deeper into that. And I'll maybe put a little softer piece of bone first and then put the big piece in after to jam it in. So that's kind of...
Do you add BMP?
No, we can't afford that.
Okay.
This is all natural, you know? It's
I love it.
It's natural bone.
Well, great. I think because we're coming towards the end of the day, let's just go straight to the cases. And Manish, if you want to get up there, Martin, I think Chuck obviously is not going to join. And Sig, I think, took off already.
Yeah.
You got to leave too. Okay. Well, the experts, yeah. And Mo, do you want to present? Yeah.
So, well, thank you for that great day today. It was really informative. So the case I'm presenting is sacral fractures below prior instrumentation requiring S1 PSO. So 68-year-old female with prior fusion at L3 to S1 for degenerative scoliosis. She's been reporting pain since 2014 when she slipped and fell on her buttock, sustained a fracture in her sacrum. Since her fall, she's been having burning pain to her lower back. She thinks that she's been starting to lean off to her right side even before the fall. As I mentioned, she had a previous L3 to S1 posterior spinal fusion for spondylolisthesis at L3-4 and L5-S1 in 2015. That was at an outside hospital. She was referred to UCSF. She was very displeased with her posture, and this is affecting her quality of life. She says it kind of makes her feel shorter. And then prior to her surgery, she's unhappy, cannot walk her dog, her grandchildren. She's having a hard time maintaining her posture, causing her to take deep breaths to do that. Overall, she's also complaining of perianal numbness. She's tried physiotherapy, uses a walker, cane to ambulate, and requiring fentanyl patch for managing her pain. And then other than that, she also has a T-score of negative 2.1. Yeah. So these are her initial films, AP and lateral, and you can see in the films here some of the pathology. This is 6 months when she presented to UCSF. And this is kind of zoomed in. So there's like the fracture distal to the S1 there. This is a CT scan. Overall, this is her alignments. So C7, S1, SVA is 24 centimeter, L1 to S1, lumbar lordosis is 68, PI 90 degrees, L5 incidence 84 degrees. How would you manage this?
Great. Now, can you go back to the CAT scan?
Absolutely.
From here, is the fracture healed already, or?
It is, because it's been a while. Yeah.
Let's heal. Okay. So you have a high PI and a kyphotic lumbosacral junction, which is really a bad combination. So it's a bad combination having a very high PI with a lumbosacral kyphosis. So I think this is ideal, as the title said, for an S1 PSO. So, and then I guess if you want, I wrote a paper, a case report, which really well illustrated if anybody wants to see it. I think it's in the European Spine Journal, kind of with nice pictures on how to do it.
Yeah, I've read that. I would also support checking that out. It's very well done. Mo, can you go back to the first post-op x-ray? I think this is a good learning case. So this is a patient who has 3-to-1 posterior instrumentation, and she has, so that's on the verge of, does she need pelvic fixation or does she not? You know, Sig's talked about above L3, putting extra stress on the S1 screws, but then he talked about other patients who would benefit from pelvic fixation. Those are those with high pelvic incidence, a priori. It looks like she has probably a unreduced L5-S1 isthmic spondy there. In the setting of a high PI, she probably we don't know, but maybe she's overweight and she's not osteoporotic, but her bone quality is not ideal. So all those things into consideration, stopping at S1 risks a distal junctional issue. So either a non-union or a fracture like this. In the sacrum, the worst bone quality is in the sacral ala, and that's where the screws start, and they aim medial, but usually it's a fracture bilaterally, and then you can have a concomitant transverse component, which leads to a U-type sacral fracture. It's ideal to get to these sooner than later, but once it gets to this point where it is a united kyphotic deformity, then doing a S1 PSO is needed. The easier thing to do would be to do it higher up, like L4. You see she has a spondy at 4-5 that's not reduced, so that's also contributing to her flat back. But I think the tenets of deformity surgery are address the deformity at its apex. If you do something higher up, you're not addressing what's distal, and this is the lady that you may correct her sagittal plane, quote unquote, adequately, but you're going to have a lot of cantilever forces still on the pelvic screws that you put in. And this is the one that may have the tulip heads pop off, the set screws pop off. So you have to address the deformity at its apex.
Having said that, though, I think it's really important that you know that you can achieve distal fixation before you're going to do an S1 PSO. Because if you can't get good distal fixation, then I would highly recommend not doing the S1 PSO because you're kind of screwed. And then if you're not comfortable doing an S1 PSO, I don't think you'll go to jail doing an L5 or an L4. So I think we like to fix it at deformity, but you have to work with, if you do a beautiful S1 PSO and they have a drop foot after, they're not going to be as happy as if you felt more comfortable doing an L4. So I would say I would pick, ideally, I do try to go for where the deformity is, but I think you have to work as safe as possible for the best outcome for your patient. So.
I was wondering, given that she's having some cauda-like symptoms, would fixing the deformity above where it is most acutely deformed would the decompression obviously help resolve that or prevent it from progressing?
You can decompress everything as well. So, like you'll study your imaging and decompress what needs to be decompressed.
Okay.
Yeah, I think the decompression is super important. It reminds me of a high-grade spondy. The high-grade spondy with lumbosacral kyphosis is a typical appearance. So you have to decompress, and then you have to fix the lumbosacral kyphosis. So the good news is, the bad news is they didn't use iliac fixation. The good news, they didn't use iliac fixation. So you got lots and lots of good tracks to put at least 4 S2AI or iliac, whatever you want. And then this one, you can't just have 2 screws. Mm-hmm. You have to have 4, and then do the PSO. And I use the table, so I'm not cranking on the screws. That helps a lot, because if you crank on the screws, sometimes they splay inside the bone. So I use the ProAxis table, which helps. It's an expensive table, but I've done them before where you just have to push down. So either way. But I think having good distal fixation, good decompression, wide decompression, really lay out the nerves before you start taking bone and destabilizing it. Then the nerves disappear, and then you're in trouble.
Mm-hmm. The key also to take out the whole sacral ala too, and follow the 5 root. Do a 4-5 decompression. Follow your 5 root from the top down, and then follow your S1 the same way. And you have to actually, the distal part of the foramen is the sacral ala. So just like when you do a PSO, at a different level, you take the pedicle out, so you make one foramen. The sacral ala is your distal pedicle, really, that you have to get out along with the pedicle of S1.
Yesterday, I was moderating a AAOS webinar on sacral fractures, and it was a combination of spine surgeons and trauma surgeons. And the trauma surgeons are now more in tune with the sagittal plane deformity. So when they have kyphotic sacral fractures that are acute, they are doing their best to reduce them and get them realigned to prevent a situation like this. So it is but if they don't fix it, you could end up with a similar situation.
Yeah, interesting talking points. Actually, this is exactly what was done in this case. Every single point has been touched on. So I'll kind of summarize what happened. So they basically revised the segmental fixation from L3, 4, 5. They placed bilateral pelvic fixations using galvestone technique for the iliac screws. That was been popularized in 1980s, as well as bilateral sacroiliac fixation for supplemental pelvic fixation based on the Sponseller Kubesh technique in 2007. And then they went on with fixation above and below the S1 fracture, and then performed a wide decompression, exactly as we've heard, for the neural elements, and then specifically revision of the laminectomy of L5, S1, extended the laminectomy of 2S1, and then performed the posterior base osteotomy of S1 through the prior fracture. And the osteotomy incorporated the sacral ala into the SI joint to disarticulate the sacrum from the ilium. And then following that, significant correction was obtained to the S1 fracture, but it wasn't adequate, incomplete. So when they went on to with the pedicle subtraction osteotomy, as we discussed, specifically they performed the posterior base osteotomy, Smith-Pearson osteotomy, to the incomplete fusion, and then performed the posterior base extension of the S1 pedicles bilaterally with a 3-column wedge resection of S1. And then for the correction, they used cantilever technique with a 6mm cobalt chrome rod, rotated the pelvis to reduce the pelvic tilt, and then extension of the legs to assist with the correction. And then they went on to fixing the rod into these segments. And then they used local bone for fusion. They did encounter a dual tail, but that was repaired. And this is how it looks like.
I think it looks like you fixed the coronal plane as well. You see that? So, spondylolisthesis, if you look at them really carefully, they're never like straightforward. They always have a little rotation, right or left. So this was what happened here.
It looks great.
Yeah.
Congrats.
All right, thanks, Mo.
Thank you.
Anu, I can present it. It's okay. Okay, we'll do the next one. And this is a gentleman who is a professor at Berkeley, 71-year-old male, presents with back and leg pain, chronic back pain over 4 years, and disabled by his back pain and leg pain, has failed non-operative management. The major focus is his abdominal surgical history, is a history of Crohn's disease. And I'll show you his pretty extensive surgical history. So he has a form of it that causes a lot of strictures, and he's undergone more than 5 operations for recurrent small bowel obstructions, strictures, et cetera. And as you can see here, multiple revisions of his jejunal anastomosis, the most recent one being back in 2019. So if you look at his abdomen, you can see all the history of that. So anyways, he presented initially to me with a de novo deformity. I recommended an operation, asymmetric PSO, reconstruction of the coronal and sagittal plane. He didn't like that, so he went to Stanford, and they recommended an MIS decompression and this MIS TLIF. And then within a year, his coronal plane decompensated even further, and his sagittal plane got worse. So he came back to me, and I told him I'd be happy to help. So looking at his imaging, he's got a pretty significant coronal plane deformity to the right. Sagittally, he's not as significantly off. If you look at the supine, he does have that autofusion of the L4-5 disc space from the osteophyte on the right. And then looking at the MRI of his lumbar spine, you can see the decompression's done from the right side. The L2-3 segment looks persistently stenotic, and but the rest of it looks open. If you look at the CT scan at L5-S1, the TLIF cage placed from the right, when you see black, or that's usually a sign that there's motion within the disc. And if you look at the posterior lateral space, the transverse processes of L5 to the sacral ala have no bone. So all the fusion was attempted to be done through the interbody space, but did not achieve it. There's no gross loosening of the L5 screws, but you can see some subtle haloing around the S1 pedicle screws. Sometimes when you have non-unions at the lumbosacral junction, that can also drive your, a change in your deformity, either sagittally or coronally. So here, the questions were, and I was going to pitch it to Chuck, any role or option for ALIF. He's not here, but based on the surgical history, I think this would fall into the contraindicated category. I would, even if he told me he'd probably try it, I'm not sure I would want to mess with that because his abdomen was a complete bomb. And then I wanted to ask you two and others in the audience, what are the posterior only operations for this patient for achieving fusion across the lumbosacral junction in the revision setting?
I think I don't do a lot of minimally invasive fusions, but I do revise quite a few. And I think there's not a lot of good dissection of the posterior elements. So you could see that they made a little hole and then they put the cage and bone in. So I think a thorough cleaning, removing the instrumentation, and doing facetectomies, I think you should be able to get this fused. But I don't think that'll be the problem. The problem is the correction. So the 4-5 is asymmetrically collapsed, and he's got it's not as much the sagittal plane, but he has coronal and sagittal plane, right? So I think you can do this all from the back. I wouldn't go in the front. I would do from the back, and then you can do sort of an asymmetric PSO, not at 5, but at 4, and then get that corrected, depending on how far up you have to go. You don't have to go very high, just in the lumbar spine or the thoracolumbar junction down to the pelvis with iliac or S2AI screws.
Yeah, I agree. I don't think it'd be that complex to fix it up. You can work on the other disc side, on the whatever that is, the left, to do an interbody from that. Looks like the S1 screws may be a bit loose, so we would change and upsize those and improve the distal fixation. And then, in terms of the realignment, as you can go up higher and realign them. I have to look at the imaging again, whether I need a PSO at L4 or something to kind of an offset PSO to properly align him better. So.
Yeah, it was nice that they didn't do anything on the contralateral side with the TP and the sacral ala. In the setting of an open operation that's been attempted in the past, that would make it a more challenging situation, and maybe going on the contralateral disc, like you said, and putting a cage contralaterally, or considering taking out the old cage, I think would be under consideration. But here, because of that virgin side, we thought leaving the disc space alone would suffice.
So, I think that you should not take the urge of trying to take that cage out. Resist that urge.
Leave it, yeah.
Because when you go in the canal, there's nerves there. And, Art Steffi wrote a paper a long, long time ago where he had a lot of neurogenic problems, and it was always revision pliffs. So that scarring is real in the nerve root. You can really damage and traumatize the nerve root. So I would resist the urge of, unless it's really impinging on the nerve physically, I would resist the urge and try to just get the fusion, and you can get to the disc space from the other side, like Steve said, and then do your correction at L4.
Yeah, great. I think if there wasn't this significant abdominal history, we probably would consider all going to the front and taking out the cage and doing an anterior fusion for this. So what we did was revision, decompression, PCOs. We at the L4-5 segment, I called it a TLIF, but what we did is we took an osteotome, broke that lateral osteophyte, did a discectomy, and then I just packed some cancellous graft in there. So I tried to release it bilaterally just to open it up. He had some other pretty significant comorbidities with his heart, so I thought PSO plus minus. And we did multiple rods across the lumbosacral junction, multiple pelvic screw fixation, and then on the right side we put a kickstand rod. Another intraoperative photo. Now you know where I got it from. So with him, I think this was the outcome, and the question is, do we restore the coronal plane adequately enough? And I think yes. His C7 plumb line is adequate. I was a little bit concerned about pushing him too far the other way, because you already see his right shoulder starting to come up, and maybe that's because he's not adequately corrected. But he's very happy with his improved posture. So.
Are you happy with like a hook on 11? A pretty small TP.
Yeah, I've only done that once, and this was it. And no, I was not happy. Yeah, I was toying around with different options and trying to figure out what I liked the most.
Well, I was telling somebody, good judgment comes from experience, and experience comes from bad judgment. So TPs of the thoracolumbar junction are no good.
Yeah. So
stick with the screws.
Yeah.
Upper thoracic TPs are much better, much stronger. You can actually lift the body off. But if you're within 2 centimeters, I mean, look at the coronal plane, it looks quite good. So I think you did a great job. Yeah.
Yeah, he's happy. Okay, great. So uneventful course. He went home relatively soon, and he's very happy. Oh, and then we got a CT post-op at 1 year just to see how things were looking. He was more curious about it than anything. And you can see posterior lateral fusion and interfacet fusion. That was the contralateral side. We were able to denude that cartilage. So thinking along the same lines. Okay, last case. And I think this is going to be presented by Rahul. Come on up.
Thank you. I have the unenviable task of being the last one. This patient was a 64-year-old female that had undergone multiple prior surgeries, as these things tend to go. Presented after feeling a pop in her back. This patient's history is notable for osteoporosis. Actually had completed a full treatment with Forteo, as well as a couple other things that you see here. They have a kind of interesting cocktail pain pump that's also been implanted at some point by another physician. The surgical history is pretty extensive. As you see, it all started with the TLIF once upon a time. And then it sort of grew from an L4-5 TLIF that got removed and then turned into 2 laterals that were plated. And then at some other point, a 5-1 ALIF was done, and it became a T3 to pelvis fusion with the PSO. And then in 2018, the patient underwent a redo L5-S1 ALIF and revision of all screws between L4 and pelvis for what I understood to be pseudoarthrosis with multiple rod fractures and loose screws. This patient had presented with this exam when they were evaluated in our clinic, which I think was essentially stable from one of the 2 previous large surgeries that they had undergone. So they have some stable right-sided weakness with particular notable weakness of the TA and EHL on the right side. And that really hadn't changed for better or for worse in quite some time. You can see here a couple of notable things in the scoliosis film that we have, including the patient's still kind of relatively pitched forward sagittal alignment, sort of listing a little bit off to the right as well. There's an implanted pump. There's a few more notable things, which I think perhaps you can see more clearly up on the screen than back here, but this is what you can see how it looks in supine position compared to the upright position. You can also see here the theologist sign. So my slides were edited to include a bunch of red arrows that point out a couple of interesting phenomenon. But in summary, this patient has pseudoarthrosis. It looks like, I think this is the remnant of the 5-1 disc space, perhaps, that's like open. Here in the front, ventrally, at least one of these iliac screws is completely fractured, and there's a rod fracture as well. And you can see that most well demonstrated in the top right image there. So a question for the panel, in the context of revising what is a pretty complicated situation here, is a revision ALIF an option? And if so, from right or left side approach, given the patient's had 2 prior? And if and when you attempt posterior reconstruction, what are your options for a number of rods and pelvic fixation?
Just a question, do you guys use cannulated iliac screws? Is that a thing for you guys, or? Because I see that these are cannulated ones. If they look,
The original operations were done many years ago. And I don't know if all their pelvic screws are cannulated or not.
Okay, I don't use any cannulated for that. I just think they're weaker, but so the clear distal fixation failure with a SUDA 5.1. The CT is not very clear. I think the options, you have some sagittal malalignment. I'd love to see a little bit better at the bottom there, what to do. But that's obviously a contributing force. The simplest thing would be to reestablish some distal fixation into the pelvis, redo the iliac screws, and set up perhaps a few more rods. And then I still think you have to address the 5.1 fusion, which I probably, with our previous anterior, would probably want to lean towards just doing the back again. And then that would, this one I would throw in some BMP. And then I do get to use it for revisions. And then obviously if you have a non-union in the setting of a long construct, alignment is the issue. And a kyphotic lumbosacral junction is not a great recipe for fusion. And so that would be something I want to see if I can address it. I have to study the imaging a little better to see how I can do that better. So.
I think Steve said it eloquently, but it looks like there's disengagement of the screws and broken screws, and basically there's no distal fixation. That's why it's such a difference between standing and supine X-ray. In the supine X-ray, it looks quite well aligned. So I think reestablishing distal fixation, and then comes to see, look, it looks quite good there. I mean, you can see the view of the pelvis is in the correct plane, in the sagittal plane and the coronal plane. It's all lined up. So it's all the distal fixation issue. So I think you have to revise that completely. So one thing I want to confirm is there was a formal anterior approach at 5.1 before? Two of them, okay. I wouldn't go there because I've been there before. And I remember, I think one time I went to a 6th time anterior revision, and we put stents in, and then all of a sudden, like, what color is the stent? And of course, I was into the stent. So I think I would try to avoid a revision anterior. I would do it from the back, and then you'll have to do sort of a TLIF approach like Steve was saying, but adding good distal fixation, lining it up, and doing a TLIF from the back.
Yeah.
If it's a line, I'd have to study whether a trans 5 screw is another option for fixation as a kind of a salvage in these kind of.
So this is a integrated ALIF cage. So it's an ALIF cage that has a screw going down to S1. So how would you do the TLIF there? You take out the cage?
I would find out where the screws are and work around it.
Okay.
If how many screws are in from the front? Are there?
I think it's 1.
Usually there's like one, yeah. So I would work around it. Okay. And worst comes to worse, you put like they have these cortical made TLIF cages.
Mm-hmm.
So it's all bone.
Mm-hmm.
So you can put a couple of them around the screws.
Okay.
Yeah, but don't put BMP in there because the BMP tracks up into the canal. Yeah, but distal fixation is absolutely key.
So this patient was ultimately revised from L3 to the pelvis to address the distal fixation failure, as you pointed out, with an 8-rod construct. Which I think, as I understood, you didn't end up opening the whole incision to do a lot of this, or we were able to accomplish a lot of it through essentially the bottom half of the incision.
Yeah, so our thought process here was we were given the hard stop of another anterior by the vascular surgeons. He didn't want to go back in. We were thinking that, similar to what Dr. Gupta just said, that a lot of the sagittal plane deformity was just lack of pelvic fixation when he lay down, that his sagittal alignment got a lot better. So we thought just fuse him or re-instrument and essentially fuse him in situ. The question of how to get union across the 5-1 junction was, we weren't exactly sure. I like the idea of the screw. That probably what we would have done after the fact. So we decided to just load her up with a lot of rods and see how that went. The way that we connected additional rods is a construct that I use for when I do sacrectomies, is with the distal iliac screws, we put a cross link, a cross bar, a rod across it, and then we use that as an anchor point to have rods travel proximally. And so what we do is put a lateral connector that you use to the pelvic screws normally, connect that to a domino in line, and then run rods cranially. So that was a way that we could get rods, accessory rods to the lateral iliac screws. We could then go directly and then use that rod that goes transverse as other ways to go cranial. We did this about a year ago, and so far so good, but the question is, when will this fail? And it may not, I don't know.
Is that a transverse connector with the end-to-end connector on?
Can I see that?
On the bottom, there's an end-to-end connector.
This way?
No, right, on the left. Yeah. That's an end-to-end connector?
Yeah, I think that's connected to, I don't know what that is.
Many years ago, we patented this technique where we put 2 iliac screws and put a rod across, and it has these connectors that go forward. And it was an idea to correct neuromuscular-pelvic obliquity. So once you have that rod, you can grab the rod and turn the pelvis how you want it. So DePuy never made it, and then Globus copied it. So they produced it, but now DePuy's making it again. So if you're ever in this situation, call up DePuy, they have it.
Any comments from the audience? All right, well, that brings us to the end. Thank you everybody for staying. Hope you enjoyed the course, and thank you very much. Thanks, Steve.
All right.